Like she got an ERCP now, and then she developed.
Oh, yeah, yeah. After ERCP, pancreatitis is number one complication. Because if you inflame the sphincter of Odin, the inflammation starts going in. Well, the first branch will be pancreatic gut. So the inflammation will enter the pancreas. And then it can make its way up.
That's what she's watching. We went for a time. Like. Anyway. Okay, I need you guys to people that I think are. I know. Yeah, I can wait. I don't know. I don't know. I can wait. Yeah. Wait, for sure. Like. I'm gonna take my point. Shoes. Like I'm like I'm looking for. I'm like fun. Yeah. Yeah. That's for hours. I say no question. Yeah. I think it all. She says she thinks I do it every day. Oh, you need that. Okay. Okay. So I think I just like. I'm probably. I didn't really. I think like. Okay. I know we are. Yeah. You have my party. I actually. I have oh. Okay. I put them up. I'll walk around. The only place I won't walk with them up is the bathroom. That I just. Yeah. That's nasty stuff. Yeah. But everywhere else, yes. That's. This is. Yeah. Yeah.
But I know that everything is said. So. Someone. Like this, like.
Yeah.
They're all. Right. They may be on the light.
You know what?
Oh.
Yeah. Yeah.
I thought like there's 3 miles here, 2 miles. How long have you driven?
Oh.
Three runs. So how many miles? No, we're still on this. Well. Yeah. But. But 20 miles. So it's. So it's. Yeah, I don't know if that's. That one.
I think. Oh.
That's.
Yeah. I think look the same.
Whatever was. Yeah. That's right. Yeah.
You want to have a white ball?
They might
have white. You saw all of them? All right, let's take it from where we left off yesterday. And where we left off. All right, we're going over the microcytic anemias. The most common anemia in America is iron deficiency. They give you a differential and how to separate it from chronic disease. Very, very important. Know your differential throughout the years. And then how to separate from anemia chronic disease. Remember I said use ferritin and TIBC. Serum iron and saturation are the same for both of them. And you're gonna get confused if you start looking at those. Lead poisoning is therefore next. Lead blocks two enzymes in heme synthesis. First one is delta alpha dehydratase, and then ferroketolase, which is the last one, who actually binds the iron to the four heme molecules. So lead blocks two enzymes. You got to know those two enzymes because that's what they like to ask. Most common cause of lead poisoning in America is eating peeling paint from old buildings, still number one. All right, so classic clues that we use, basophilic stippling. What is that? These are really the porphyrin rings stuck to the walls of the red blood cell. And that's why it looks like little blue dots. And that's why they call it basophilic stippling. Or you can measure free erythrocyte protoporphyrins. These are the two best clues for lead poisoning. You ain't get any better. Meaning, as once I see one, I click. All right, lead poisoning. Years ago, I wanted to know what was so attractive about lead to children. Why are children eating lead all the time? Because my partner and I served the poorest part of the town. So of course, the poor children are the ones who get this. So I went to an old building and I ripped some peeling paint off the wall. And I said, I'm gonna chew some of this so I can see what's going on. Well, I didn't have to chew any of it because as soon as I brought it near my mouth, I smelled it. It smells like cherry bubble gum. Think about it, when you're poor and no food to eat in the house, and all of a sudden cherry bubble gum's on the wall. That's what they're after. They're eating it like candy because they think it's candy. And when do children get lead poisoning? When they're walking around on their own and mama's not watching them, all right? Why do you think we start screening at age 1 year when children are finally walking around on their own? You see how everything just lined up for me? I said, oh my God, everything. I never have to look that stuff up anymore. Because now I knew why we screen at what time and why we tell moms, watch that child carefully between age 1 and 2, because they're gonna get into everything. Everything just lined up. So anyway, that was my own personal curiosity. I'm glad I didn't have to chew any of it. All right, first screen of lead. This is all updated numbers now, so pay attention. First screen at 1 year of age. Why? Because they're walking around by themselves and a lot of moms don't watch. That's why the most common cause of death between 1 and 2, accidental drownings and ingestions. That's a child who's unsupervised. All right, heel stick versus venous levels. Heel stick, that means we poke a needle in the toe or the heel and take a little bit of blood and test for lead. It has like 99% negative predictive value. Meaning what? If it's negative, great, we'll see you next year. But if it's positive, I can't use it. It's only like 30%. It was worthless. All right, so if it's positive, then you follow it with a venous level. What? So watch out for that too. They got me the first time I saw that question. They give me a real high level, 75. I said, oh my God, we got to treat this kid. I didn't look carefully. That was a heel stick. The next answer is you do a venous level to see if that's real or not. Okay? All right, so be careful of that. Numbers you want to know, 0 to 5. That's background. So he's exposed a little bit to lead. What do? Follow levels every 6 months. But get a good history. Try to figure out where this child is being exposed to lead. 0 to 5, background. 5 to 14, get even more history. Follow every 3 months. Notice we follow closer and closer. 5 to 14, be careful. I can hear you guys talking too much. Be careful, keep your voice down. 5 to 14, you get even more history, follow every 3 months. 15 to 44, you say, wait a minute, it's still climbing. And I've already gotten history twice, and I still can't figure out where this is coming from. That's when you ask your health department to help you out. The health department has the power to go into the household now, because by history, I can't figure it out. So they need to go in there and test the walls, test the toys, test the dirt around the house, test the roof, test some pipes. They have that power. And that's why 15 to 44, you call the health department. Now, most of the time, they'll be calling you because they know doctors forget to call. So anytime a lab is elevated, it automatically goes to the health department. So even before it comes to you, it's already gone to the health department. But that means you got to know, you better be doing your job because the health department's going to follow it up on you. And if you're not, then they file a complaint against you, you get in trouble. All right. So anyway, get the health department involved and follow the lead levels every month, because now this thing is still going up. I still haven't figured out what's going on. 45 to 69, when you're treated orally. We only have one oral drug. That means only one drug can be used outpatient, and it's called Suxamar. And then you continue to follow lead levels every month to see if it's working. And then if 70 or above, automatically hospitalize them. We no longer do that, what was that chelating test that we used to do? Just so you know, this is all updated. They say skip the chelating test. 70 or above, automatically hospitalize them. If they have neurological problems, 2 IV drugs. If they don't, 1 IV drug. And that's how you make your decision. The drugs we use IV, EDTA, dimercaprol, and penicillamine. Now, EDTA binds everything that is 2+. And that's how I remember all the side effects. Michael, give me anything else that's 2+ besides lead.
Iron.
Iron deficiency. Keep going.
Calcium.
Calcium, hypocalcemia.
Magnesium.
Hypomagnesemia. Oxy will help you out. Zinc deficiency. Another one, Mitchell.
It's positive.
No, positive, that's 3 plus. Or is that 3 negative, sorry. Melissa. 2 plus ions. No, all right. Justin? Copper. And you guys heard that just a couple of days ago. All right, anyway. I'm just pointing you to the 5 2 plus ions. That's the side effects of the drug. That way I don't have to tell you. There it is. You can figure it out for yourself when we do electrolytes. All right, so anyway, EDTA binds everything, especially calcium. So hypocalcemia is the number 1 side effect. The other 4 are also side effects, but not as common. So that's why you see EDTA is given as calcium EDTA. We already know you can become deficient, so might as well give it with it. Okay, and that's the routine. EDTA is also used to preserve blood on the shelf. Why? It binds up calcium. You've already learned. Calcium floating around will kill cells. Remember dystrophic calcification? So we put something in the blood, binds up any calcium that's floating around so it can't get into red blood cells. Okay? Damocaprol binds everything that's 2 plus as well, but we use it for lead poisoning and arsenic poisoning. Penicillamine binds everything that's 2 plus as well, but we use it for lead poisoning and copper, Wilson's disease. Any questions on lead poisoning? That's your update. Laurent. With Suximer, yes? That's the first line treatment because it's oral. Yeah, so you try to catch them early enough where you can start at 45 to 69. That you're trying to avoid hospitalization because once they get hospitalized, they got to stay in the hospital till I bring their lead level back down to normal. And that may be a long time. Drug-induced lupus is a side effect of penicillamine. If you look at the name penicillamine, there's penicillin in it. So if you've had anaphylaxis with penicillin, I can't use that one. So watch out. Remember, they give you the past medical history of the patient somewhere in the middle of the vignette. And if you forget to take that into consideration, by the time you come all the way down here, you forgot. Okay? If you had anaphylaxis with penicillin, I cannot use penicillamine. All right, any other rashes and stuff? Yeah, you can still use it. But anyway, drug-induced lupus. The mnemonic we use here is HIPPE, H-I-P-P-P-E. The 6 drugs that most commonly cause it. Not the only drugs that cause it, just the 6 that most commonly cause it. That means for test-taking purposes, these are the 6 they're asking you about if they ask you. Drug-induced lupus is different from regular lupus. First, drug-induced lupus is anti-histone antibody. Regular lupus, so I'll just put over here, has different antibodies, double-stranded DNA, Smith, and cardiolipin. So the marker by itself can separate them out, but it's very important that you know the difference because they're not the same disease. How are they different? Number 1 is their markers are different. Number 2 is drug-induced lupus is reversible. You've never heard about lupus being reversible. Once you get it, you're going to eventually die from it. And number 3, drug-induced lupus usually does not attack the kidney. Whereas regular lupus, that's your cause of death, is renal failure. So they're asking that question quite a bit now. So make sure you know the 3 differences between drug-induced lupus and regular lupus. Now, what about these antibodies? The lupus antibodies, here's what you want to know. Double-stranded DNA is the most specific. So when they ask you what's the first one you want to get, that's what they mean. That's the most diagnostic one right there. Double-stranded DNA. If that one's positive, you don't have to get the other ones if you don't want, but we always check all 3. But that's the first one we get. Double-stranded DNA antibody is also the most nephrotoxic antibody, which is why they die from renal failure. Double-stranded DNA, the most nephrotoxic. Think about it. Your body has never seen double-stranded DNA floating around in the urine. You can imagine how that scares the heck out of your body to see something strange like that. And that's why it sets off such severe inflammation that destroys that kidney. You understand, Melissa? Now you understand, Mitchell? All right. Double-stranded DNA causes such severe nephritis, you got to know steroids don't even work. That we used to use that years ago. A lot of books still have steroids. That ain't the answer anymore. Then we switched to cyclophosphamide. But remember, this one causes hemorrhagic cystitis and then bladder cancer. So that's why then mycophenolate beat it out in the study. Mycophenolate. Mycophenolate blocks inosine, which is one of the purines. So they're both anti-metabolite. No, cyclophosphamide is alkylating agent. All right, so this one's better. So now when a drug is proven itself superior, you can't use any of the old drugs. So now the treatment for lupus nephritis, mycophenolate, is now the answer. Anytime some drug decreases mortality or saves lives, folks, it's on your exam, I can guarantee you. Because I've seen this question several times. All right, why? Because as a doctor, you're expected that when a drug has been proven superior to whatever else we were using, if you don't use it, that's called malpractice. Because you're using an inferior drug. So be careful. So that's why they always tell doctors, you gotta pick a journal that keeps you updated, because you gotta keep up to date what's going on out there. Because when something changes, you better catch it. And like I do a lot of questions. I get my stuff all on CD, so I'm always listening to what's going on. And then when I hear something's changed, I say, okay, why are we switching? All right. And then of course you look up the literature and you find, oh, okay, I didn't know it was better. You learned something. Okay. All right. So lupus. Next thing, cardiolipin antibody. Cardiolipin antibody has 4 bad associations that go with it. 4 bad associations. Learn it.
False.
What's their favorite question? Why do you get this false syphilis test with lupus? Now you know. It's a cardiolipin antibody. All right, now give me one. Multiple spontaneous abortion. It just clots up the entire placenta. I had one patient, she had 9 straight abortions before she had 1 child on the 10th try. And the way I picked it up was, she wasn't even my patient, her daughter was. I was thinking of her daughter, and I just noticed mom was, they call her helicopter moms, you guys ever heard that term? Hovering up over her daughter. The daughter's a teenager. And when they become teenagers, you got to let go as a parent and help them find their way through the world. Don't hover. It actually hurts the child when you hover. So anyway, so she was hovering so much. I said, Mom, why are you so protective of this child? And she said, Doc, you just don't know what I went through. I said, what do you mean? She said, I had to go through 10 pregnancies before I gave birth to this one. 10 pregnancies? She said, yeah, I had 9 straight abortions. Really? Elective or spontaneous? She said, spontaneous. Immediately I looked at her face, I saw a faint red malar rash. She's not my patient. I just haven't seen it. I said, wait a minute, do you ever get a lot of joint pains? And all of a sudden, lupus just started popping out. I said, you need to talk to your doctor. You got lupus, okay? That's why you've aborted 9 children. I said, but at least now I understand why you're so protective of this one, because it took 10 pregnancies to give 1 child. But that's what happens in lupus patients. So cardiolipin, so multiple spontaneous abortions, give it a 3rd one. Blocks VWF, so you get bleeding problems. Give it the last one. Stimulates the intrinsic clotting system. So you can get clots or you get bleeds, you never know. And that's what gives us such a bad prognosis. Because one day they come in bleeding, what do? We gotta get fresh frozen plasma, stop the bleeding. 3 days later, oh my God, they're throwing clots. Okay, gotta put them on warfarin or heparin. And we're just chasing that tail all the time. What? All right, in order, it stimulates the intrinsic clotting system. Block VDRL, false VDRL. There's 4 associations. They love to test it, folks, especially the false VDRL. All right, but drug-induced lupus, very, very important. I remember I had a student who got a residency based on this right here. What happened was, they were about to kick him out of school. All right. And his father called me and I told him that I would take him into the program. Okay. Oh, you know what? Give me a second. I forgot. And I can tell him closer to dropping this. We diabetics have clinical science. We'll be my bar.
It's like the new. Oh, I don't know, but I think you know, like. Yeah, I know. This is in the. It's inhibiting. My brain, sorry, I'm like, all of these. This is my lip already, like, what I need to work on. Yeah. Yeah, exactly. Yeah. I was trying to get you. So it's like, oh no. Like, the guy. I was like, no, because then. Like. Anyway. Yeah. No, I mean. That's good. Oh my God. Yeah, just one thing about that is like. Yeah.
All right, let's go. All right, fortunately, I can always feel it falling, so I always got a warning sign. I got bars everywhere. Just bring my blood sugar back up, so no beta blocker. Nah. I mean, the one time I almost came close to passing out, Shireen, who sits here, she was the one who noticed it. And she said, "What's wrong, Dr. Franks?" I said, "I don't know, girl. I'm just feeling so weak." And she said, "Could it be your blood sugar?" I said, "No, I thought I ate breakfast." Then I realized, oh, damn, I forgot to eat breakfast. Oh my God. So I was lucky I even made it to work because I got an hour drive. Totally forgot. I didn't eat any breakfast. She said, okay, she went and got me, somebody got me some candy, somebody got me some juice. So I started sucking on the candy. I started to feel the difference. Oh my God, it's hypoglycemia. I thought, man, I thought something really bad was going on. But at any time I get to that level, it wipes me out. I had to pass on the lecture to my partner. I said, no, you got electric. Now my body is so weak, I can barely move. So I just went home and laid down. So that's why I try to catch it early before it ever gets to that level where it wipes me out. So that's why I got bars in my office everywhere in my car. All right, anyway, here we go. Drug-induced lupus and regular lupus. Now that you know the difference. Lead used to be the most common cause. Now, I apologize for this because I've tried to catch everywhere in my slides where I have mental retardation. Now we got to change all that to intellectual disability. So I apologize in case it offends anybody. It offends me too. I got a nephew who has that, so I know I got to change all these words. But every now and then I catch a slide, I have not changed it. So, huh? Oh, it's all over the literature that say don't use mental retardation anymore. Yeah, because they say use intellectual disability. Yeah, so anyway, I just didn't want anybody to get offended. Moving on. So yeah, see, I gotta change. I gotta remind myself this whole lecture. Come back and change all these slides where I talked about it before. So anyway, so intellectual disability now, #1 cause of fetal alcohol syndrome. Because of course a lot of people drink alcohol. The best clue for fetal alcohol syndrome. Oh, wait, I think I have a picture. Yeah, is a smooth philtrum. This dimple in the middle of your upper lip, it'd be non-existent in fetal alcohol syndrome. That was the #1 feature I found that was different from every other syndrome. Just so you know, I put the picture here so you see a lot of things, but there's so many other syndromes have almost every one of these things. So that's why I don't use it. But once they say smooth philtrum, I get my point. That philtrum is very useful. When it's smooth, fetal alcohol. When it's a short philtrum, DiGeorge syndrome. When it's a long philtrum, like when it's hanging way down here, that's called Williams syndrome. So 3 syndromes I've gotten points for with that philtrum. Can you repeat that? Yeah, smooth philtrum, fetal alcohol syndrome. Short philtrum, DiGeorge. Long philtrum, Williams syndrome. Yeah, that happy puppet, the one at the party, what's that? The cocktail personality. Anyway, we'll talk about that. So anyway, that's fetal alcohol syndrome. Otherwise, the other features are not unique. Fragile X syndrome is the most common cause of chromosomal induced intellectual disability. Before puberty, they have a pill-shaped head with big ears. Pill-shaped head with big ears is how they will describe it. This is before puberty. Then they get the large testicles at puberty. That's their most defining feature. And that's the one most students talk about. All they do was just switch to, okay, before puberty, all of a sudden students start missing the question again. All right, so that's why I teach both profiles now. Before puberty, hill shaped head, big ears. The big testicles don't start till puberty when every boy's testicles enlarge. And then, of course, Down syndrome we'll talk about later because there's a bunch of things to talk about there. Hang on, Gabriel, was you first?
Yeah, I had a quick question actually about the smooth and short philtrum detailing
Okay.
about the three conditions that you mentioned. I was wondering if you could just repeat that one more time, if that's okay.
Oh, yeah, smooth philtrum, fetal alcohol syndrome. Short philtrum goes with the George syndrome. And then long philtrum goes with Williams syndrome. Yeah, just,
Thanks so much.
yeah, 3 easy points. All right, and whose hand was up over here? Was that you? Babe? No, okay, oh, sorry, Steve.
The long face and large ears, it's maintained throughout puberty.
Oh, yeah, it's maintained. The long face and big ears is a permanent. But the large testicles don't start till puberty, that's the key. All right, now, porphyrias. What is a porphyria? Porphyria is enzyme deficiencies that lead to protein deposition. When the problem is caused by the actual protein, how's that going to be inherited? How's it? Porphyria, there's enzyme deficiencies. However, what's causing you the problem is protein deposition in the wrong place. When the protein is the actual problem, how's that going to be inherited? Autosomal dominant, almost every one of them autosomal dominant. Just connected to a pattern that you already know, so you don't have to be looking up each one of them one at a time. Okay? All right. So in porphyrias, either you're synthesizing too many porphyrin rings or you're not metabolizing them fast enough. That's why they didn't deposit it. You understand, Nolan? All right, stand Kathleen. All right, you got porphyrin rings deposited somewhere in your body that don't need to be. And that's going to set off terrible inflammation, which is what kills you eventually. All right. Porphyrin rings are red, so they make your urine red. So the person will say, oh, my urine is red. But when you do a dipstick, there's no RBCs in there. Doesn't that remind you of another disease, Saber? Doesn't that remind you of another disease? Where your urine is red, but there's no red blood cells on the dipstick. How many Sabers are in this room? You guys got to quit blurting out answers. Yeah, I told you, raise your hand, then I'll put you on the spot with a different question. Yeah, it's so much easier when someone else is on the spot. Let them fight the cortisol. I told you, I give each person 20 seconds because I know that's guessing starts after that. But I got to give them 20 seconds because it takes time to learn how to fight your own cortisol and bring it down. And now you see the answer. All right, but Raptor, we just talked about yesterday. So again, just reminding you, clues, boom. Now you got 2 things that have that same profile. There's a bunch of porphyrias, folks, but there's 2 that are common and that are always on the exam. In fact, I had a patient with this one. Acute intermittent porphyria, AIP, is the most common type. What do you have? A buildup of porphyrin rings, and the porphyrin rings deposit into your visceral organs and around your nerves. So you can have visceral organ attacks. So the person gets a lot of abdominal pains, non-specific, but it can look like pancreatitis, look like cholecystitis, look like appendicitis. You just never know what it's going to look like. And they have neuropathy. So again, deposition around visceral organs and around nerves. How do you manage abdominal pains? I thought since I just talked about it, let me discuss it right now. Why? Because it covers every patient that presents with abdominal pain. This is what you do until you figure out what's going on. Okay? Number 1, we say NPO, none per orum, meaning nothing by mouth. Why? In case I got to take you to surgery. Because that kid, he's a chunk of Snickers bar, and then all of a sudden we find out he's got appendicitis, we got to take him to surgery. And the surgeon comes in and says, has he eaten anything? Yeah, he just ate a Snickers bar 10 minutes ago. Oh, he's going to hang you. All right, why? because he's got to take the child to surgery no matter what. But that means there's a good chance he's going to aspirate. And he might die from it. And so that's why you got to remember that. That's number one. NPO. Okay, it doesn't matter what they came, what's going on. This is what you do until you figure out what's going on. Remember, that's why the question says, what's the next step in your management? Students think it's about appendicitis, about a cholecystitis, and no, it's not. That's not what that question means. That means, how do you manage somebody who has abdominal pain? Then later on, you'll find out that it's appendicitis. All right, NPO, because they gotta take you surgery. IV normal saline, because it's very isotonic, meaning I want isotonic fluid that's gonna stay in your plasma, so your blood pressure does not drop. And most of these patients have had a lot of vomiting, so you got to replace their plasma volume. Number 3, nasogastric tube to decompress the gas in their intestines, which is what leads to perforation. And perforation can obviously lead to death, so you don't want to forget to do that. That's why they test you on this periodically. Number 4, meperidine for their pain. Meperidine, Demerol, every ER has it, every nursing station has it. Why? Because meperidine is the only opiate that does not contract the sphincter of ODDI, which means gallstones can still pass freely in case that's why he's here. You give him any other opiate, sphincter of OD tightens up. That means the gallstone can't pass, which means that pain will get even more severe if that's what he's here for, or what she's here for. Abdominal X-ray, then done next. With abdominal X-ray, we look at the pattern of the gas. Is it small intestine or colon? How do you know it's small intestine? You see the lines are real close together, remember? Segmentation, little segments. Colon, haustra, further apart. Just by taking a look at X-ray, you can tell. Colonic, small bowel obstruction, whatever it is, okay? Next thing you do, look for calcifications, right? Right upper quadrant, gallstones. In the flanks, kidney stones. Midline, aneurysm. So you look for calcifications that can help you make a diagnosis. Then you look for air underneath the diaphragm. If there's any air underneath the diaphragm, you've already perforated. We need to get operating right now, quickly. Figure it out up there. Air underneath the diaphragm, you perforate. Or if I can see both sides of the intestinal wall. Remember, there's gas inside the intestine. How come I can see the opposite side? That means there's gas out here too. You should never see both sides of the intestinal wall, unless you got gas outside, that's perforation. And then CT scan is a test we do when everything's been negative so far. That's why it says if still unsure. That means if the vignette says you can't really make out what's going on, nothing is showing up on X-ray, then I know the answer is CT scan next. Because a CT scan allows me to look at every organ with one test. Any questions? This is every abdominal pain now. Remember I told you when they give you a vignette, they'll hint at appendicitis to make you think of appendicitis and forget to do this stuff first. They'll hint at gallstones to make you think of gallstones and then you forget to think about this stuff first. See, again, to see if your mind is organized. All right, so be careful. Anyway, I'm sure we'll see it many times, so I'll remind you again. Yes, sir.
This algorithm applies vitals are relatively stable.
And this algorithm applies if the patient is what?
Vitals are relatively
Yeah,
stable.
patient's vitals are stable, right? This is what you
If it
do.
was unstable, which is
If they're unstable, we're going to the operating room. Yeah, don't stop it. We don't even stop in the ER. We go straight up to the operating room. Yeah, patient who's unstable, something bad is going on in there and needs to be taken out immediately. You don't have time to even stop in them to run X-rays. We go straight to the operating room. Okay. Yeah, this is the patient who's clinically stable. All right, and we got Leslie Gonzalez. You have a question?
Hi, doctor. Yes, I have a question regarding, I got confused with the autosomal recessive versus autosomal dominant. Porphyrias are autosomal, it depends if it's an enzyme deficiency. For example, the one we're discussing now, it's
Right.
enzyme deficiency, right?
Yeah, most of them are enzyme deficiencies. However, it's not the enzyme deficiency causing the problem. It's the protein, it's the porphyrin rings causing the problem.
Okay,
Yeah, so that's why they're autosomal dominant. Yeah, I used to
Okay.
get fooled, I used to pick autosomal recessive, then I looked them up one day and said, oh my God, they're all autosomal dominant. So then I had to figure out, okay, how do I make it go back to my pattern? Otherwise, I'm not gonna try to memorize one disease at a time, that takes too long, folks. So anytime I learn something, I say, okay, how do I make it still fit the pattern, so I don't have to memorize 17 diseases all of a sudden? All right, Mabel, you have a question?
Please, what did you say about in abdominal X-ray? You said something about classification.
Yeah, I say you look for calcifications. In the right upper quadrant, that's gallstones. In the flanks, that's kidney stones. Along the midline, that's aneurysm, a calcified aneurysm. Did you understand that?
Yeah, it said that
Okay.
if it's frank, it's kidney stone. If it's midline, it's aneurysm.
Right, exactly. Yeah. All right, very good. All right, moving on. Managing AIP. All right, what do? Same thing as for any other abdominal pain. The stuff I just gave you. But then specifically the disease, we increase the sugar in their fluids. That means rather than D5, we give them D10. That means twice the amount of sugar. Why? Because you got porphyrin rings. There's a lot of bilirubin, Karina, you now have to get rid of. How do you get rid of bilirubin? Remember, diglucuronide, that's sugar. Just gives them extra sugar. That means they can conjugate it faster and get it out of their own system. You understand, Cynthia? You understand, Angie? All right. We give them extra sugar, and then long term, we give them a drug called hematin. Hematin is synthetic heme. What's it gonna do? Block the rate of the enzyme of heme synthesis, and therefore slow down how much porphyrin they can make. And that's how it works. And it does work. I've had one patient I had to treat many times. All right, so managing AIP. Any questions at all? Managing abdominal pain. Any questions on that? Next one, burns. Oh, before I get to the burns, I put, this came out of order. I want to show you guys something. There's a different porphyria that led me to talk about burns. That's why yeah, there it is. And in my organization, I flipped it. Oh, yours is okay, so don't worry about that. I had to go forward to bring this forward, so I'm gonna have to remember before the next session to move this around. Anyway, the second one you need to know, second porphyria you need to know, is called erythrocytic protoporphyria, or late onset, we could say porphyria cutanea tarda. This is the people who burn upon exposure to light, which is what got me into talking about burns. So this should have been way before this. All right, one more time. This is the porphyria where so many porphyrins deposited underneath the skin that it causes burns when exposed to any light at all. Think about this, John. When a baby has jaundice the first few days, what color is the skin? Usually yellow. Everybody understands so far, right? How do we treat that baby? By doing what? A little phototherapy, shining a light on them. That's because light reacts with porphyrin rings and makes them water soluble, and then you pee it away. Right, follow me? So what if you had thousands more porphyrin rings than you normally would have? Then that means the reaction will be thousands more powerful. Right, follow? Because we're in organic chemistry, anytime a reaction is too powerful, it causes heat to be released, you're gonna burn. That's how they burn. That's how they burn. It's just a simple reaction, but it's multiplied times 1,000. And so that means now a ton of heat gets released and burns that child. Okay? Most common cause of death is skin infections. And that can happen right there in the hospital before they even leave, which means they could die before they can leave. Protect them from lights. So you can imagine the horror on a nurse's face when she sees this, because if you're not familiar with it, it'll scare the heck out of you. She calls you, newborn baby, put it in a bassinet. It's such a rare disease, I mean, we don't screen for it, okay? Put the child in a bassinet. What's above each bassinet? A light. It's just a light shining direct on that baby. Before you know it, skin bright red. Before you know it, blisters, bright red, first degree, blisters, second degree. Before you know it, you see smoke coming off the child's skin. What the? And a child is screaming at the top of their lungs because they're burning. They're literally burning. So you got to understand when the nurse calls you, I mean, she's panicking. But if you hear the clues, you have to tell her, snatch that child right away, go into a dark closet, close the door, I'll be there shortly. Folks, if you don't say that, the 5 minutes it takes you to get to the newborn nursery to go see this baby, that child was burning the whole time. The mom will still sue you and said it was your fault that this child died. And you wouldn't be able to prove otherwise because you let the child burn for 5 more minutes. And staff orders kill him right there in the newborn nursery. So you don't want that. So that's why when you hear the history, you got, oh my God, snatch that child, wrap him in a blanket, go in a dark room or a dark closet. I'll be right there. Because what you got to do is arrange for a room, private room for this kid that's going to be just dark, no lights allowed. And that means now I got to educate the parents that this child has to live in darkness. Yeah. Well, they found over time, if you're living in darkness, what vitamin deficiency you're going to develop? Vitamin D. All of them have vitamin D deficiency. But that's okay. We give them vitamin D and calcium supplements. Problem number 2. If light does not hit your retina by 3 months of age, you're blind for life. Like Stevie Wonder. That's what happened with him. If light does not hit the retina by 3 months of age, that's it. The brain shuts down the retina. That's it. No more information is allowed to come through. All right, that kid's blind for life. So a lot of them were blind because we didn't know back then what to do. Now, look what, see, get a blue or red light. Any light must hit their retina. So now they have red and blue lights in their homes. Looks like there's a party going on. Whoop, whoop. No, really, it actually works. So it's just the neighbors don't know what the hell's going on. Red and blue lights, they think there's a party. But that's the only lights they can tolerate. All right? No. See, Stevie Wonder has retinopathy of prematurity. So light never hit his retina. That's why he's blind for life. Yeah. This is just another cause of that, not that Stevie Wonder had this. Yes.
So is this also dominant recessive?
No, this is also dominant because it still has to do with the proteins deposition. Yeah.
So wouldn't it run?
Would it run in the family? Yeah, it can run in the family, sure. Yeah. Are you talking about for Stevie Wonder still? Or are we talking about for anybody? Okay, I was wondering why you were asking. Yeah. Oh, no, yeah, no, they're not surprised. I mean, the parents, usually one of them already has it and he passed it on. But the other parent, now you got to say the house has to be dark. Now we can say you can have red and blue lights in the rooms and these people don't come out at all during the day, but they'll come out late at night. Now imagine you're the neighbor, 11:30, almost midnight, and you hear, ha, 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 kick me the ball. You move the drapes, who the hell's out there playing ball at midnight? It's the neighbors. Like, what the? Don't come out till it's dark outside? And there's some weird people, man. You don't think nothing of it. And then the next day you go to school, and on your way back from school, and you overhear some nosy neighbors talking about it. And one of the kids had to go to the hospital for transfusion because they do sometimes, right? And then you hear, yeah, he needed some blood. What? Only comes out at midnight? Needed some blood? Folks, anyway, that's where the rumor about them being vampires, that's how it started. Just called nosy neighbors who only heard pieces of information and they swore. All of a sudden rumors started going on. Oh, those are vampires. Can't stay away from them. No, they come out at night because they can't come out during the day. I had one, not my patient personally, but there was one lady who came up with an ingenious solution. She talked to a tattoo artist and had him meet her at the tattoo parlor and tattoo her entire body in black and blue ink. Remember, black and blue reflect light away from your skin. By doing that, she could actually come out in the evening, like 5:30, 6 o'clock. Before that, she has never seen sunlight all her life. This was a full adult, never come out. But she just came with the idea and it worked. You know, but Normally, they don't come out till, 11 o'clock, 11:30. Now they'll come outside and take a walk around the neighborhood. Yeah, otherwise they're trapped in their own homes all day long. All right, anyway, that's porphyria containing tartar. Now, let me take you through here. This is called, survival, clinical survival. When I was a student, you show up for your first rotation, your third year, and then before you know it, they tell you, why don't you write the fluid orders for this child or for this adult? And you look up and say, I don't know anything about fluid, writing fluid orders. When did they teach that? They never did. And this happens all across the country. They never did. They've never taught, in any medical school I've gone to, they don't teach fluids. And yet on the first rotation, you expect to know fluids. And that used to just irritate the heck out of me. Why are they asking students questions about stuff they were never taught? It's a bunch of crap going on, folks. But anyway, that's why I threw this into you. I said, I'm going to teach you about burns, about fluids. That way, before you leave here, you know how to write fluids for anybody you want. Okay? And there's going to be a lot of questions where they're going to be discussing fluids. And I want you guys to understand what they're saying, because now you understand it. Okay? So let's go through it. Burns, you got to recognize it by their description. First degree burns involves only the epidermis. I'll tell you the histology, and I'll tell you clinical what it looks like. First degree burns involves only the epidermis. All you see is redness, like a sunburn. No extra fluid is necessary for first degree burns. No fluid resuscitation necessary for first degree burns. Any questions on that understanding? All right, second degree burns, you get blisters. It involves the epidermis and just below the epidermis. Saber, what is the first visible sign of inflammation after a burn? Swelling. So what's really happening is fluid is moving into that pocket, coming out of blood vessels. Because swelling is the first sign. Notice the answer has never changed, but it's got a new name all the time. So anyway, it comes out. That's why you have to give them fluids, because they just left their plasma. That means they're fluid depleted now. Just so you know why they want to test you on this. Because if you forget, the patient dehydrates and dies right in front of you because you didn't see it. All right, second degree burns must have fluid resuscitation automatically. How do I know they have it? Blisters. Those blisters, that's fluid. That should be in his plasma, and instead it's underneath the skin. Third degree burn, Bailey, involves the epidermis and the dermis. If you remember, the dermis is where your nerves and blood supply is located. That's why they have complete neuropathy. Can't feel a thing. I used to wonder why the surgeon would be cutting their skin right there by bedside. So I realized they can't feel a thing. In third degree burn, you can slice the skin off with no problem. Okay? Anyway, so third degree burn involves the epidermis and the dermis. Neuropathy on exam. That means all total sensory loss. And again, you got to have fluid resuscitation because your body will let fluid evaporate to cool that part of skin. But that's water evaporating out of your plasma. I got to replace it. This is why so many burn patients would die of shock, because doctors didn't recognize that. This is why the #1 cause of death in the first week of life is usually renal failure or a staph infection, because staph is already on your skin. You don't have to go there to catch it. But the renal failure is preventable. That's the reason why, if you didn't know, why they created burn units around the country strategically. And that way doctors are trained in taking care of burn patients, because they realize most doctors have no idea how to calculate any of this stuff. It sounds like, give them 200 cc's an hour. Sounds like a lot. You know, folks, 500, 600, 700 cc's an hour. See, sounds like a crazy number, unless you understand what's going on. If you don't give that much, they'll die. Okay? All right, so burns, first, second, third degree. Cindy. Well, it involves the entire dermis. That's why I just said epidermis and the entire dermis.
The second also involves.
No, it doesn't have to involve the dermis though. It doesn't have to, yeah. That's what I when I looked it up, it says does not have to involve the dermis. So there's this pocket, epidermis, and then there's this little pocket right before the dermis. That's where most of the fluid is. So the dermis does not have to be involved in second degree.
But third degree when it goes to
Yes, exactly. Third degree means it's gone all the way to the difference. That's why you have complete neuropathy. Yeah, so good question. All right, so burns, first, second, and third degree now. Then, how do you figure out fluid resuscitation? How do you figure out the fluid deficit of a burn patient? Now, this is on everybody's exam, so make sure you're catching this. Fluid deficit for any burn patient. A Dr. Parkland came up with this, so they call it the Parkland formula. This is a deficit only. I want to make sure you understand that. Then I'm going to show you how to figure out the maintenance fluid for anybody. This is just deficit for a burn patient. What you do is take 4 cc's of normal saline times their weight in kilograms times the percent burned area not to exceed 50%. If somebody gets burned more than 50%, most of them will die. Because we don't put more than 50% in that parentheses. Okay? And that's because those people have such a high death rate. If you put more than 50% in there, you'd be giving so much fluid, you put them in heart failure anyway. So we don't want to be the ones that kill them. But guess what? Most of them die anyway. Okay? So anyway, just remember that. 4 cc's times your weight in kilograms times the percent burned area, not to exceed 50%. Then you got to know, how do we give it back? Give half of the deficit. Half the deficit plus maintenance. So you got to figure that in a minute. Half the deficit plus maintenance. Give it over the first 8 hours. Give the second half of the deficit plus their maintenance over the next 16 hours. Meaning by 24 hours, every burn patient should be fully hydrated. That's the aim in America right now. Because we used to kill so many of them because of dehydration in the past. Renal failure because of dehydration, heart failure because of dehydration. We had no idea how much plasma would evaporate off of somebody's body when their body's so hot from a burn. All right, so now they expect every doctor to know how to calculate, because no matter who you are, you don't have to be a burn patient specialist, but you got to be the one that resuscitates the patient until you can send him to a burn ward. So you're the one who's going to be starting the fluids. And that's why they want you to know how to calculate it. So let me just talk through one of them. So let's say I got a 75 kilogram adult, that's about 152 pounds. Okay. And so let's say he's got 30% second and third degree burn. So that's my percent burned area. Remember, first degree does not count. Everybody with me so far? I gave you a number, 75 kilograms. I give you 30% burned area. So what do? Listen carefully. I take 4 cc's of normal saline times 75 kilograms. 4 times 75 is 300. And then I multiply it times 30. See how it just went from 300 to 9 liters, 9,000. Multiply times 30, not times 0.3. Yes. 30. Yes. This is why doctors were totally undercalculating what a burn patient needed. They thought 9,000, well, that's too much. And they would just, yeah, let's give them 2 liters. Patient will be dead in a few days.
Always a numerical value on the percentage, not the actual percentage.
Yeah, it's the actual percentage. The numeric value is what you're going to be multiplying by. So again, 75 kilogram person, 30% second and third degree burns. I take 4 cc's times 75, which is 300, and then I multiply times 30. That's 9 liters of water this person is deficient in. That's just deficit, not even maintenance. So for a 75 kilogram person, maintenance is about 125 cc's. Now I'll show you how to calculate in a second, so I'll write that down. Maintenance is about 125 cc's. I'm going to take the 9 liters divided in half, 4,500. I take the 4,500 cc's divided into 8 hours. Remember, the first 8 hours. That's about 510 cc's. Now I add the other 125 that he needs. That means he needs a rate of 635 cc's an hour for the first 8 hours. That's also how to remember on them, that they all need central lines. There's no peripheral line can handle 635 cc's an hour. Every burn patient gets a central line in the ER, because they know where you're going to resuscitate if you don't have a central line. Okay. Any questions so far? Yes. What about the risk of heart failure for what?
With that much fluid.
With that much fluid, actually the risk of heart failure is greater if you don't give them the fluid. The heart will be pumping so fast, so hard, because it doesn't have the fluid to pump. They'll die of heart failure. Yeah, so you got to put the fluid back in. Then the heart rate will eventually relax and say, oh, okay, I got plenty of fluid now. Yeah, so that's why you must get the fluid the first 24 hours. All right? All right. So that's how you calculate deficit for a burn patient. Any questions on that? Now the question is, rule of nines. How do you figure out percentage burned area? Rule of nines. Head and neck, 9%. Each arm, 9%. Torso, front is 18, back is 18. Each leg, 18 each. If you do the math, that's 99%. For the last 1%, your genitals. You got some guy who's vain, okay, 1.5. We're not talking about fantasies here, we're talking about science. Anyway, but this is how you calculate the rule of nines, because on the test, they'll tell you, oh, he's got a second-degree burns on his entire arm. Okay, that's 9%. But if they say he's got second-degree burns only in the front of his arm, you can estimate, that'll be 4.5. Okay, they expect you to know how to calculate that for yourself. All right, for children, usually under age 2. If you remember when they're born, their head is big compared to the legs, which is tiny. So what are you gonna do? Borrow a 9 from each leg, put it in their head. So head and neck, 27%. Each arm is still 9, torso is still the same, and genitals, 1%. So rule of nines, how to figure out what percentage burned area. And now you know with the Parkin formula how to figure out what deficit of fluid the person needs. Any questions before I do maintenance? Okay, here comes maintenance then. Fluid management. Children. Now Reno will go through the entire calculation. Right now, I just want you to trust the fluid so we can exercise it as we do questions. And then we'll go through the actual calculation of everything when we get to Reno. Maintenance fluid for a child, quarter normal saline. Mild dehydration, half normal saline. So you're doubling the amount of salt to hydrate them quicker. And that's why it works. But if you got moderate or severe dehydration, go to the top. The most isotonic fluid is normal saline, which is 0.9 normal saline. Half is 0.45 and quarter is 0.225. Obviously, again, this is memorization, but I want you to memorize it tonight so that tomorrow when fluid, if a question comes with fluids, I'm going to drill you. Because after a while, you become well-versed in it. Because I want you to shine on that first day when the residents start asking you, write the fluid orders for this child, and you actually know what to do. Otherwise, they get upset because students don't know how to write fluid orders. Maintenance fluids for children. Here's how you calculate the amount. Let me just do the amount, then I'll do your question. For the first 10 kilograms, it's 100 cc's per kilogram. For the next 10, that means 11 through 20, is 50 cc's per kilogram. And then everything after 20, so for 21 on, is 20 cc's per kilogram. What's your name in the back, sir? Was it Knife? Oh, yeah, okay. I didn't see you before, that's why I was asking. What school are you from? Oh, Roslyn, Chicago, way north? Okay, good. All right, so you do this with me then. Let's say I got a 20 kilogram child. How much fluid does he need? For the first 10 kilograms, how much? 100 cc's per kilogram. 20 kilogram child. No. So 100 cc's per kilogram. That means times 10. So it's 1,000 cc's so far. Everybody with me? I'm telling you, math kills a lot of students. Half the students can't even come up with these numbers because they get all mixed up with the math. So 100 cc's per kilogram. I see a lot of students that say, oh, 100 cc's. They didn't do any multiplying per kilogram. So if there's 10, it's 100 times 10. That's 1,000 so far. And since we're dealing with a 20 kilogram child, it's another 10 kilograms. What do we have there? So talk it out so everybody knows what you're doing. For the second 10, 50 times 10, which is 500. Then you add it to the 1,000 you already have. That means this child needs a total of 1,500 cc's in one day. The question always reads, how much fluid does this child require in 24 hours? On step 1, they want to just figure out the total, which is what we did, 1,500. Step 2 and 3 for you, you develop for this IV rate. They expect you to figure out the IV rate for anybody. See that, folks? If you can do that in front of a resident, you shine. Because most students don't know how to figure that out. Okay, now you know the name of the fluid and you know how to figure out the rate for it. Okay. All right, so let's do another one. Amy, you got a 27 kilogram child. For the first 10 kilograms, $1,000 cc's because 100 times 10. All right, for the next 10 kilograms, 500 cc's. So we're up to how much now? 1,500. For the last 7, yes, 140. Oh my God. Now you guys know why they brought the calculators back, man. I'm telling you. If you get confused, please use the calculator because I always got to give away a point. A point is a point. So anyway, so 7 times 20 is 140. You add the 140 to the 1,500. So this child needs 1,640 cc's in the next 24 hours. That's what they want on step 1. Step 2 and 3, divide by 24. There it is. IV rate. Okay. Now for the step 2 and 3, that's really just you behind them. Is there's a 5-2-1 rule. You ever? I'm sorry, 4-2-1 rule. You ever heard that? 4 cc's per kilogram for the first 10 cc's, 2 cc's per kilogram for the next 10, and then 1 cc per kilogram for everything after that. Yeah, it's much faster. So let's say for the 27 kilogram person, all right, rather than going the long route and then divide by 24 hours, you just say 4 times 10, for the first 10, that's 40 cc's an hour. 2 times 10, that's 20 more cc's, that's 60 cc's an hour so far. And then 1 for the last 7, that's 67 cc's an hour. That's the same thing as if you took 1640 and divided by 24. It just saves you time. Okay. Huh? 24 is bigger. What? Yeah, it's not 100%, but it's just a quick way to figure out the rate. Yeah, you can use either route you want because it can pretty much come up with almost the exact same numbers. Being off by 1 or 2 is not a big deal.
And then for step 1, I do multiply that number by 24 again.
No, you don't have to multiply that 24. You just do it either the regular route to figure out the total,
Yeah.
which would have been 1640. That's it. That's all. That's what they're going to ask you on step 1. You stop there. For step 2 and 3, for him, I said you can use this so you figure out the IV rate because on step 2 and 3 they want the IV rate. They don't want you to say 1640. They figure out the rate. Okay, because that's what we do in the hospital, folks. They want you might as well get used to it. Yeah, because he's a resident, so they expect you to know how to figure out the rate for anybody. Okay? All right. Yes, sir. Yeah.
1640.
Yeah, so he needs 1,640 cc's of quarter normal saline because it's maintenance. Doesn't have any illnesses. But if he had mild dehydration, you say, I want half normal saline then. If it was severely dehydrated, say, okay, 1,640 normal saline. Yep. This way again, I want you to know how to calculate it, calculate the IV rate, and know what fluid you should be giving. That way, by the time you finish this program, you'll know fluids for anybody. Okay? All right, any questions on this?
So is this just for
Is
burns?
this Ryan? Yeah, go ahead, Ryan. Sorry.
So is this
Go
just for
ahead, Ryan.
burns or for dehydration?
This is for anybody.
Okay.
Yeah, this is for any child. They'll tell you the child's weight in kilograms. This is how you figure out how much total fluid that child needs. Okay? All right, Gabriel, you have a question?
Yep, I just wanted to clarify what the numbers that you wrote to the right in red actually meant, just
Yeah.
to know.
The numbers over to the right in red is how to figure out the IV rate for
Okay.
anybody using the cc's per kilogram versus you calculate the total like we did over here on the left and then divide by 24.
Okay, so it's
Yeah,
with the
this
rate
is
then.
just a faster route, right?
Okay, awesome. Thank you.
Yep, no problem. All right, there was a hand up in here. Oh, Josh.
So I'm wondering, by that logic,
Mhm.
our.
Okay.
Does that mean that? Like that child?
Yeah, and so he's saying if we calculated that a 27 kilogram child needs 1.6 liters of water each day, that means each day he should be consuming approximately 1.6 liters of water each day. Now, it doesn't mean he has to drink, 1.6 liters of Gatorade every day, because in all the foods you eat, there's fluid in it. Okay, so that's why we say, all right, a rough estimate is somewhere between, 6 to 8, well, let's say 6 to 10 glasses of water a day. If you're doing that, then the other will come through the food that you eat. Just a rough estimate. Okay, and like I said, we'll go through all the calculations when we get to Reno. All right, Mabel, you have a question?
Yes, so if the child is like, okay, let me say 25 kilograms, so you times it will be 20 cc times 25, right?
No. Watch again, for 25 kilograms.
Because
For
you
the
say
first
after
10 kilograms. Wait a minute, let me take you through the steps. You gave me a 25 kilogram child. So for the first 10 kilograms, I need to give him 100 cc's per kilogram. That's 1,000 cc's right there. All right, for the next 10 kilograms, I need to give 50 per kilogram. That's another 500. That's 1,500. And then for the last 5, it's 5 times 20, which is 100. That means that child will need a total of 1,600 cc's in a day.
Thank you.
Yeah, no problem. Any other questions? Cool. Adult fluids now. That was just children we just did. That's pediatrics. What about adults? Maintenance fluid is half normal saline. Any level of dehydration is normal saline. So in other words, any patient who's an adult in the hospital needs normal saline. This has been written all over the renal literature, because this is what doctors were taught, half normal saline for an adult. But an adult who's in the hospital, it has mild dehydration because they're not eating and drinking because they're sick. And we forgot that. Okay, because I was trained that way, just have normal saline. Now realizing, well, if you're sick enough to be in the hospital, you're definitely not eating and drinking normal. I gotta assume that at least you have mild dehydration. You should be on normal saline. Okay? So by giving half rather than normal, we're giving a little more water than they needed. Guess why hyponatremia is so common in the hospital? Wonder no more. All right, so anyway, adult fluids is easy. You take 1.5 cc's of normal saline or half normal saline per kilogram per hour. Like the 75 kilogram adult I gave you. 75 times 1.5 is roughly 125. It's easy. 1.5. That adult starts around age 8. So 8-year-old, just multiply 1.5 times kilogram. Any questions on that? All right. Which fluid should I give? Whenever you're in an emergency, folks, you give the first isotonic fluid you can grab off the shelf. That is normal saline or lactate ringers. They're both isotonic. Because look at this. Normal saline has 154 milliequivalents of sodium chloride per liter. Ringer's lactate has 130. They're both about 10 milliequivalents away from where I need to be. So that's why they're both equal. Okay? Because your sodium is about 140, right in the middle. So that means when I give you normal saline, I give you slightly more sodium chloride than you need. You understand that, B? However, when I give you Ringer's lactate, Steve, I'm giving you slightly less sodium chloride than you need. You understand? Keep your voice down, folks in the back. All right? You understand, Steve? All right. So in an emergency, that's why they have normal saline lactate ringers in the ER, because it doesn't matter which one you grab. Just grab one. Okay? However, one is one better than the other. That's when you have a completely stable patient in the ER or on the floors, and now you can make a decision which one would be better for your person. All right? Look at Ringer's lactate. It contains bicarbonate. Who benefits from bicarbonate? Somebody who has metabolic acidosis. Okay. then that's when this is better than the other one. Except in DKA. That's the one time we don't give bicarb. Because you could kill them if you did that. But like burn patients, ringers like that. When I was doing my first rotation of surgery, I was writing the fluids for a person, and I wrote normal saline, and the resident starts yelling at me. We don't use normal saline up here, we use like their ringers. You know, my question, well, why is that? And then they get mad at me. What do you mean? Why is that? That's the way the surgeons like it up here. He had no clue why they like the ringers. Here it is, folks. When you got somebody laying on their back for surgery, they're smashing the tissue along the back. Has everyone seen that? It was just lactic acid building up back there. But I couldn't get one surgery resident to ever explain that to me. Why do you use lactate ringers in all surgery patients versus normal saline? Because I'm in pediatrics, we use normal saline almost everybody. So just a matter of habit, I was writing normal saline up there, and I'm getting yelled at because I don't know lactate ringers is better. But he has no idea why lactate ringers is better either. He says, yeah, we always do that up here. I said, no, well, why? No explanation. Now I know, okay? And that lets me apply it to so many more diseases than just surgery patients, okay? All right, normal saline though, has a little more sodium chloride than you need, Solange. If I give your body more chloride than you need, your body will waste the other negative charge, which is called bicarb. Who needs to waste bicarb? Somebody who has one acid-base problem. Somebody who has metabolic alkalosis, and that is 90% of dehydrated people. That's why normal saline is always snatched off the shelf first, because you're gonna be right 9 out of 10 times. I told you that's the way we practice medicine. Nobody says you did anything wrong when you do the 90%. There's only one person, 9 out of 10. One person will be harmed by what you're doing. And still standard of care, folks. If you look throughout all the literature, said doctors should be right at least 90% of the time. They didn't say 100, 90. That's because this is how we practice medicine. Okay, because we rather you save 90% of people and you might harm one person, you know, 1 out of 10. We got no problem with that. Because you saved 9 out of 10 with no harm done to anybody. All right, so anyway, remember that. Yes, sir.
Based on that premise, any bedridden patient, lactate ringers will probably better.
Any what now?
Any bedridden patient.
Bedridden patient, yeah. If they're like elder people just lying on their back, you know, after hip surgery, that means they can't move. Yeah, you might want to use lactate ringers on that person. Yeah, because they got a lot of lactic acid building up in their tissues on their back. And you want bicarb to go in there and neutralize all that. Yeah. See? I mean, now you're thinking, baby, figuring things out without my permission. All right, I like that. I told you, man, I'm telling you, folks, that's why I get excited. 28 years, I've never been bored teaching this stuff. Because the day, every time Dr. Shah helped me make the connection, I was so excited. Because I said, oh my God, that's why we do that. I never knew. And not did any resident or any attendant. Everybody just yells at you when you don't do something the way they want it done. But then ask why is it done that way? All of a sudden everybody looks at you like, well, why you even ask? Now you get in trouble for even asking. That's because they have no clue. Everybody just does it because it's part of protocol. I told you everything's written on the wall. I get so tired of that. And that's why doctors just don't even think. Now, what's the protocol? Just follow protocol. And that means we're not even allowed to think anymore. That's why doctors are burning out. There's no more fun in it. You're just following rules. You know, medicine's fun when you know what you're doing. Okay, because that way you know your thought process will help somebody stay alive. I like that thought. I like that whole thing. All right. And that way people stay alive, they thank you, they love you, they are grateful to you. Then you feel good every day when you go to work. Solange.
I was wondering, do we not give the ringers like this because we're gonna give them insulin before this?
Yeah, we don't give bicarb to anybody at DKA. All right, and when we get DKA, I think, yeah, next week, then I'll explain all the reasons why we don't give bicarb. There's like 5 reasons why we don't give it. All right. When do we use 3% saline? For 3 reasons. 3%, 3 reasons. Here they are. Number 1, hypernatremia with sodium under 120, and they have symptoms. You use 3% saline to get them back above 120, not to correct back to 140 now. Hopefully you guys remember, if you correct sodium too fast, what do you get? Central pontine demyelination. You cause brain damage, and that's permanent. So I want to make sure everybody understands. You give 3% saline just to get them above 120, and then the seizures will stop. And then you can treat it the rest of the way, slowly. All right. if you have increase in intracranial pressure, and I need to suck fluid out of your brain, so that the brain will collapse a little bit to take the pressure off of it. Another use. And then finally, as an aerosol, so breathing treatment for obstructive lung disease, especially in cystic fibrosis, bad COPD. All you do is spray in the lung with a bunch of water, and because it's hypertonic, it'll pull more water and loosen up the mucus, so the person can cough up the mucus, clean up their lungs so they can breathe better. Mabel, do you have another question? See, your hand is up. Oh, that was old.
No,
old hand.
no, I don't
Okay.
have, I'm sorry.
Okay, no problem.
There's a question here.
Oh, all right. Sabu, go ahead. Ringer's lactate is the question, yes? If they're bedridden or surgery, lactate ringers is better. Yeah, even if there's no surgery, yeah, because if the reason for why would they like to use a surgery is because you're flat on your back for hours. There's lactic acid building up along your back. That means as soon as we roll you over or the surgery's over, all that lactic acid enters circulation. And you might want to have some bicarb to neutralize it. Yeah. Your grandpa passed away because they gave him what? And now it's not because they gave him normal saline. Yeah, it's not that. But yeah, lactate ringers would have been better. Yeah. It's just whenever you have a chance to do something that's better for your patient, you should do something that's better for your patient. But like I said, in emergency, it doesn't matter which fluid you use. You just want something that's isotonic. But when you have a chance to make a decision, folks, I just want to show you how you make that decision. Like I said, it'll make you shine on the wards if you know these things, because residents get so mad at students because they don't know fluids. And I get mad at the residents and say, when were they ever taught fluids? All right. So that's why I just said, let me throw it into the program so that students will learn how to do fluids on their own now. All right, so this was a porphyria that we just talked about. And now I'm going to go through some pharmacokinetics before we take our first break.
Actually, I had a quick question from the prior slide.
Who's this? Gabriel, go ahead.
Yeah, sorry about that. I was wondering for the 3% saline in particular, when you mentioned that you use it for an increased intracranial pressure,
Okay.
how does that work in terms of, because I would think that it would pull water into the CNS or like the CNS space and
Okay, the question
would
is, how
increase
does
it more.
3% saline decrease intracranial pressure?
Yeah.
So let's say I inject the 3% saline into your veins. Follow me so far?
Mhm.
Venous blood returns to your heart. You with me so far?
Mhm.
The heart will pump that 3% saline straight up to your brain. Within seconds, it's already in your brain. Now it's going through the vessels. If the vessels have hypertonic osmolarity, which way is water going to move? Into the vessels or out of the vessels?
If the vessels have hyperosmolarity, water would move into the vessels.
Into the vessel and out of the brain cells so that the brain
Oh, okay.
shoots down.
Okay.
And there it is.
That makes sense.
The brain shoots up.
That makes
Sorry, my
sense.
man,
Thank
that's
you.
why you're here.
Thank you very much.
I'm gonna teach it to you. Yeah. That way, when you can visualize it, you don't forget it anymore. Yes, sir.
Same example, so you will give that with like mannitol or.
Yeah, you gave same thing that mannitol would have done. Yeah.
No, but like, would you combine them?
No, you don't have to combine it. One or the other. Yeah, one or the other, because they're both doing the same thing. Would it work for pseudotumor cerebri? It could, but with the pseudotumor cerebri, all you got to do is take away the vitamin A or take away what the person's doing, and the body will just take care of it. Because it's not pushing on your brain. There's just too much CSF, but there's nothing really pushing on your brain. Yeah, so you don't have to worry about it. All right, here we go. Pharmacokinetics, folks. I'm going to talk about opiates, benzos, barbiturates, and then miscellaneous CNS depressants. Hear me again. Benzos, barbiturates, alcohol even, and then miscellaneous CNS depressants. What do they have in common? They all depress your CNS. If I depress your CNS, Zena, is that going to speed you up or slow you down? Slow you down. So without missing a beat, folks, I want to hear one word that means the same thing. Now, if you remember, we already did this exercise. We're just going to let me just do a few more. Let's do this side of the room. Slow me down, go ahead. Bradycardia. Brittle nails, okay? Lethargy. Low energy state, what does that mean? Give me a word. bradypnea, coma, constipation, weakness, low respiratory rate, fatigue, tiredness. Sight first. Just give me a word that means something is slowed down in your body. That's how you figure out all the sound effects without looking it up. Bradycardia. All right, Melissa? Was that? Confusion. All right, Akshay? Hypotension. Michael? Shortness of breath. All right? Yeah, you do. Slurred speech. Sinus depression. The people don't say, hey, doc, my sinus is depressed. Give me a word. Give me a word that means the same thing. Sleepiness. There you go. Respiratory depression. Obtundant. Come on. Constipation. Hearing loss. Meiosis. Urinary retention. Bradycardia. Infertility, man, you're looking way down the line, huh? All right, but that's cool. Lack of blood flow to your testicles, you're definitely gonna be infertile. But anyway, my point is, but notice, remember we did that on the first day. Now look, 2 days later, see how much easier it went? And first day we had to struggle. I had to come back to a couple of people. Now he's getting better. Why? Because we're thinking in patterns. And now you're not trying to remember, oh, what that hand I have on the left hand side of the page that we got on that Tuesday afternoon in that class. See, no more taking 10 minutes to remember one word. That's all you remember. One word after all that thinking. Only one word popped in your head. You just create a pattern real fast. Especially when you're in front of an attendant. Create a pattern real fast. That way, when it comes to you, you got 10, 20 things to say. You shine. Because remember, you want to impress your attendings. They're the ones who control the residencies. If they like you, they're making calls, they're talking, hey, what residence do you think about? Also, they want to be your best friend. Just like all these testimonials, man. People are getting residencies without even going through match. That's because they're impressed with you. They're not used to seeing students who are organizing their thinking, folks. Not at all. All right, so now, question is, I just gave you a whole bunch of drugs. They all have the same side effects. How do I know which one you're on? Only a couple of them have a clue. When you're intoxicated with opiates, I can tell, pinpoint pupils. Is the only CNS depressant that gives you pinpoint pupils. And that's because it stimulates what they call Edinger-Westphal nucleus, which is a nucleus for current of 3. The current of 3 is one that constricts your pupils for you. So opiate intoxication can clearly be separated with pinpoint pupils. And then it has the most sedating effect on smooth muscle. So they have severe constipation, severe urinary retention. That's how I know opiates. Severe constipation and severe urinary retention. It has such a sedating effect on smooth muscle like no other drug out there. Let's say, if I asked you, when somebody's overdosed on any one of these drugs, Chris with a K, what organ should I worry about first? Kidneys? I wouldn't pick that on the test. Which one? Brain. Don't forget, if I say worry, I didn't say sacrifice. Yeah, who's gonna shut down first? Now you say kidney. When I say worry, I want to make sure you never forget all these patterns I'm teaching you. Otherwise, you got a lot of reading to do. If you're gonna figure them out one drug at a time, good luck. All right, but I'm showing you the profile, so you don't have to look them up anymore. Okay, they're all sedating. It slow everything down. Got it. If they say, "What are you worried about?" I look for a neurological word. CNS depressant, bradypnea, something. It's got to be a neurological word, though. You got to make sure you're looking carefully. Don't just pick the first right answer. All of a sudden, you pick something about the heart, you won't get a point. Because the brain goes first. All right? So brain, heart, kidney. Same pattern again. What are you going to die from all these drugs? Well, heart failure would be the first answer, but it's actually number 2. Why? Because if I shut off your brain, folks, your heart still keeps beating. So you didn't die from heart failure. I turned off your breathing though, so respiratory failure is number 1. all CNS depressants cause of death, respiratory depression. And then number 2 is heart failure. And we'll do cardiac, I'll teach that to you again. You can turn off the brain, but the heart will keep beating. But you'll stop breathing because your diaphragm is controlled by your brain. So respiratory failure is number 1 cause of death for all CNS depressants. Heart failure is number 2. Lawrence, you had a question about opioids. You get cramps and diarrhea as you're coming off the opiates. That's the opposite direction, right? Which is what I'm about to do now. So everybody understand my profile for all of these drugs. They're all depressants. You come up with 1,000 words if you want. But remember, you look for neurological words first, cardiac words, and renal third, the whole thing. Nothing has changed. Now, what if I say cause of death? You say respiratory failure followed by heart failure. Done. How about if you're withdrawing from any of these drugs? Abigail, you expect to speed up or slow down? Speed up. Everybody follow? Now, without mentioning the beat, I want a word that means speed up, starting with you. Yeah. Yeah, fast breathing. Good enough. Tachycardia. Diarrhea. We say polyuria. Excessive, so polyuria. Montessori. Tachycardia. Excessive lacrimation. Sandra. What? Somebody already said diarrhea. You can't use the same word. All right, hang on. Everybody listen carefully. I showed you guys how to survive a moment like this. An attendant should never come to you and you got to stall for that long because he's going to move on to somebody else. You just missed a chance to shine. You follow me? What did I say to do? Number 1, if somebody is using one particular organ, get ready with another organ. That way you got your answer ready to go when it comes to you. Or second, do like I do. Steal the damn answer, man. There's no way anybody goes before me and it comes to me and I ain't got something to say. All I do is steal whatever I've heard already. You know, so with the bradycardia, you say, well, somebody said slow heart rate. Somebody else said bradycardia. I said, well, low blood pressure. How am I wrong? All I did was say the same thing, but I used a different word. But the attending will give me a point because I know I'm right. You see? And that way there's no stalling because, you know, he's going through a whole bunch of students at the same time. You want to have an answer, folks, because he's got to grade every one of you. So if you draw a blank every time he comes to you, that's not going to be a good grading. He's not going to assume that you know because you didn't know. You didn't tell him. You got to know when he asked you the question, what's the answer now? So remember, you have 2 ways to get out of that situation. Take another organ. Just listen to what somebody else is saying before you. That's why I always say, listen when other people are talking. Because that's what I do. I figure out what organ they're taking and say, that means every time they take one, when the organ I had in my head, I go to another organ, go to another organ, go to another organ. Then as soon as it comes to me, boom, I already know what organ I'm taking. And then boom, the answer comes out of my head like that. Okay? That way you are ready every time an attending asks you a question. All right, let's do one. Reed, your turn. Weight loss. Okay, weight loss from all that diarrhea. Increased peristalsis. Psychosis. Anxiety. Lawrence. Hypersalivation. Mydriasis. Hypertension. Who's behind? Oh, sorry, Cynthia. Increased metabolic rate. Increased temperature, Rachel. Hyperreflexia, Roshni. What? Seizures. Nausea. Sweating. Diaphoresis. Agitation. Palpitations. Arrhythmia. Oh, look at this, man. All right, we're playing Texas Hold'em now. Karina, see her, wait. See her one, raise her two, give me three. See her one, she gave me one answer. You're gonna do better, give me three answers. Three answers.
Okay, restlessness.
Restlessness,
Hunger.
hunger,
Sorry.
no, agitation is okay, as long as it's not the same word.
Sorry.
All right. Boo. You can't let her trump you like that. You gotta see her three and raise her two, baby. Give me five. Only five. Yeah, just five. I know you probably got 10 or 20, but that's okay. Just give me five, that's all.
Can I say the one?
You can say whatever you want to say, as long as it's not the same word that she just said. Tremors. Increased heart rate. Increased sexual drive.
Study?
Increased sweating. Anxiousness. See, it wasn't that hard. See, it was not that hard, folks. That's what you do. And see, after a while, you'll get so used to it, it won't even bother if I say, give me 10, give me 20. And remember I told you the national average, 2 for students, 4 for residents. Imagine if you come up with 5, 10 in front of attending anytime you ask you a question. Come on, folks, they're gonna be inviting you to residency. I can guarantee you that. Because that's what blows them away, is when a student who I know just came through the program goes to a rotation, and in a few days, they're already calling me, man, they offered me residency already. I said, I told you it's gonna happen. They're shocked that you know all this stuff and you can run off lists like it's nothing. Because students hate to be put on the spot. Residents hate to be put on the spot. That's how I know everybody's memorizing. You just memorize. That's why you're afraid you're gonna forget what you memorized. But if you use patterns, man, you come up with 1,000 things anytime you want. All right, Amara, you have a question?
Good morning, sir. I just
Good.
want to add yawning.
Yawning. Oh, you wanted to give us some answers? Oh, but wait a minute. She wants to play cards with some food. And you gotta give me the game for some money. You're gonna see her 5, raise her 3. Give me 8. Go ahead now. Amara, go ahead.
Okay, so if I have to give you 8, I have to repeat everything. Okay,
Come on, girl, just give me as many as you can. Go ahead.
okay, so let's start with CNS. Dizziness, confusion,
Dizziness, confusion,
then sleepiness,
sleepiness. No, not sleepiness now, remember. Increased activity. You're
agitation, sorry, agitation, yes.
Agitation.
Opposite of that. Agitation. Then
Let's go to the order.
so for lungs, it can be increased breathing,
Yeah,
and
increased breathing.
for heart, it can be tachycardia and
Tachycardia,
high blood pressure.
high blood pressure,
And for stomach, it can be nausea
nausea.
and vomiting,
Come on, baby, bring it home.
and then cramps,
Oh,
and
now she's
then
rolling. Way beyond 8 now. Now, maybe let's-
abdominal pain, urination, then
She's an animal. All right, good job, man. See what I mean? I told you after a while, you get so good at it. All of a sudden now you're not scared about anybody answering you questions. Because now you know how to think it out with patterns. And that is more powerful than trying to remember one line out of a page of some book or some handout that you got. And that's why nobody can come up with 2 or 3 things. 2, oh my God, 2 things. I don't know about 2 things. No, you should know 20 things. Okay? That's all you do, folks. And then whenever you're in a group, use the steal. I'm telling you, man. Steal people's answers. The attendings never knew what I was doing. That's how I know they were never trained like Dr. Sean, Dr. Rick. Because I'm stealing right in front of them. All I'm doing is duplicate everything I heard. But I'm racking up points in their eyes. How does this kid know this stuff? I thought he was the resident who was in trouble. Yeah, I was. I was happy to say, yes, I was the resident who was in trouble. I was on probation. I said, I got nothing to hide here. I got no shame. I said, but somebody finally told me how to think. I want you to know that. Because I want them to know that even somebody who was having so much trouble, take the time and teach them instead of looking down on them because they don't know something. You know, that's why I give Dr. Shaw so much credit. He never looked down on me, never put me down. The man just kept teaching me till one day my brain exploded and I saw things that I'd never seen before. And that's when I realized there's so much misinformation written in books. And that's why I get so many fights with students that always start with the book said, the book said. I said, I know what the book said. I said, but this is a better way to say it if you want to get more points on that exam. Okay? Because if you say it the way the book said, you only get one answer right. The test is going to switch something, your answer's not wrong, just that fast. Okay? Just like acid base. Most students don't even know when the test writer switch environments. And they pick the same answer the book said, and I realized they didn't get it right. Okay? All right, so now, how do I know what you're withdrawing from? A couple of clues. Opiate withdrawal. Opiate withdrawal. Severe diarrhea and urination. Makes sense, right? I told you the most sedating effect is smooth muscle. That means when it starts to wake up, this thing starts, I mean, they poop all over the place. Ask any policeman when you take a heroin addict to jail. Yeah, oh my God, they poop all over the place, they pee all over the place because they cannot control it. That's how you know it. They're in opiates. All right. The second one, alcohol withdrawal. Alcohol withdrawal, formication. You guys ever heard the term formication before? Formication, yeah, it's a feeling of crawling insects underneath your skin. Alcohol withdrawal is number one. Don't worry, it's coming up. Formication. All right, let's go through them now. Opiates, CNS depressants. Now, there's all these drugs. CNS depressants, most relaxants, and analgesics. I got to confess a couple of confessions for you. When I first got here, Champaign, I remember reading this word analgesics, and I thought it had something to do with the anus. And I thought it meant that people were constipated. I said, oh, analgesics must be something that helps you move your bowels. Until I went to Walgreens, I saw a whole aisle full of analgesics. I'm like, damn, everybody's constipated in Champaign. I'm serious, man. I'm telling you. I'm glad I never told any instructors that. I said, well, everybody in this town must be constipated. There's a whole aisle full of analgesics. And then when I went to the library and I saw the journal, Annals of Internal Medicine, I'm like, damn, what is this fixation with the anus going on in here? There's a whole journal about it. Until I find out what that word really meant. I was so embarrassed. I said, I'm glad I never told them. They would have kicked me out already. All right, but then, okay, one more confession. I'll tell you, because I can laugh now, because back then I was like, whoa, I mean, I was so far off from the truth. Another one, I went to the library and started reading some articles. And I noticed at the end of every article, it always says somebody, Al. You guys know what I'm talking about? Al? I thought there was some guy named Al out there. And by the time I read the third article, I said, this Al is everywhere. Damn. I said, I want to be smart like Al. I got to find out where he lives. I thought there was a guy named Al. In every journal. Oh my goodness, I was so embarrassed when I found out what that meant. Okay, so anyway, opiates, CNS depressants, muscle relaxants, analgesics, the receptors, mu and kappa. Mu, M is for mind. So anything about CNS, pick mu. K, kappa, kill the pain signal in the spinal cord. So all over the spinal cord, all those are kappa. In the brain, mu. Just a good way to remember it. The clue for opiates, remember, pinpoint pupils. Withdrawal, severe GI motility and bladder motility. So urinating all over yourself, pooping all over yourself, that patient is withdrawn from opiates. We see the same thing in a baby born to an addict. Same thing. You can tell mom is a heroin addict by looking at how that baby is withdrawing. Okay. So create a pattern, folks. Very powerful. Solange.
Are those the babies that when, like, if the pregnancy goes to 9 months and let's say like 2 more days, the baby can actually poop on inside her?
No. She's asking, is that the reason for some babies pooping inside the mom? No. That's called meconium release, but that's not the same thing. Yeah, we'll talk about that at a different time. All right, benzos, the next group. Benzodiazepines, first, the action. Remember I told you, always know the action. Increased frequency of chloride channel opening. That means more chloride goes in, the cells become more negative, and therefore less likely to do anything. Remember, that was our pattern. Slow things down. All right? From the beginning, fluorazepam, longest acting. Who'd you avoid this drug in, Karina?
Sorry, longest acting one.
Longest acting benzodiazepine, who'd you avoid it in?
Children.
All right, now stop all that whispering. Yeah, see? Somebody hear you? They're gonna say exactly what you said, but now they didn't learn anything. Give her a chance to figure it out for herself.
I'm gonna say abortion. Or like.
Well, remember the first pattern to go through, that means children, elderly, obese, overweight, pregnant, diabetic, hypothyroid, anybody with a high fat content, avoid. Or anybody with liver disease, avoid. See that? That way you can hear that without my saying a word. So long as acting, short acting, you got to make sure you hear it when I say it. All right, that way we use the short acting for the elderly and the obese and the diabetic and the pregnant mothers. You already hear all that stuff without my saying a word. Okay? All right, so pay attention. Flurazepam, longest acting. Alprazolam, shortest acting. See, now you hear the opposite. Why we use a lot of Xanax in elderly people. Okay, but now it makes sense versus you just memorize that out of somebody's book. Okay, alprazolam, short acting, is the drug of choice for all anxiety disorders acutely. If I want to stop an anxiety attack due to anything, this is the drug of choice right here. It's short term, it's not, definitely not long term, because we don't want you sleeping every day. But acute anxiety disorders, acute management, that's the key. How do you stop this anxiety today, right now? Alprazolam is a drug of choice. Triazolam, also short acting, but triazolam, we give it to elderly people. Notice again, elderly, makes sense, right? To help them try and get to sleep, triazolam, that's how I remember that. Because elder people have trouble with sleep initiation. Triazolam helps them try and get to sleep. Temazepam helps them with sleep maintenance. What does that mean? Temazepam is like a 2-hour delay before it even kicks in. In elderly people, they have a habit of waking up every 2 hours. What if I give you this one? At that 2-hour mark when you were about to wake up, knocks you right back out. Now you sleep 4 or 5 hours and they feel so much better. Instead of waking up every 2 hours and have to stare at the TV because they can't go back to sleep. So temazepam is called sleep maintenance versus triazolam, sleep initiation. Okay, oxazepam, nothing unique there. Clonazepam is the only benzo ever approved for absence seizures. As you know, it's not the drug of choice. Ethosuximide took over that throne, but that question is still out there. What was the only benzo ever approved for absence seizures? Victoria, you have a question?
Yeah, so I know that the benzos, they decrease your deep sleep, is that correct?
Yeah, the decreased REM.
So what is the reason for that if it helps you, if they're used to help you fall asleep and stay asleep?
They help you fall asleep, but they help you go all the way down to delta, which is still deep sleep. It's just not REM. You just don't dream as much on a benzo, but you still feel well rested. That's why we still use it
Okay.
short term for sleeplessness. I'm
Okay,
able,
thank you.
rested. Yeah, no problem.
You said that oxazepam is the only benzo for what again?
Which one?
Oxazepam. is the only
Oxazepam.
benzo-
No, that one has no clues. I didn't say anything for him. It was clonazepam that I said is the only benzo ever approved for absence seizures.
Okay, absence seizure. Oh, yeah, okay.
Yeah,
Oh.
absence, right. But ethosuximide is a drug of choice now. All right, clonazepam also was the drug of choice for restless leg syndrome. This is the husband or wife talks about they can feel, prickly feeling crawling up their legs. And so it twitches a lot and ends up kicking the spouse. All right, and the spouse obviously is complaining. He or she gets kicked every night. Clonazepam was a drug of choice for that until they came up with new drugs. The drug we now prefer for restless leg syndrome is called pramipexole. Pramipexole and ropinirole. Yeah, you can also use for Parkinson's. Yeah, these two drugs are dopamine agonists. They're like 20% potency. That's why they're not lead drugs, but you can add them to the other dopamine drugs for Parkinson's. Anyway, but they're anticholinergic. That's what stops muscles from contracting. So pramipexole, ropinirole, drugs of choice now for restless leg syndrome. The problem is pramipexole, P for pathological gambling. Remember, dopamine can make you psychotic. And some people went to the casino, lost all their money, and they were never gamblers before they started pramipexole. So that's why they have to write that down as a side effect. All right, so if you got somebody who's a gambler, you probably don't want to promote pramipexole because he's gonna go lose all his money. All right, that's clonazepam. Next one, diazepam, drug of choice for, let me see, status epilepticus is the term. Somebody who's been seizing for more than 20 minutes. That's value, right. The way I remember that is diazepam is the only benzo that comes as a rectal suppository. So somebody's in the ER, hasn't even been seen by the doctor, he starts seizing. There's no IV. You can't start giving him shots or giving him something by mouth. He's seizing, his mouth's all over the place. Shove this up their butt, the seizure will stop. So diazepam. Drug of choice for status epilepticus. Diazepam first, lorazepam is second. Now, lorazepam alpha, ladies. Lorazepam is a drug of choice for generalized anxiety disorder in middle-aged women, because it has an exactly 8-hour half-life. That way, if most of the anxiety is in the morning, use it for these 8 hours. That way, the afternoon, evening, you won't be feeling anything. Or after evening, it works out exactly 8-hour half-life. All right, so first line benzo for generalized anxiety disorder in middle-aged women. Next, L for liver disease. Lorazepam is the only benzo that can be excreted by the kidney. All the rest are long half-lives, except the short acting ones I told you about. All right, so L for liver, if you got liver disease and we got to use a benzo, that's the one we like, because the kidney can get rid of a lot of it for you. Yes. Yeah, that's what I was pointing out. These are also short acting, but this is the lead. Yeah. I know we're saying the same thing. Lorazepam is just a lead drug, but I already gave you the other three, which are also short acting. That means they're also excreted by the kidney. Oh yeah, oh yeah. Yeah, so I just remember L for liver disease, because they'll give you an alcoholic who's withdrawing, and we tend to use chlordiazepam epoxide, which is Librium. But then they tell you liver enzymes are elevated, and you're supposed to know, okay, lorazepam now. See? And so you gotta know what is the best clue for a drug, and that's all I'm sharing with you. Lorazepam, L for ladies, L for liver disease. Next, midazolam, one of my favorite drugs. Midazolam has what they call anterograde amnesia. This is the drug that was copied for the date rape drug, by the way. GHB. Midazolam, excellent drug. We only use it for procedures. Because if I spray it up your nostrils, because it's a nasal spray, or give it to you by mouth or inject it, doesn't matter. The problem is for the next 45 minutes, you're wide awake, talking to me, interacting, and then you suddenly wake up, realize you don't even know what happened for the last 45 minutes. The first time I saw that, when we were doing a colonoscopy, I was like, wow, that's pretty neat. I mean, the guy is looking and we say, hey, see that polyp there, 35 centimeters? And he's, yeah, oh man, that's what about the whole time. And then all of a sudden he wakes up. When you guys gonna get started? Oh man, we're done already. He had no idea what even happened. All right. So anyway, I was one of those bad patients. I ran from the doctors. You know, first colonoscopy. I said, well, I'll put it off to next year. The next year, the next year, the next. Man, something happens to you when you walk into a gastroenterologist's office and you see that colonoscope hanging from the damn ceiling. And I'm looking at that thing and say, Doc, you're gonna shove that up where again? You're looking for blood? You can definitely go find it. And I said, okay, I'll come back next year. I didn't go back. 5 years I ran. I said, no, I ain't going back there for no colonoscopy. And then it was time for my wife to have hers. She was brave. She says she's going. So anyway, so I went with her, and I remember she came out, and I said, well, how was it? She said, how was what? I said, the colonoscopy. She said, what colonoscopy? Oh, I thought they were still gonna do it. She don't remember nothing. So then the gastroenterologist come out and said, hey, Doc, what you give her? I said, a little midazolam. She said, midazolam does this? Oh, Doc, sign me up. I'm next, man. I'm next, baby. I'm telling you, I stopped running. Good stuff. I mean, I can now tell my patients. I'm talking about midazolam, not the colonoscopy. The midazolam, man. Oh, I'm telling you, I've had 3 of them. And all I remember is I'm sitting there like this, and anesthesiologist comes in and says, "Yeah, we're gonna give you a little." I said, "Wait, Mendoza, right? Okay, good. That's it. I don't care what y'all do after that. Just do whatever you want to do." Because all I remember is the guy standing here telling me, "Mendoza, yes." Next picture, the nurse taking out my IV. We're done. I don't know nothing about what happened. And I said, "This is the best drug in the world." And so now I can actually tell my patients, 'cause I've had patients who were running from it too. I said, no, dude, just make sure they give you some Mendoza, all right? Tell them Dr. Francis insisted on it. Yeah, propofol does the same thing. Man, good stuff. But I'm just sharing that with you guys so that if you got a patient who's running, because I know I'm not the only one who was running. A lot of guys run for colonoscopies. But if you reassure them and say, "Hey, there's this drug that we use," your eyes will be open, but for 45 minutes, you won't record anything in your brain. You won't even know whatever happened. And the first time when he wakes up and realizes the procedure is over, he'll love you to death. It's like, man, this is good stuff. As long as they give him that, he can care less what they got to do. Yeah, I'm telling you, good stuff. Anyway, that's all right. Chlordiazepam peroxide, drug of choice for alcoholic withdrawal seizures. Unless they got liver disease, then you go to lorazepam, so don't forget it. And then flumazenil, benzo overdose. It blocks the benzo receptor. Any questions? All right, cool. We'll continue after a word from our sponsors. Time to take a break. All right, 10:40, we'll start back at 10:45. Take a break.
Hey, is anyone there, please? Hello?
Always late, always early, always late, 1 and 2. Yeah, I just told you, come back at 10:45. Nobody said a word. Mabel, did you have a question? This is break time. What was your question? Oh, see, here we go. That's your
I
phone.
have a question.
Oh, okay, Mabel, go ahead and ask. What's the question?
Sir, please, what did you say about midazolam?
I just give you a whole story. I mean, those didn't hear words. I know,
Midazolam,
Mabel, you gotta be listening when everybody else is listening. Midazolam gives you anterograde amnesia. Anterograde or anesthesia for like 45 minutes. It's used primarily for procedures. That's why I was talking about the colonoscopy. The person will never remember anything that happened.
okay.
Yeah, that's the best group for that drug.
Yeah, dude, it's good. No, okay. ¿Te gusta mi no? Oh, I see. Guess what? You're right. Like, okay, I need do I need
Talk to. Decrease. But they can be two.
Yeah.
Oh. Also, no, they'll be,
Yeah.
Okay. Right away. Yeah. Awesome. Yeah.
But it should be basic. I think right now, I think. I don't know. Would you do like double it? No, I think I could do it of the other stuff and then a normal amount. And so. If you have it, if you only add more, it's about. Yeah. It's not. Well, yeah, it's, I mean, it's fine. Not ideal, not the best.
All right, let's do it. Finish it up. Next category of drugs, barbiturates. What do? Similar to benzos, they increase duration of chloride channel opening. But notice you get the same net effect. More chloride goes to the cell gets more negative, and therefore less likely to fire. And there it is, everything slows down again, just like we did. The unfortunate thing is benzos and barbiturates don't have any classic clues that you're gonna see on their physical exam. All right, from the top, primidone is the parent drug for phenobarbital, long acting. So now you hear all that stuff that goes with that. But primidone was taken off the market because phenobarbital was better. So it's not even around anymore. But I saw somewhere, somebody's using it for something. So maybe it's starting to come back. Anyway, phenobarbital is the longest acting barbiturates. All right. The drug of choice for generalized seizures in children. Now remember, long acting, we usually stay away from children, right? But why did we settle on this one for children? Because when we tried all the anti-seizure medications, all of them blocked their development. They block folate somehow. And so the mental deficits for these children was great with all of them. This one only brought the IQ point down by 1 point. That's why they said, okay, let's settle and use this one. But valproic acid, carbamazepine, all of them, nope, hurt their IQs. And so that's why we don't use those. All right, so phenobarbital, drug of choice for generalized seizures in children. Thiopentol, shortest acting. Used primarily for anesthesia. Again, to calm the patient down, to let the anesthesia have effect. But it wears off in like 5-10 minutes max. Thiopentol. Next one, amobarbital, nothing unique about that one. Next one, secobarbital, that's for streets. Most abused on the streets. This is the one they call the downers. Excuse me? Downers, I mean, bring you down. Yeah. Like if some addict on the street is high on cocaine, he would take this to bring himself back down. Yeah, that's just a nickname for it, downers. All right, overdose of barbiturates, just like any other drug. Remember, 9 out of 10 drugs, or what kind of drugs, Bailey? Weak acid, see? I just want to make sure everybody's seeing, so that you don't have to highlight it, it's the same old stuff. Anytime you don't know, go right back to fluids and bicarb. Remember that. You'll be right over 90% of the time. Okay? And then we use a drug called doxapram to stimulate their breathing. Remember, we use barbiturates for medical coma. These drugs can put you into a coma. So it made sense to me why we had an extra drug to get you to start breathing, because the drug would knock the patient out for hours if you just left them alone. So we use doxapram to kind of wake them up a little quicker. And Gabriel, you had a question?
Yeah, I actually had a quick question in terms of like
Sure.
Weak acids being the majority of drugs that we give, and also dealing
Okay.
with overdoses.
Okay.
So in terms of, I remember that we've discussed like, or I've heard like acidifying or basifying the urine,
Right.
to be able to increase excretion of drugs that are processed by the kidneys. Would
Correct.
that be would this be a situation in which we would be able to do that? Or I guess like
Yeah,
we would.
that's why you get
Okay.
bicarb. The bicarb will
that's-
keep it
that makes
charged in the blood so that it goes straight to the kidney, and then the bicarb will leak out to the urine to keep
Okay.
it going right out.
Thank
fully
you.
charged.
Perfect.
Yeah,
That
see,
sounds-
now-
that makes
see how it
sense.
all makes sense now? Exactly.
you.
Yeah, instead of books that say acidified urine, or sorry, alkalize the urine. They don't
Yep,
tell you it's just an
makes
extension of the same thing. Just give bicarb. And that bicarb will eventually end up in the urine. Yeah, and that way the drug stays charged all the way through. All right, that's barbiturates. And then alcohol, we already talked about. All right, benzos, barbiturates, alcohol, opiates. Again, all of them are seen as depressants. They will slow you down. Most common cause of death, while toxic respiratory failure. Again, this is all a reminder of everything you learned earlier. I try to put everything in the notes for you. That way you can, as you read your notes, you see the things constantly over and over again. Withdrawal of these drugs will cause things to speed up. Most common cause of death, then will be cardiac due to arrhythmias. Because the word arrhythmias means increased activity of your heart. Alcohol withdrawal leads to formication. Remember, sensation of insects crawling underneath the skin. Alcohol withdrawal is #1 cause of that. And then cocaine intoxication is #2 cause of that. And then I'll get to you in a minute, Bryce. Let me finish this miscellaneous stuff. These are miscellaneous drugs which also enhance GABA, but they're not in the family of benzos or barbiturates. Which means they all still do the same thing. So there's nothing new to learn about them, except the clue. That's all I need to know. All right, Zolpidem. Ambien, 4-hour half-life. All right, but it causes significant sleepwalking. A lot of what is it? People in Hollywood, what do you call them? No, what do you call them collectively? Celebrities, thank you. You know, sometimes the word just escapes you. I just can't come up with it. Yeah, a lot of celebrities have taken Zolpidem and caught sleepwalking blocks from their homes. I remember, what's the name? Jay-Z was on this. Beyonce was on. Oh my God! Another one was caught near a cliff. Imagine she would walk right off the cliff. Luckily, most of them don't live near a cliff, or they would walk right off. But I've heard it on CNN so many times. You know, it took this, and they were just sleepwalking blocks away from home. Anyway, that's Zolpidem. Zopiclone, nothing unique about that one. These are just short acting for insomnia. That's about the only time we use them, huh? Yeah, that's Lunesta, exactly. They call them the Z drugs because you use them just for sleeplessness. 4-hour half-life, so it wears off quickly, no addiction potential. All right, topiramate is used prophylactically for migraine headaches and for procedures. Okay. I haven't seen it use weight loss yet. And they're putting Topamax what?
Combine 2 drugs into one.
For weight loss?
Yeah.
Oh, wow, I haven't heard about that one.
Decreases the hunger drive.
Which makes sense. It's still enhancing GABA. Yeah, that makes sense. Yeah, I didn't hear about that one. All right, so they're using it for some weight loss along with some other drug combination.
What's that normal one? Adifex?
Phentermine? Yeah, phentermine. Oh, they got a combination drug. I didn't know that. Okay, thank you. All right, so anyway, so those are the main clues for topiramate. Propofol. Here's how they like to ask about propofol. Propofol is fat soluble. You expect it to be long or short acting, Abigail says. Long acting, but only lasts for about 10 minutes, which doesn't fit now, does it? All right, so that's why they like to ask that question. If propofol is fat soluble, how come it only lasts for 10 minutes? Anytime you're asked that question, because this is not the only drug, topiramate can do that. Lidocaine for antiarrhythmic does that. Like lidocaine, I actually looked up one day, 51-hour half-life, but it only lasts like 6 minutes in the blood. Anytime you're asked about that, it's called redistribution. I mean, it is so fat soluble, it goes into all the cells nearby. That means it's not staying here to block the sodium channels where I need it. Yeah, so it doesn't mean the drug has character that's changed, but you need to know the right word that fits fat solubility when they ask you that. Why does it wear off so fast? It's called redistribution, not metabolism. They always put that as answer A. All right, anyway, that's propofol. Spiral short acting because it redistributes so fast. Gabapentin, you can tell GABA enhances GABA, but it also blocks sodium channels in the presynaptic terminal. So you're blocking neurotransmitter release. Remember, presynaptic sodium presynaptic calcium influx, calcium channels, not sodium channels. Gabapentin blocks presynaptic calcium channels. Therefore, you're blocking a release of neurotransmitter. If you remember, gabapentin is a drug of choice for neuropathy when you have a heart disease. You don't want the sympathetic tone of TCAs. And then pregabalin, same thing, Lyrica. All right, now questions. All right, Bryce, you're first.
Yeah, my question is regarding doxapram. I did not get exactly what you said about that.
Yeah, doxapram is a drug that stimulates your breathing centers in the pons. It wakes you up. Because remember, benzos can put you into a coma.
Yes.
Which means we would have to wait like 18 hours for the person to start breathing on their own. Or give them a little doxapram to stimulate their breathing so they wake up faster.
Okay, thank you.
All right, Mabel, you're next.
Can I see the last slide? When you said, talk about benzo and the alcohol, the benzo and the other one. The last slide,
You mean
please.
about the actions? Yeah, this is
Yeah,
just
the-
repetition of the stuff we were talking about earlier.
Okay, I'm good. I'm fine,
Yeah.
sir. I just got some.
Okay.
I'm fine. Yeah.
Yeah, no problem. Okay. All right. Now finally, oh, sorry, Leslie, you get the last one.
Yes, doctor, I heard like in one vignette that they use pregabalin for fibromyalgia.
Yeah, pregabalin for fibromyalgia. Yes, it does work.
What's the mechanism of action like?
The mechanism is this: anytime you have a disease that causes anxiety, remember people with fibromyalgia have a lot of anxiety because it hurts just to even move. So they always think about, oh my God, I'm gonna be in pain if I have to walk to the bathroom. So anything that has anxiety, you can treat it one of two ways. Either you enhance my serotonin, the serotonin will mitigate my perception of anxiety. Why do you think SSRIs are used for every anxiety disorder in the book? See that, I read that, this is only a few years ago, I learned that. I said, damn, why is SSRI being used for all these diseases? See, again, you have to be curious enough to go look it up. Okay, because nobody told me I had to go read the assignment, but I said, SSRI is a stimulus, I don't get it. People are, anxious, it sounds like too much activity. Why are we using something that causes more activity? Well, I find out serotonin actually suppresses your perception of anxiety. And then all the indications for SSRI suddenly make sense to me. See, this is what I mean. Once you understand this stuff I'm going to teach you, it's going to save you a ton of reading because you can see the connection. So anyway, two ways to handle anxiety. Either increase my power to ignore it as serotonin, or GABA, which can ignore anything. And that's how gabapentin work. Yeah.
Okay, thanks. And the other question is like, it's a little behind, but like I was doing a question from acute intermittent porphyria. And
Okay.
one of the things that they said on the answer explanation, it was that the pain is when they have severe abdominal pain, they don't have tenderness because it's neuropathy.
Right.
So that's a good clue to rule
Yeah,
out.
that's a good clue, right? They have abdominal discomfort, but when you push on it, there's absolutely no pain. That means they also have the neuropathy that goes with it. Remember, recurrent abdominal pain and neuropathy. Yeah, so they may not say they feel anything, they just don't feel good. But when you push on the abdomen, nothing. Yeah, so that could be a good clue too. All right, opiates. The group that started our discussion. Heroin, most abused on the streets. Heroin, most abused on the streets. Methadone, longer acting, Melissa, longer acting. Because they love to ask you, what is the characteristic that allows you to use it to withdraw from heroin? It's longer acting. Because it's longer acting, allows you to come down slowly. That way it's not a precipitous drop. All the stuff that's sold on the streets are short acting. That way you get a short high, a short slam back down to the ground. Guess what? You now have a craving to go get some more. Yeah, all the, crack cocaine, short acting. Ice, which is an even shorter version of cocaine, short acting. They just keep making it shorter and shorter. That way you get addicted very quickly. Okay, quick up, quick down. you have a craving. So heroin, methadone is used to withdraw from heroin because of the long-acting nature of that drug. Okay? And that's why it's used as an outpatient. You have to be hospitalized for it. Morphine, used for severe pain, inpatient or outpatient, doesn't matter. Morphine, used for severe pain. Meperidine has 4 good clues. Number 1, is the only opiate without pinpoint pupils. Yep. The only opiate without pinpoint pupils. Number 2, most abused by physicians. Why? Because you can't tell they're high.
Like doctors take this?
Doctors, isn't it? It goes on this stuff, you can't tell they're higher because there's no pinpoint pupils. Little story, I had one time I was on call, I think I was second or third year resident, and there was this one young anesthesiologist. You know, this guy was maybe like 24, 20, he's really young. Handsome as all hell. Even as a man, I could say, damn, that guy looks good, man. But I mean, when he walks down the hallway, the nurses were just that's how handsome he was. But anyway, one night I was on call and somebody tripped the emergency cord in the toilet. When that goes off, we got to go get them out because you don't know if they passed out, bumped their head, they're bleeding, we don't know. And I was the one on call, so I get there and push on the door. So somebody's pushing back at the door. This doesn't make any sense. So I had to push hard till I finally opened the door. It was him. He was shooting up methadone. I mean, Meperidine. I was in shock. I said, dude, you could have any nurse in this damn building you want. You're one of the most handsome guys I've ever seen. And it's young and brilliant. You're an anesthesiologist already. And this is how you kill your career? Because now he has to be hospitalized. Anyway, when a doctor's caught with drugs like that, yeah, the medical officer has to talk to him. They give him a chance to go to rehab before they report it to the state. So they'll get reported right away. You have to go to rehab. But if he does not go to rehab or fails the rehab, immediately report to the state, you're screwed. That's it, your career is over. Because no insurance company will pick you up. Because they're afraid they're gonna get sued for every case you're in on now. There's any mistake made, they're gonna blame it on him. I mean, but I was devastated, man. I said, your career is over, you're a young guy. Think about all the years it took him to work to this point, and that's it. Shooting up, man, I was like, wow, okay. Anyway, the other clues. Blocks your uptake of catecholamines, which is what dilates the people's back to normal size. Blocks your uptake of catecholamines, like TCAs or cocaine. And then the last clue, remember, drug of choice for abdominal pain, because it doesn't contract the sphincter of OD. So Meperidine has 4 good clues that they'll test you on. Codone, excuse me? What do you mean? Meperidine is a drug of choice for abdominal pain. Yeah, until you figure out what's going on, because it won't contract the sphincter of OD. That means gallstones are free to pass. All right, codone and oxycodone, moderate pain. It's Vicodin and Oxycontin. So moderate pain, outpatient, they're oral pills. Both of them are heavily sold in high schools. Huh? Oh yeah, it is sad. But you know, there's always that one drug dealer everybody knows about. Cool guy, got a nice car, got nice clothes, but he's selling all this stuff. $5 a pill. Makes a lot of money. Yes. 4 things from Meperidine was number 1, does not contract the sphincter of OD, so the drug of choice for abdominal pain. Number 2, blocks the uptake of catecholamines. This is what dilates the people's back to normal. Number 3, most abused by physicians, right? And, oh, the only one without pinpoint pupils. Yeah, no problem. Codeine, mild pain, outpatient, right? Tylenol with codeine for sprained ankles, fractures, that kind of thing. Codeine, mild pain. So morphine for severe pain, codone and oxycodone for moderate, and then codeine for mild pain. Dextromethorphan is the #1 antitussive, cough suppressant in America. The DM on every co-medicine, Robitussin DM, Dimetapp DM, all that. And the DM is dextromethorphan. Second clue, most abused by rappers. Lil Wayne started that crap, man. You know, when I first saw Lil Wayne, that persona of his, I thought it was just that, just a persona. He was just putting on a show, you know, that's how he makes his money. And I said, man, that man looks high all the time. I said, I didn't know he was high all the time that I saw him. And of course, then he came out and said, yeah, he mixes dextromethorphan with Thorazine, some Sprite, and some Benadryl.
Oh, lean, right?
Yeah, or whatever, lean, scissor. I mean, he has his own name. But he was rapping about it, and all of a sudden it became popular. Because it's all over the counter. All over the counter stuff. It makes you high as hell. That's why he's been in and out of jail. Because every now and then they catch him. Okay? Because I said, this guy, if he openly says he's high on this stuff, how come they never catch him? Well, every now and then they actually catch him taking it, and then boom, he's in jail again. In and out.
The huge epidemic in the South.
Oh, really? Epidemic?
Yeah, I mean, everybody's on it.
Holy cow. Big epidemic in Texas, that's what I'm hearing. Wow. Loperamide, difenoxylate. Best antidiarrheals for travel. Especially if you're going to the Amazon or Africa or South Asia, where if you catch dysentery, you ain't making it back. I'm serious. All right. So luckily, when I go to Nigeria, I go to my village, but we're still near a town if I have to go get IV fluids or something like that. But when you're going to somebody even deeper in the jungle, you better take some loperamide with you. Because if you get dysentery, you have diarrhea so bad, you can't even make it back to your village, let alone to the clinic. All right. That's what those drugs are for. So when anthropologists are digging up, they don't even know what they're gonna run into, they have it. When somebody's traveling, all these missionaries in the deep jungle, they have it. Okay, so for severe diarrhea, yes, sir.
Will it help with color?
Huh?
Will it help?
Will it help with color? Yeah, it'll help. Because this thing will paralyze your GI tract. That's what saves your life. Yeah. Oh, Mabel, did you have a question?
Yes, I wanted to ask you the dextromethorphan.
Yeah, dextromethorphan.
Yes. What's
Go
it
ahead.
for, sir? What's it for?
Oh, it's the #1 antitussive. That means cough suppressant.
Okay, it stops cough, right? Okay.
Cough suppressant. So antitussive is the word we use.
Okay, so it didn't say anything about oxycodone.
No, I did. I said codone and oxycodone are for moderate pain, outpatients,
Okay, thank you.
and then abused in high schools. Yeah. Now, the bad side of this stuff. I remember when I was in Peoria, there were 3 physicians, me and 2 other guys, who remained independent of the HMO. Almost everybody sold their practice HMO. I always believed in being independent, doing what I felt was best for my patient. They didn't care, you know, so I remained independent. Now, years later, I went back to town and there was one guy who was an OB who was also independent. His name was Robert. And we had another friend together who owned a little cafe. So I went to his cafe to have some lunch. And I just happened to ask, hey, have you seen Robert? He said, oh, Dr. Franz, I tried to tell him don't do that. I said, what do you mean? Tried to tell him what? He said, Dr. Franz, I would see drug dealers coming in this building and walking right back out. And I knew they were going up to Robert's office. I said, what? Anyway, he got involved in this crap. There's a lot of doctors who've been busted. They would write prescriptions for drug dealers. Drug dealer would fill it, sell it on the streets, and then give him its cut. Now, he's an anesthesiologist. No, he was OB-GYN. This guy owned a farm, horses, houses, all that stuff, right? And then the FBI got him. They always wait till they got enough evidence, then they shut you down. And I was shocked. I said, you talking about Robert, the same friend you like? He said, yeah. He's living just outside of town in a little trailer house. They took his license, they took everything he owned. His farms, his homes, everything was taken away from him. And they said it was drug money. I was shocked. I could not believe somebody I knew was involved in this crap, man. So please, folks, watch out the friends you hang out with, because if they get involved in something, you better get away from them. Yeah, because they'll take you down real fast.
A couple months back in Michigan, about $15.
Yeah, I'm hearing on CNN all the time. They always watch how doctors are prescribing. And when they see too many opiate prescriptions coming out of one doctor's office, FBI is at your door, or DEA, they're at you. you know, and you gotta justify every one of those prescriptions. If they find one that doesn't match, you're in trouble. You're now labeled a dealer. Yeah, you know, so, I mean, because I had another buddy, he's my best friend, and but he does pain management, anesthesiology do pain management. They were at his door thinking, hey, wait a minute, you prescribing too much opiate. Yeah, but he produced all the charts and said, yeah, these people on it for blank and blank and blank. And that was it. DEA is gone afterwards. That's it. Their job is to verify things, you know, but he was upset that they came to his door. I said, dude, as long as you got everything documented, you got nothing to worry about. He was just getting frustrated, always, you know, worried about this DEA stuff. I said, DEA doesn't say you cannot prescribe opiates. You just got to make sure you got it charted and it's justified. That's it. The guys who get busted on CNN are the ones who just, they talk to you on the phone and give you 60-day supply. They haven't even touched you yet. I mean, come on, they forgot. FBI taps the damn wires and they say, wait a minute, you didn't even see the guy. How'd you get a prescription? And then when they get enough evidence, they take you down. And then they lose everything. So whatever it is they thought they were making off the drugs, hell, they're gonna lose way more than that. So FBI takes everything away from you, okay? All right, anyway, let's finish these. Fentanyl, most potent. Yeah, you guys ever hear about this fentanyl on the streets, right? This is the most dangerous thing I've ever seen, man. This fentanyl is so dangerous. I remember one cop, there was a heroin addict who didn't even know they got into fentanyl. You know, they find like 80 to 90 bodies of people who overdose on fentanyl almost every day. Yeah, around the country. It's amazing. Fentanyl coming out of China. They finally traced it all the way back to China. This is the most potent fentanyl I've ever seen before. All right, but here was a case in point. A policeman, first responder, the guy on the ground, they're just trying to get him up for, put him into the ambulance. And his hand touched a little bit of powder that was on the guy's shirt. He absorbed enough of it and passed right out, right there on the street. It took 10 naloxone injections to wake him up. Gives you an idea how strong. This is just a little bit of dust on his finger. 10 naloxone injections. Remember, that's why they started making it illegal for cops to carry naloxone with them. Because when that one hit the lip, they said, holy cow, this is some rough stuff out there. And so they have to protect. So now firemen are carrying it, policemen are carrying it, all that, because they got to protect themselves, you know? And in the ER, well, they got plenty of naloxone, but if you actually even touch the dust on somebody's shirt, and oh, that's it, you're out. It gets absorbed so fast. I mean, this is a very fat xylem, right through the skin. Yeah, it's rough stuff. Yes, sir. Cesar. A lot of singers. Oh yeah, Percocet, yeah, oxycodone. Yeah. 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 That's what's happening. The drug dealers are sneaking fentanyl into other pills. This is why you tell teenagers don't try drugs at all. They always think you're trying to deny them some experience that they gotta have. They have no idea what they're getting into. This is what I mean when we're in the ER, folks, and these teenage bodies roll in, you're like, okay, what the hell did he get into? Because now with this fentanyl, most of them die right in the ER. Because it's so potent, we can't seem to wake them up. I mean, think of the cop, just a little bit of dust on his finger. It took 10 Narcans to get him to wake up. And here's a teenager, he took a whole bunch of it because he smoked it or he ate it, whatever they gave him, and he's out. I don't care how much Narcan you give him, he ain't waking up. It's sad, folks. 80 to 90 bodies dead every day. All right. Oh, you see.
I
You have a question for me?
I think you might answer it later on, but I was just
Sure.
wondering why we don't develop any sort of resistance or tolerance to Narcan, even if it's a receptor antagonist. Like, does it not dull our response or anything?
Well, remember, you only develop tolerance to a drug if you're exposed to it all the time. We're not taking Narcan all the time, so that's why you're not going to have tolerance. You only
So
take it
in the
when you-
case, sorry.
Yeah, go ahead.
So in the case of the police officer that needed 10 Narcan shots to come back from the fentanyl,
Right.
like, I guess I'm just wondering, do you have to wait a certain amount of time before each injection? How do you know when
Oh,
to
no,
stop or
they have to
anything
give
like
the
that?
injections back to back to back. Narcan works almost immediately. You give somebody Narcan, within seconds, they start waking up. This one, you know, they gave the policeman Narcan, you know, it's like 10, 15, 20 seconds, nothing. He's not even moving. They just gave him another one. And they have to do that 10 times for him to finally start moving around and start coming back. I mean, that was devastating when I read that. I was like, holy God, I had no idea it was that strong. Anyway, that's life on the streets now. All right, Leslie.
Yeah, hi, doctor. I have a question because some of us miss the diphenhydroxylate clue.
Diphenhydroxylate?
Yes.
I said loperamide and diphenhydroxylate are used for severe diarrhea in traveling.
Okay.
That's what I said, if you're going to the jungle or you're going to the Amazon or deep in the bush, yeah, you better make sure you take some of these with you. Because if you get dysentery, you know, salmonella dysentery, shigella dysentery, any of those strains, it will kill you.
Okay,
Yeah.
and I also have something to say about when you all talk about mixing drugs. It's very curious that in Puerto Rico is the only place that in the streets they mix heroin with horse anesthesia.
You're kidding me.
No, it's true.
Heroin
And
mixed with
there's
horse
a-
anesthesia drugs.
there's a documentary about it, and they get like gangrene on the skin, and it's all over like the drug abusers in the streets. Would they meet, like, if you go to YouTube and put like a documentary of drugs in Puerto Rico, they explain that this is the only place that they mix with horse anesthesia.
Wow. That's just people looking for a new high all the time. That's what I'm saying, it's mostly teenagers. Teenagers love experimenting with anything, just to see if there's a high from it. It's crazy stuff, man, but that's the life, that's the world we live in. Victoria.
Hi, yeah, so with fentanyl, I know they give like the fentanyl like lollipops, don't they, for pain relief?
Yeah, there's lollipop form. Yes.
What is like the difference between that and the tiny bit of powder that knocks the cop unconscious?
No, when it is given as a lollipop, it's a very, very low dose. We use it in children just to get them sedated. Yeah, to do a procedure or something. But it's low dose, like micrograms, not like milligrams on the streets. Ooh, no, this is some stuff that I've never seen before in my life. All right, let me just finish this. Pentazocin is a partial agonist, a partial antagonist. So they say do not use it in an addict because you might cause withdrawal that could kill them. Pentazocin, partial agonist, partial antagonist. Do not use in an addict because you may cause withdrawal that could be deadly. Buprenorphine is a partial agonist. So you only get a partial high. So it's also used to withdraw from heroin. See that? Either use long acting to let the person come down slowly, or use a drug that's half the high, so you only get half the high, and then you slowly wean it off, and the dude's fine. And so buprenorphine is usually put with naloxone, which are called Suboxone combination. I got a buddy here in town who does addiction medicine. Okay, and that's the one he likes to use, but other places like methadone clinics. And then nothing unique about apomorphine. Oh, methadone now is available for babies to help them withdraw from mommy's heroin. Yeah, they finally made one that you give to babies. It's a little paste, methadone. Forgot to add that in there. Methadone is now available. It's just come out in the last couple of years, probably a little more than that, but you can just a little paste. You just put it in their lips. That way they can just eat it down, drink it down. But you hate to see these children go through such severe withdrawal symptoms, man. It's so sad.
The shrieking cry.
Oh yeah, high pitched cry. I mean, you feel so sorry for the kid because it's not his fault. Oh yeah, they're in pain. I mean, yeah, when you go through withdrawal, your whole body hurts. Yeah. All right, moving on. Opiate overdose. Naloxone is given IV or IM. Now, Naltrexone is given orally. Adam, which one is fat soluble?
Obviously, naloxone.
How do you know naloxone is fat soluble?
Route of administration is going through the muscle.
No, I want you to tell me based on what I just said. Naloxone is given IV or IM, and naltrexone is given orally. Which one is fat soluble?
Naltrexone, sorry.
Why? Why naltrexone?
Get absorbed in the gut.
Yeah, if you gotta go by mouth, you gotta go through a thick intestinal wall. All right, come on, you better be fat soluble. All right, because I've seen that question. That's what I'm telling you. You have enough information to figure these things out now. All right, once you know which one's fat soluble, then you can ask hepatitis, myositis. You can figure out all the side effects without my saying a word. All right, naloxone is water soluble. That's why you just deliver right into the tissue. That way you don't have too many memories to cross. Okay. Methyl-naltrexone, they put a methyl group on naltrexone so it cannot get into the brain. That way it works only in the periphery. So it's used to block receptors out in the periphery. We use it for opiate-induced constipation, OIC. Just so you know, the methyl group was added so it cannot cross the blood-brain barrier anymore. All right, Mabel, do you have another question?
I didn't get it from fentanyl down. I didn't get the explanation you gave. What you explained
Which one?
from fentanyl down.
Okay. Pentazocin. I said is a partial agonist and partial antagonist. You got that?
I didn't get it from fentanyl, sir. From fentanyl down.
I just said pentazocin. Did you catch that? Huh?
I said from fentanyl. Yeah.
Oh, fentanyl is the most potent, very deadly. That's all you need to know for that one. Remember, we just went through a bunch of stories, people overdosing every day on this stuff on the streets, coming in out of China. And then pentazocin is partial agonist, partial antagonist. So do not use an addict because you may cause withdrawal. And then buprenorphine is a partial agonist only. So it's used to withdraw from heroin because you can only get half the high. And we usually couple it with naltrexone, or rather naloxone, so that way you block it and it slowly the person withdraws slowly. And then apomorphine, nothing unique there. All right, Gabriel, you have a question?
Actually, I kind of forgot the question, so don't worry. If I remember, I'll raise my hand again.
All right, no problem. Muhammad Khan, you got a question?
Yes, I just want to know what drug do they use for nerve block?
For nerve block? There's
Yeah.
lots of drugs. We usually use anesthetic drugs though, not opiates.
Oh, okay.
Yeah. And that's usually like lidocaine, novocaine, tetracaine, there's a bunch of. All right, but that's different class. All right, moving on. Opiate overdose, again, naloxone, IVIM, naltrexone orally, and then methyl naltrexone for opiate-induced constipation. And now into hemoglobinopathies. Gabriel, do you have a question?
Yeah, I remember the question.
Okay,
In
what was
terms
it?
of like, so using loperamide and diphenoxylate for antidiarrheals, do you ever have a use case for it in terms of like pain control and pain management, or only antidiarrheals?
Yeah, we only use it for antidiarrheals.
Okay.
Yeah, it's a very small dose, only made so it can sedate your GI tract, so you don't die from dehydration.
Okay, that makes sense. Thank you.
They're abusing this too.
I know. What's that?
No, they're abusing this too.
But they're starting to abuse that too now.
So they come in, they said I have diarrhea for 3 weeks. They're like, can I get some loperamide? I'm like, are you kidding me? I'm like, putting everything on.
Holy cow, there's abuse all over the place, man. I didn't know they were abusing that one too now. Oh my God, we only use that probably for traveling. If somebody's gonna travel to Africa or Asia or something. All right, hemoglobinopathies, S and C disease. Here's what you need to know, Paul, about S disease. First of all, it's autosomal recessive. Second, there's a high prevalence in Africa. That's called natural selection. When a mutation saves you from a more lethal mutation, natural selection keeps it around. The point is, sickle cell anemia keeps Africans safe from malaria. Because every time you lyse a red blood cell, the malaria that's in there will die with it. And that's how you keep your malaria counts low. So it has an advantage. The substitution is the number one thing they ask. Valine for glutamate and position 6 of beta chain. You gotta know that. Hypoxia is the number one cause of sickle crises, leading to vaso occlusion. And the number one cause of that hypoxia is an infection. So Kathleen, where do you think you would find an infection in a sickle cell patient? Where's the most likely places to find an infection in a sickle cell patient? Where? The lungs or? Where? Urinary tract. Does that sound familiar to anybody? Good. Kathleen, can I tell you? They want to know who you are when you get back there. See my point? When you know these connections, you don't have to think for that long. You just say, oh yeah, Bob Campbell, Lord, just say, oh, pulmonary UTIs. See? In and out in 2 seconds, you still got it right. And yet you haven't looked it up or read about it before. Okay? Concepts don't change, they just got new names all the time. All right, so hypoxia is the most common cause of sickle crisis. That's why we want them to have oxygen at all times. Okay? And that's why we try to induce hemoglobin F, remember hydroxyurea? That way F keeps oxygen in the blood at all times. Therefore, you're less likely to sickle. Zena, question.
So there are UTIs and pulmonary infections.
UTIs and pulmonary infections, those are the first 2 places infected in anybody. It doesn't matter if you have sickle cell. But they love to ask that question as if it's about sickle cell. That's why I keep trying to make this case to the students. Think simple. Stop thinking about the disease that they talked about. That's how they know they got you. You're thinking with details. And there's a concept that answers 9 out of 10. Use that one. That way you're gonna be right almost every time. Okay? All right, anyway, let's see, we go S disease. Sickle cell, see that? When they sickle, it clog up your vessels, which means I can summarize everything that happens in sickle cell anemia with the term vasoocclusion. See? And therefore, if you're asked what's the most common cause of death in sickle cell anemia, Bailey would say? Heart what? Heart failure, sounds good. Due to all these heart attacks that they've had, vasoocclusion. See? Why they get osteomyelitis? Ischemia to the bone. See? Anything they ask, I just think about vasoocclusion, I can then explain it. Okay? And that's the way I want you to think it through. All right, vaso-occlusive crises. Notice the brain is always at the top of the list. Can't forget that. CVA. Pulmonary infarct. They can infarct the entire lung. Clog up pulmonary artery. Now there's no blood goes in that lung. Splenic sequestration. They can vaso-occlude the splenic vein. So that blood comes to the spleen and can't leave. And you could die of shock. Okay? In fact, under the age of 4, if they ask you about the spleen in a sickle cell patient, it's usually enlarged because of splenic sequestration. From age 6 on, it's usually shrunken from too many infarcts. The age tells me which one they want. One more time, under age 4, if they question, okay, is that Mabel again? Mabel, your mic is still on again.
Oh, I'm sorry.
Okay, watch that mic. So anyway, now I forgot what it was, splenic sequestration. Yeah, so the age will tell me which answer they want. So if they ask me about the spleen, I've seen that, I think, twice now. They ask you about the spleen. Watch the age. If the child is under age 4, you pick enlarged spleen. They know that most students are going to pick, oh, my grandfather. That's what everybody talks about as the autosplenectomy. But they don't tell you under age 4, you're not going to see autosplenectomy. You're going to see an enlarged spleen. Okay, so watch the age before you answer. And then priapism. Poor guys get the erection, blood goes into the penis. That's where erection is. And then it won't come out because a clot forms. Now you have a painful erection. Priapism. The worst day of your life. So what do you do for this guy? You give him a bullet, bite on this, son. Just hold on. You know, what we do is, you can actually look at the penis, because it's very rigid, and you can see a bump on the vein with the clot in it. You can actually see it. As I say, you sedate them, because they know about it, it's gonna hurt. It hurts me to have to do the damn procedure. All right, but you put the needle just proximal to that bump, the clot, and aspirate real fast, the clot will come flying out in the needle. And he will be so happy. If that does not work, you stick the needle into the cavernous, bulbous cavernous, or whatever that structure is called, is engorge your blood. And suck blood out till the erection goes down. That way they feel at least comfortable. Okay, if that doesn't work, then you inject them with epinephrine, which will vasoconstrict, and it'll go down automatically. Okay, so management of priapism. Anyway, for any one of these, what do we do for sickle cell patients? Now, remember, I'm talking about sickle cell patients. Oxygen first. Remember, hypoxia causes crisis, right? So you don't forget that. Oxygen first before anything else. And then exchange transfusion. In exchange transfusion, Josh, what I'm going to do is transfuse you with a bunch of blood so that it goes throughout your whole body. And anywhere there's a sickle cell, I always got to make sure I'm still in the picture when I do these things. So wherever you have a sickle cell, as soon as blood touches it like this, watch what happens. Blood touches it, it takes its normal shape, wiggles right out. So exchange transfusion cleans out all your vessels with one procedure. So whenever somebody has one of these four things, we say just clean out their whole body. Exchange transfusion is best. Okay. All right, so oxygen is first. Obviously, give them some fluids. What fluid do you want to use, Zena? No, I said, what fluid do you want to use, Zena? Just name the fluid. All of them are called saline. Don't say just say saline. Maria will help you on this one. Best just use normal saline for this. Yeah, they're not really acidotic at this point. Yeah. All right, yeah, so we give them oxygen, followed by normal saline, and then do the exchange transfusion. Because it takes time to get all the blood and everything together. You can't not give them fluids. They need fluids to flush some of that stuff out too. All right, aplastic crisis. Well, honestly, because we're always worried about this, aplastic crisis is when your bone marrow shuts down. Why? Because they have infarcted their bone marrow too. So they always say, check their reticulocyte count every time they come in. If you remember, reticulocyte count, Paul, tells you whether the bone marrow is working or not. Normal is 1%. So the test cells give you 0.2%. You got to know that ain't enough. That bone marrow is gone. Okay? Normally, Austin, if you lose your bone marrow, what organ takes over erythropoiesis for you? The spleen. Except they don't have a spleen. And that's why they always test you on this, because if you forget and send them home, you literally send them home to die. They don't have a spleen. Which means anemia is going to get worse. So they're going to heart failure at home. And they may not make it back to the ER. Okay? So we always check reticulocyte count. That's the way that I remember that my hematologist trained us, and I never forgot it. She made that a strong point. Before you call me, I better have a reticulocyte count. Because that's the first question I'm going to ask you. Because if that bone marrow is shut down, that person is transfusion dependent for the rest of their lives now. That's a whole different situation. Okay? All right, parvovirus B19 is the most notorious for wiping out people's bone marrow. A few points to remember about sickle cell anemia. Functional asplenia by age 6 due to infarcts, like I just explained. That means now you're susceptible to encapsulated organisms. The most common encapsulated organism in society, Miguel, is what? Strep pneumonia. So that's why that's the one you're going to pick. It's not that's the only vaccine we have. Remember, we have H influenza B and Neisseria meningitis. But on a test, you ain't get no points for those two. This is the one I expect you to pick. You have to make sure to get it. And what do we do now? You give them Prevnar 20. You start with Prevnar 20. Prevnar is superior to Pneumovax. We don't use Pneumovax anymore. So it's Prevnar 20, and within 6 months, hit it with Pneumovax. That's for the last 3 strains, just so you know why we're still doing it.
PPSV 13.
Yeah. Yeah. Now, PPSV 13 is now going to PPSV 20. It's the same company. They're trying to get up to 23 so we can just get rid of Pneumovax altogether. Yeah, they're doing a very good job. From all the literature I'm reading about their stuff, their vaccines, 98, 99% protective. Like people who make Pneumovax, they've had almost, 30 years to fix it? They never fixed it. Well, this company came along and said, we'll fix it. And now they're knocking them right off the market. Billions of dollars that company's about to lose. All right, anyway, functional asplenia. Infections are the most common reason for crisis, like I already explained. Hydroxyurea increases hemoglobin F, which leaves oxygen in the blood at all times, and therefore decreases the risk of sickling. Use opiates for their pain, because their pain is severe, folks. Don't be giving them no aspirin and NSAIDs. hit them with the opiates. Let's say you say, well, Dr. Francis, do we need to give opiates to all of them? Yeah. Okay, fine, let me make my case. If you're in pain, let's try Maria. If you're experiencing severe pain, you're now stressed out, are you not? What's the number one stress hormone in your body? Say it. Cortisol. See, I got to pump it out of here like cortisol. See, but you had that thought 10 minutes ago. All right, so anyway, cortisol. Cortisol, if you remember, destroys T cells, eosinophils. You're making your patient immunocompromised. Most doctors don't even think about that. If you leave your patient in a lot of pain, you're immunocompromising your own patient. The best place to pick up germs is the hospital. And so you increase their death rate, folks. There's literature to show you. Okay, doctors always worried that somebody's gonna get addicted. Folks, there's literature about that too. Okay, if somebody has a reason to have pain, the addiction rate is 1%. Are you really gonna let 99% of people suffer for the one person who might get addicted? That's not how we practice medicine. I always told you that. All right, that's me. We're gonna treat everybody and create one addict out of 100.
Can you repeat that?
Yeah, if somebody has a reason to have pain and you give them opiates, addiction rate is 1%. There's literature, all kinds of studies done about that. Again, I was interested in stuff like that because doctors always saying, well, I don't want to give them that, everybody get addicted. Well, some people did some research on it. Well, what's the chance you actually get addicted when you have a reason to be in pain and you just want pain relief? It was 1%. So I'm just saying that in case you ever have to pull that literature to show you're attending. You may be one of those guys who's afraid of any opiate being given to anybody. That's cruel, folks. You're gonna let 99% of people suffer for the one person who might become an addict. That doesn't make sense in medicine. That'll get you in big trouble. Yes, sir.
What about relapse?
What about relapse?
I mean,
If somebody's an addict already, good question, sir. So his question is, if somebody's an addict, how do you treat that person? Here's what you do. You try to give them something equivalent to opiates, but not an opiate. We got a drug for that. That's Toradol, exactly, which is an NSAID with the potency of morphine. Because, ketorolac, because it's unethical. We hold good pain medication for somebody who's an addict. That means you're punishing them for the addiction. You cannot do that. That's unethical. You get you sued real quickly. However, let's say you tried a ketorolac and it didn't work. Next step, talk with the patient and say, I have to use morphine. I hate to see you in a lot of pain, Ms. Smith, and I know you were addicted before and you did a good job of going through rehab, and I hated to come down to this. However, you're still in a lot of pain, and I'm afraid it's leaving you susceptible. You might pick up infections while you're here. So I'm forced to use morphine. So if the cravings start to come back, please let me know. We can get you back in that rehab program and get you off of it again. That's what the studies say to do. Discuss with the patient that you have to use the morphine, but you cannot deny them of that opiate because you say, oh, they were an addict. That's a lawsuit. If you let them stay in pain, that means you left them susceptible to infections, whether you knew it or not, okay? And that's all proven in the literature. All right, let's do a question, and I'm gonna stop here. Hang on a second. Bryce, you have a question?
Yes, my question is regarding hydroxyurea.
Hydroxyurea, your question is?
So, you said in the book that it can wipe out the entire bone marrow.
Right.
So I'm just wondering, how do we give this? Is it just is it a regular, like a daily drug we give, or is this just?
No, it's occasional transfusions, or infusions. We give you the hydroxyurea. The drug will wipe out your bone marrow, and then your bone marrow will reconstitute itself. But in so doing, Melissa, the bone marrow has to go through hemoglobin F to get to hemoglobin A. And by chance alone, some of it sticks around. We're only talking about 5, 10, 15%. Because if I let too much hemoglobin F stick around, I kill my own patient. You better understand that? Hemoglobin F can't drop off oxygen for an adult. So it's just to elevate a small percentage, just to keep a little oxygen in the blood, and that fools the red blood cells. That means they're less likely to sickle. Okay? Yeah, no problem. Isis, you have a question?
Yes, I think this might be related to Bryce's question. But in the slide where you mentioned the aplastic crisis and you mentioned that there's complete bone marrow suppression, is it because of the hydroxyurea use, or is it for some
No,
of the cause.
it's usually due to a virus that does that. But hydroxyurea is used to wipe out the bone marrow, but that's called treatment. That's not an aplastic crisis. We were doing it willingly. A crisis means it happens and we didn't expect it. That's why a virus, when you pick up a virus, we don't expect your bone marrow to get wiped out, but it can be wiped out.
Okay,
Right.
so when they acquire the parvovirus, that's when the bone marrow suppression happens because.
That's
of
correct.
telomerase. Okay,
Right.
Okay,
That's when you have an
Thank
aplastic
you.
crisis with the virus. Lillian. The patient with relapse. Yeah, you could put it back on methadone or buprenorphine, either one, yeah. Transfuse sickle cell patients when they're anemic or symptomatic, folks, that's every time. So that's automatic. When they come in, they're in pain, that's symptoms. And they're anemic because they're hemolyzing. So they get a transfusion every time they come in. All right, and then finally, functions of the spleen. Since I mentioned it, again, I just want to remind you, the spleen does 5 things for you that's important for you to know. Removes old red blood cells. So when they lose their spleen at age 6, that's why you start seeing spherocytes, because it's no longer removing old red blood cells like before. Removes damaged RBCs. There's no particular name for those. Removes nuclear remnants. That's how you get hollow jolly bodies. And that's a common question they like to ask. When would hollow jolly bodies be a normal finding in a sickle cell patient peripheral smear? Anytime after age 6. Okay, because the spleen doesn't work anymore after that. Number 4, removes encapsulated organisms. That's why anytime after age 6, but you can do it earlier, obviously. Make sure they've gotten their Pneumovax, H influenza B, Neisseria meningitis vaccines. Protect them against all the encapsulated bugs. But the Pneumovax is the most, strep pneumonia is the #1 vaccine they're gonna ask you about. And erythropoiesis, if bone marrow shuts down. They don't have a spleen after age 6, and that's why you got to transfuse them from then on. So these are the 5 main things that the spleen does for you in anybody. Any questions at all? I will stop here. I gotta go get my allergy shots. This is allergy season. So luckily I'm not sneezing and stuff. That's because I keep getting my shots. All right. Let's stop here. We'll start back at 1:15. Enjoy your lunch.
The next 4 hours.
Hi, guys. What's the time there, please?
Can she hear us?
What's the time?
Oh, yeah, she can hear us. It's 11:45 right now. No,
So we'll come back 1:15, right?
yeah, it's an hour and a half. An hour and a half.
Okay. Okay, thank you.
Come back at 2:15.
150.
Does anyone else know whatever? No, yeah. Like. Good job. communities. I know that's fine. I mean. I was, it was great. I was right next to him. She's my mom. Do you want me to take my card? I got mine. Oh, you'll, honestly, we'll go. Get lost. But I do feel very bonded. It has to, I don't know. I think a lot of people have it is. I think a lot like charging about is that I love. Particularly, I download PDFs and I really got excited. I like learning. Yeah. I also want to speak this, but thanks. I feel like with this.
Yeah, no.
No one doesn't, is there anywhere to say? Oh, it's like finally. Last hour. This is one. This is very hard. But that's what I mean, like, I'm gonna adjust. What is it? Nice. Yeah, I was looking at it. Couple, please. What is it? What? You're like. Okay. Oh, maybe you can have. Yeah, yeah. Good. Great. Yeah. 2 years. And then. If you want to wait, yeah, I think about 2.5 years. I don't know if that means one. Oh. Okay, one of these. We can. Okay. I'll just do it. I could. Oh, I. This. It's like,
better, to share resources, to help each other study better and motivate each other, that we would create a group, either on WhatsApp or Facebook or Discord, whatever platform that you use that you think would be more accessible to you. And we're all in touch and share resources and talk to each other and find diverse study partners. Would that be something that people would be interested in? Yes, okay. If I could show of hands, who would like Discord?
Two discords.
Do you know what Discord is? Okay. WhatsApp, who would like WhatsApp?
There we go. So everybody knows WhatsApp.
WhatsApp. So then if you could, after the lecture, come see me, I will make a group and I will make sure that I. I mean.
You should pass like a piece of paper.
Okay, there you go. So please share and, yes, perfect. So come see me afterwards and we'll get everybody. Right, yes, that's what, well, I will have to have your information.
All right, that's the way to do it. Help each other out, folks. All right, let's continue our journey.
Dr. Francis, could I add something really quickly?
Yes, who's speaking? Oh, Ayushi. All right, go
Yes,
ahead.
I just wanted to say to the people in class, there is a group me as well. So if you guys
There's a
want
what?
to,
What
there's a
group?
group me and there's a WhatsApp. I know that people online made one, so I wasn't sure if the people in class wanted to have one separately or not, but that's also something to consider. Okay, continue.
So there's already one from online?
No, that's too much.
Oh, that'd be too many people. All right, let's go. Sorry. No, wait, one for online, one for people here. That way, because you have too many people. All right, let's continue our journey, folks. Let's do it. Sickle cell trait now. Daniel, you have a question?
Yeah, it was for the about the hemoglobin F. It says that it's treats hypoxia, but we know that it has a higher affinity for oxygen. So I wanted to know if you could kind of explain that.
Yeah, this is about hemoglobin F. When you induce hemoglobin F, remember hemoglobin F has a very high affinity for oxygen, which means it holds on to it. That means as it's floating around in the bloodstream, it's holding on to the oxygen, it's not going to drop it off. Well, as the RBCs are circulating, they're going to see hemoglobin F with plenty of oxygen. Well, as long as they see oxygen, they won't sickle. They don't know that hemoglobin F cannot drop it off. But the key is it decreases the number of sickling crises, and it does work. All right, so you're fooling the system. That's all you're doing. Fooling the red blood cells into thinking there's more oxygen than there really is. All right, so like I said, 5 to 15% is what they usually shoot for, because obviously if you made too much, then you'll kill your own patient. Sickle cell trait is usually asymptomatic unless there's severe hypoxia. I had a 47-year-old Black female who had this. She never even knew she had the trait until her house caught on fire. Remember, fire sucks up oxygen. She had her first crisis at age 47. That's about the only time you see sickle cell trait cause a crisis, is when there's hardly any oxygen in the environment, like in a burning building. Okay, so for that reason, see that careers to avoid, you don't want to be a fireman. Because if you go into a burning building and then you don't have enough oxygen, you're going to go into a crisis. Now you're going to burn with the other people. Okay, deep sea diving, there's not much oxygen down there either. Okay, and then pilots in a lot of planes, they won't let them be pilots for that reason. Because if the plane decompresses, that's it. Your pilot is in the middle of a crisis now. Okay. All right, how do they usually present to the physician is what they usually ask. They don't present with symptoms of sickle cell, but they'll present with bleeding from their ureter. So they'll present with hematuria. I've seen this question several times. How will they actually present to the doctor? No pain crises whatsoever, but they tend to bleed from the ureters a lot. So they'll come to you, complain about hematuria. Reed, did you have a question? They cannot do what now? Can the person fly on the airplane? Yeah. They just don't want him to be the pilot flying the plane. That's all, but he can fly on the airplane. But that means if the plane decompresses, he may go into a crisis. But we don't stop him from flying. All right, sickle cell trait. Any questions on sickle cell anemia or trait? It is, yes.
Hematuria, yeah, there will be red blood cells. Yeah, it's real hematuria. In fact, the patient I had, she had a lot of it. She has several cases. And I remember I asked the urologist, hey, let me scope her with you. I want to see where the bleeds come from, because the books always say you can't really see where the bleeds come from. Sure enough, 3 times we scoped her. All you see is blood leaking off the ureter, just coming off the wall, like one of these Hail Mary bleeds. You can't even see a blood vessel. All right, but nobody's doing any research on it, but all you do is just give them normal saline with bicarb in it. Bicarb attracts calcium, and calcium attracts platelets, and it clots off. It stops so fast, nobody cares. All right, so it's just a good test question. How will they present to the doctor? Hematuria. Hemoglobin C disease, also aldosterone recessive. The substitution, again, number one thing they always ask, substitution, is lysine for glutamate at position 6 of beta chain, same position. But notice this time is lysine charged for glutamate charged. And that's why there is no change in the shape of red blood cells, so it's a silent disease. So that's the second most common question I like to ask. Why is it a silent disease? Because there's no change in the shape of the red blood cell. Any questions on hemoglobin S or C disease? Cool. Thalassemias now. Thalassemias are gene deletions. You need a gene for globin. Remember, we make the heme and then wrap around globin. Well, you need a gene to make the globin, alpha and beta, globin chains. If you don't have the gene, you can't make as much. Alpha has 4 genes to it. Beta only has 2. This is also autosomal recessive, common in Mediterranean people, just like sickle cell is common in Africans. If I end it with the word minor, that means there's at least 1 gene still remaining. So alpha minor, beta minor, it means you have at least 1 gene still remaining. Give you more, but it's at least 1. If I end it with the word major, it means you have no genes remaining anymore. You understand, Rachel? Understand, Ashni? All right, understand, Cynthia? Cool. 3 hemoglobins, you gotta remember what they're made of, Melissa. A, 2 alphas, 2 betas. A2, 2 alphas, 2 deltas, and F, 2 alphas, 2 gammas. So alpha thalassemia, again, 4 copies. This is just to illustrate it for you. All right, 4 copies. Baseline labs you want to remind yourself of. I already gave you hemoglobin, 15. If you multiply times 3, that's your hematocrit. So 15 and 45. And then red blood cell mass, I threw that in case they give you that one. I've seen them give all 3. So that's why I don't know which one they're going to give you on your exam. But you got to know what normal is. 3.5 to 4.5 million RBCs is the norm. So less than 3 million RBCs, you're anemic. More than 5 million RBCs, you're polycythemic. So baseline labs. Alpha, we'll do alpha first. Let's go over to Melissa, you do alpha with me, ready? So alpha minor, 1 gene missing. That means there's still 3 left. You are asymptomatic. If you got 4 copies, each one represents 25% of your globin chains. So that's why I said here, you got 75% of your globin chains, that's still a hemoglobin around 12. That's why it's completely asymptomatic. People with alpha minor with 1 gene missing have no idea they have any illness at all. We just find it by accident. Usually late in life when we're checking for something else, all of a sudden say, oh, he's got alpha minor. Okay. And then 2 genes missing, if you're sedentary, you'll have no symptoms. But if you're active like an athlete, guess what? You're gonna have symptoms because you only have half your hemoglobin, which is 7.5. For a normal person, not a problem. For an athlete, yes, a problem. What do you think would be the most common presentation for alpha minor with 2 genes missing? By the way, may I? All right, let's ask Solange. Would it be what? It would be alive. It says here, asymptomatic. That means you're alive. Chipmunk face? I don't know. Let me see. I don't know, Bailey. I don't see it. I think I see it in your eyes. What are you gonna present with, girl? Yeah. Shortness of breath, what? Oh, look at that. That's right. Slap yourself, Solange. Come on, listen to that long story. All And remember, I told you everything about chemistry is low energy state. It's just that every now and then I gotta make sure you guys have not forgotten. Remember, all I'm telling you is the clues. I'm not going through signs and symptoms. But I don't want to find out you guys forgot and now you're guessing again. Okay? Every biochemistry disease, because biochemistry is about energy, folks. Look it up. It's the same. Okay? So I'm just telling you how to separate them. Yes, I know.
Extrapolator and any disease that causes hypoxia is going to low energy state.
Any disease that causes hypoxia takes you to a low energy state. That is correct, sir. Because without oxygen, you can't make any ATP. You're learning, sir. You're learning. See, did I tell you one day my brain just exploded because I saw all these connections. Man, oh man, vitamins, minerals, trace elements. That means they gotta be. Yeah, then I saw women inside deficiency. That means they gotta be. Yeah, I'm looking at all these. It's exactly the same. That was a huge explosion one day. I can't believe. If you guys know biochemistry, back then we were using Strider. That's our thick book. So that means I never have to read this thing again. You know how happy I was? Okay, folks, anyway. 3 genes missing. Now you only have 25% of your hemoglobin, everybody's symptomatic. 3 genes missing, everybody's symptomatic. So again, low energy state, because you got only a hemoglobin of 4 or 5. Hemoglobin of 6 or less makes you hypoxic in anybody. So that's why if they say 6 or less, assume they're hypoxic. If you look up the criteria for transfusion on them in the household, that's why they say below 7. See, same thing in biochemistry. All right, that's why I want you guys to know basics. Otherwise, you're gonna have to memorize what every article tells you. You don't realize all they do is just pull it out of basics. Okay, but that's the part that most physicians don't know. So that's why they're busy memorizing every article. Now realizing you don't have to memorize this if you go back and reread your basics. Okay. Like I said, if Dr. Shaw never told me that, I would never reread them either. All right, alpha major, you're in trouble. Why? Because you have no globin change at all. That means you cannot make hemoglobin. And because there's no hemoglobin without globin in it, doesn't matter if it's A, A2, or F, they all need alpha. That's why this is incompatible with life. You're gonna die in utero. But when are you gonna die in utero? When you're supposed to make red blood cells and then you can't. When does RBC synthesis? Cesar, begin in utero. All right, Miguel? All right, Raimundo? All right, let's Ashley. No, Rachel. How about Bryce?
4 months.
4 months gestation. He was on the slide a couple of slides back. I told you the way I remember it, because you always got to how do I follow it so I don't forget it? I told you first trimester, 3 months. You're making all the organs. You don't have a heart and blood vessels yet. Once you make it, then the body says fill up the tank. That's starting at 4 months. See, that's how it makes sense to me, and so I can still remember it after all these years. Okay, so always rehearse. How do I file this away? All right, anyway, that's alpha major, incompatible with life, and a gamma chains come together, try to help you, but they can't. So hemoglobin BART and hemoglobin H is 4 beta chains. So any mention of hemoglobin BART and hemoglobin H, another clue for alpha major, but is irrelevant because they die in utero of hydros fetalis. Beta thalassemia only has 2 copies, Zena. Beta minor, hemoglobin 7.5. Again, if you're sedentary, no symptoms. If you're an athlete, yes, symptoms. But here's the difference, Zena. You don't need beta chains to make A2 and F. So your body makes a ton of it to help you out. The problem with that, Melissa, is that hemoglobin F is no good after what age? Was that? I couldn't hear you. At 6 months of age. That's why they call it, see that? Ineffective erythropoiesis. It doesn't help you. But just so you understand, why is the body making so much A2 and F? It's trying to help you out. Since we can't make A, it says, well, let me make you the other ones. But that doesn't help me after 6 months of age. But it makes for a good sneaky test question. Listen carefully. They give you somebody who comes in and they've got anemia. And yet, when they give you the CBC and everything, they've got 9 million RBCs. Most students don't pick it up. That's why I gave you the normal, 3.5 to 4.5 are normal. You got 9 million RBCs, how are you anemic with 9 million RBCs? Oh yeah, you're making so much of the other stuff. See that? But if you don't catch that, you right past and keep moving and miss it. That's their clue. That's the ineffective erythropoiesis that I'm talking about. A whole lot of A2, a whole lot of F, but it doesn't help you. Beta major, both genes are missing. Well, you're gonna be fine because all you can make is A2 and F. So that means you're gonna have no symptoms until 6 months of age and then go downhill. They also call this Cooley's anemia. Dr. Cooley, who discovered this. They become transfusion dependent for the rest of their lives because that's the only way they can live. They cannot make hemoglobin A at all. So the only way they can live is I gotta transfuse them. We do it every 60 to 90 days. Okay? Any questions on that? So beta minor, beta major. Yes, sir.
I guess like alpha 2 is just that ineffective at carrying oxygen.
No, alpha 2 is not ineffective at carrying oxygen. It can, but it makes up less than 2% of your hemoglobin. Yeah, you can't live with only 2% of hemoglobin. What's the other 98% is not there. Yeah. All right. And Victoria, you have a question?
Yeah, you may have covered this, but for hydroxyfutalis, they die in utero, right?
That's correct. They die in utero.
So why can't they live on the mother's blood while they're attached to the placenta still?
The mother's blood does not circulate inside the baby in utero. Don't forget that.
Okay, so the placenta wouldn't keep them alive.
Yeah, the placenta cannot keep it alive. The mother's delivering oxygen, but the baby has no hemoglobin to pick it up.
Oh, okay, I see.
That's why he dies in utero. All right, so that's beta thalassemia. Blood transfusion. I put in 2 slides here about blood transfusions. Why? Because they're asking a lot more questions about blood transfusions. Now, why are they doing that? Because you and I, the doctors, we're the ones ordering these blood transfusions. And once again, folks, they were shocked that most doctors don't even know the criteria for transfusing people. And yet we write for it all the time. I remember as a resident, somebody coming out of surgery, the hemoglobin would be, let's say 7 or 8. And they say, his hemoglobin fell a little bit. And I give them a couple of units. That's not the criteria for transfusion. Numbers. Number by itself is not. It's got to be symptomatic anemia. That means less than 7 and they're having symptoms. Okay? Because I've seen a 5 walk into the ER. So you can't tell me 7 does not live. Of course they live. All right? And we transfused her. Why? Because she was very symptomatic. I mean, she was having palpitations, she was short of breath, she was lightheaded, everything. Then you have to transfuse them. But notice, she didn't get a 5 today. She's had that number for quite some time. Okay? So let's talk about when you actually transfuse people. All right, number 1 reason for transfusion, symptomatic anemia. Number 1. And then in heart failure, renal failure, transfuse and keep hemoglobin between 10 and 12. So here's where number matters. And as in those 2 diseases, they will test on this because the patient's life depends on it. If you let the hemoglobin drop under 10, it had a high death rate. If you let it go above 12, high death rate again. It means that when it's low, the heart has to work too hard, they die. When it's high, the viscosity rips up their blood vessels, which are already fragile, and they still die. So the optimal number, 10 to 12. That's why they'll test you on it to make sure you know. So you never overload them, and also you never let them stay anemic. All right? Renal failure. What's the most common cause of renal failure in children? Ida. HUS in adults, Ida. Hypertension, diabetes. Now, for everybody's sake, 1 unit of packed red cells. This is how you determine how many units you need to give somebody. 1 unit of packed red cells, raise the hemoglobin by 1 to 2 grams, which is 3 to 6 hematocrit. So that means if I want to transfuse you 4 units, you say, okay, well, how many grams I need to take them up? I need to go from 5 to 9. All right, he needs at least 3 to 4 units then. Okay? All right, but this 1 unit delivers 3.4 grams of iron. So you got to know you're also delivering a lot of iron to the person. Now, in pediatrics, Anna, 1 unit of packed red cells in pediatric terms is 20 cc's per kilogram. So 2 units will be 40 cc's per kilogram. This is how you calculate how much blood you need to give a child. 20 cc's per kilogram equals 1 unit of blood. In adults, we talk about units, but we don't talk that way in children. Mabel, you have a question?
Please, I have some confusion from, they said 1 unit of PR, what's PR? Is it peripheral red blood cells?
No, packed red blood cells is PRBCs.
Okay, so what did you say about 3 to 6 HCC? What is, please, can you explain more?
3 to 6 hematocrit. This is how much I'm gonna raise your hematocrit when I give you 1 unit of blood.
Okay.
Yeah, either raise it by 1 to 2 grams, or you can say 3 to 6 hematocrit.
Okay,
But I'm
thank you,
also
sir.
deliver 3.4 grams of iron to the person. This is how you get iron overload over time. Okay, so blood transfusions are not benign. Transfusion products, let's go through them. Whole blood is for somebody who's losing the whole thing. What is the whole thing? The trauma patient who's bleeding all over the ground. You're losing everything. I gotta put everything back. So stab victim, gunshot victim, car accidents. All right, they just completed a study a few years ago. Because for years, to try to save money, we would transfuse somebody, pack red blood cells, and give normal saline to reconstitute it. This is a trauma patient in a car accident. And so they did a study and they found if you gave them packed cells and normal saline, the death rate, you heard me correct, that death, that means they're dead by the time they get to the emergency room, 43%. 43%. If you gave them whole blood, 13%. So folks, it's no brainer. But that means it's now called malpractice. If you transfuse anything else except whole blood in trauma patients. You've heard about this? Is now until they're restructuring all the blood banks across America to get more whole blood, because we're gonna need it now. Because now, to transfuse anything else in a trauma patient, you can now be sued if you use something else. That's why they say use 1 to 1 to 1. 1 unit packed cells, 1 unit FFP, 1 unit platelets equals whole blood. So until we have enough whole blood, another CD I just reviewed, I think yesterday or Monday. Say that again. Was that?
That famous doctor?
The famous doctor who?
Yeah, the one that was like that's like the doctor.
Uh-huh.
And she got, I think that like, she's gonna go on trial and get her.
Get her license taken away? Yeah, so she's talking about a doctor, I guess, the doctor on the news, because she used the wrong blood, the wrong stuff. It's supposed to be 1 to 1 to 1. That means if you just use packed cells and normal saline, you cannot be sued. Because we know it's clearly up there, 13 versus 43, folks. Come on. Okay? Even if it's an accident, the key is, that's why I say whole blood, whole thing. That means any situation where you're losing the whole thing, I now know I got to give you whole blood. Because otherwise, I'm not trying to memorize a list of things. Don't do it that way. Okay? Anybody who's bleeding all over the ground needs whole blood. All right? And until they get more whole blood in all the blood banks, 1 to 1 to 1. Everybody clear? It's now being tested because that study came out a couple of years ago. It's malpractice if you don't. And you don't want to be in a big lawsuit like that. 1 unit of packed red cells plus 1 unit of preservation plasma plus 1 unit of platelets equals whole blood. Yeah. All 3 things. Now, remember, I'm talking about trauma patients. Somebody in the hospital, that's different. Packed cells, fine. I'm talking about trauma. Specifically only for trauma. If you don't remember to give them whole blood, you could be sued for it. That person dies, you're in trouble. Okay? All right, so that's whole blood. Fresh frozen plasma has no RBCs in it. But we use it primarily because it has all the clotting factors in it. So FFP is used for any bleeding disorder who is acutely bleeding. And I don't know why. I'm just going to stop it for now and then work you up. That means it works in any bleeding problem. I don't care if it's due to warfarin, heparin, whatever. This is somebody who comes in the emergency room, they're having a bleeding problem. They weren't in a car accident. And I have no idea what disease they have yet. Give them FFP, stop the bleeding, and then work them up to see which one they're deficient in. But FFP has all clotting factors in it. Okay?
Even if they have like a hypercoagulable,
Even if they have hypercoagulable state, you're saying?
Yeah, like.
But you're not gonna know that when you first walk in the ER.
Yeah, but would it like? what?
No.
They have a history of clots.
No. So she's asking, would that conflict with their history of clots? The answer is no, because right now acutely they're bleeding. I have to transfuse. Yeah, you have to stop the bleeding. All right, that's FFP. Next one, packed red blood cells. That's the symptomatic anemic patient in the hospital. All right, like sickle cell anemia. Their plasma volume is normal. They don't need your plasma. They just need RBCs. That's why we give them packed red cells then. But the problem is when we give packed red cells in the hospital, we tend to dilute it down with fresh frozen plasma. With normal saline, because that's isotonic. We want to keep the osmolarity the same, right? One more time, when you transfuse packed red blood cells, we tend to reconstitute it with normal saline to keep everything isotonic. Everybody with me so far? The problem is, there's no clotting factors in normal saline. So even though you keep the osmolarity normal, you're actually still diluting the clotting factors. Right, follow? That's why the high death rate when we're using the trauma. See, it makes sense to me. Okay, that's why it's clearly malpractice. If you didn't know that, you just give them all those normal saline, you're diluting the clotting factors. That's why they bleed to death before they even get to the emergency room. And that's why now they can blame it on you, because we know exactly how it happens. All right, so packed red blood cells. If you're going to give packed red cells in the hospital, the rule is for every 1.5 units, you give 1 unit of fresh frozen plasma to keep their clotting factors normal level. So that one is 1.5 to 1. So, if you give 3 units of packed cells, then you give 2 units of FFP. So numbers you want to know, folks, because now they're watching it. Because too many people have died when the doctor did not pay attention to this. Okay, packed red blood cells. Next, with cryoprecipitate has 3 things in it. And Kathleen knows, if you know the 3 things, then you know the 3 indications. All right, factor 8. So moderate bleeding and hemophilia A. Von Willebrand's factor, moderate bleeding and von Willebrand's disease, and fibrinogen. Somebody who's deficient in fibrinogen. So Kathleen, can you give me a reason why somebody would be deficient in fibrinogen in the hospital? All right, no problem. Lawrence, can you give me a reason why somebody would be deficient in fibrinogen in the hospital? Not uremia, close though. Anna, what do you think? DIC, sepsis. Think about how many people have infections in the hospital. DIC is the #1 cause of losing your fibrinogen. And that's why, here's the update. If you got DIC, because that's the #1 time, DIC with bleeding and low fibrinogen, cryoprecipitate is the answer. Yeah. Remember, we used to use FFP for many years. Now we know cryoprecipitate works better. So I'm giving it to you as an update because a lot of books don't have that yet. So cryoprecipitate is the blood product of choice. If you got DIC, so it's gonna be a septic person in the hospital, bleeding, and then they tell you the lab show fibrinogen level is low. You gotta know cryoprecipitate is the answer. If fibrinogen level is normal, FFP is the answer. Update on treatment of DIC. Any questions on that? You understand so far, Amy? Okay, cool. All right, that's cryoprecipitate. Next one, platelets. 1 unit of platelets contains about 10,000 platelets in there. Just so you have a round number to play with. It's like 8 to 10, but I rounded off to 10. Number 1, we do not transfuse into a destructive process. That means any of them. Why would that be? Cesar? We do not transfuse into a destructive process. Why would that be? Let's see what Michael says. Because those are to be destroyed. Everybody else saying that? So if you got ITP, lupus, rheumatoid, you got antibodies against platelets. What am I transfusing you for? Any place I give you destroy it as soon as I give it to you. Everybody understand? Anybody not understand? We do not transfuse it to a destructive process. Unless you're worried about something. What thing do you think you should be worried about? And then do the transfusion anyway, Fatima. What worry would concern you so bad, you say, no, I'm gonna give you platelets anyway. When you're worried about what organ? Heart? Yeah, kind of close. You see Maria, my friend, Maria. What are you worried about? The brain, girl, come on now, Fatima. That's twice I got you now, come on now. Third time, boom, gotta pick up on that. I told you about the brain. When the platelet count drops to 10,000 or more, that's when they get intracerebral hemorrhage with no warning. See that? Yeah, see, now it makes sense to you. You said just memorize, oh, 10,000, transfuse. See, that's what happens with most physicians. We just memorize numbers with no understanding because we never understood the basics yet. Okay? But once I saw that 10,000, oh, wait a minute, that's what intracerebral. Oh my, all of a sudden it made sense. I never forgot the number ever again. Okay? So when you're worried about the brain, all bets are off. You have to do something. And then second, I'm about to take you to surgery. You can't take you to surgery if you can't cut yourself off. So that should make sense to everybody. All right. So that's the only time you transfuse it to a destructive process. Otherwise, don't do it. Number one, platelet count drops under 10,000. Or number two, I'm about to take you to surgery for usually splenectomy. We just transfuse them throughout the whole surgery. Okay. All right, that's platelets. So we tend to transfuse into a production problem. There's thousands of those too. But like, let's say I just put you through radiation therapy and I wiped out your bone marrow. Well, I'll just make you some platelets. It's temporary. Your bone marrow wake back up. So that's what I mean by production problems. Radiation, chemo, viral infection, whatever it may be. Production problems, sure, transfusion because it's temporary. And the platelets will last about a week. Usually by that time, the bone marrow wakes back up. Then we're fine. Any questions on that? All right. DDAVP, also known as desmopressin, vasopressin, synthetic ADH. You guys remember ADH is made in the hypothalamus and stored in the posterior pituitary. Make sure you know the difference between those two statements. All right, because students on the test, they'll say, where is it released from? And students go pick hypothalamus. No, it's not released from hypothalamus. It's stored in the posterior pituitary and released from there. Okay, but that's not where you make it. Because I've seen the question when they flip it, or where is it made? And students pick posterior pituitary and forgot. It's not made there either. Made in the hypothalamus, stored in the posterior pituitary, and released from the posterior pituitary. All right, DDAVP has two receptors that you need to be familiar with. Phe1, that just means the first one, is on all your blood vessels. Phe1, Saeed, is on all your blood vessels. When would I want to constrict all your blood vessels for you? When you got severe hypovolemia, your body knows what's on ADH anyway, right? But if you got varices bleeding, we give you DDAVP. We need to constrict the varices because they're huge veins. Patients would bleed to death if I didn't do that. Okay, so DDAVP is used for severe variceal bleeding. Number two is used in VFib. Why VFib? I'm really trying to constrict your carotid sinus, V1, which sets off the vagus, which then slows down the heart rate for a few seconds so I can shock you out of it. DDAVP. So it's not that DDAVP treats VFib.
Can you go over that again?
Coming at you. DDAVP is a potent vasoconstrictor. Everybody still understand that, right? If I squeeze your carotid, that's called vasoconstriction, it'll stimulate the vagus that runs right next to it. And yeah, baroreceptor reflex will be set off and your heart rate will slow down a little bit. That means I can shock you out of it much better, much easier, let's say it that way. Okay? So just so you know why we're using VFib, because it's not because the drug treats VFib, it doesn't. All you're trying to do is stimulate that vagus, which makes it easier for me to shock them out of VFib. Okay? So DDAVP, that's B1 receptors. B2 receptors are on the collecting duct of the kidneys. B2 receptors, Chris, is on the collecting duct of the kidneys, where you pull in water with the help of urea. Pull in water with the help of urea. So that's helpful when somebody has central diabetes insipidus. You have to put them on DDAVP for the rest of their life. Central DI. DDAVP is the treatment. And then second, severe enuresis. Severe bedwetting is usually a child after the age of 8. We don't do this until after age 8, because then it becomes so embarrassing for the child. You don't want them to go through that trauma. All right. So severe enuresis after the age of 8, and they're going to camp or a sleepover. You don't want the child to be embarrassed like that. Because if you accidentally pee on your friend's mattress, you know the whole school is going to hear about it. And that kid is going to be embarrassed the rest of his life. So I prescribed a lot of it for the kids, and the mom was so happy, because otherwise the kid didn't want to go anywhere, because he was always afraid he's going to pee on somebody's bed. Yeah. All right, anyway, that's DDAVP. Factor VIII concentrate is used for factor VIII deficiency, so severe bleeding and hemophilia A. Factor VIII concentrate. In the old days, Karina, it would take about 60 volunteers to make 1 unit of factor VIII concentrate. And when you transfuse hemophilia A patient, they need 6 to 8 units at a time. Everybody hear what I just said? One more time, listen carefully. All right, 1 unit of factor VIII concentrate would require about 60 people to be made. And then when I have to transfuse a patient, you're supposed to give them 6 to 8 units. Take 6 to 8 times 60. You're exposing them to almost 500 strangers. That's how to remember factor VIII concentrate as the highest incidence of HIV transmission. I don't want you to just memorize it. I want you to understand why it got that title. That's why somebody had to sequence it. This is another one where a company sequenced it. Now 0 transmission of HIV. See, that's why I had to teach you guys about transmission in case you want to do that for a living. So whoever did that one, oh my God, saved a lot of lives. Because when I first came into medicine in '83, man, the chairman of pediatrics at that time had hemophilia. The man was dead by the end of the year because all the transfusions he needed and HIV killed him. And we used to have a lot of hemophilia patients in Peoria. There was a certain time, almost all of them were dead. They actually had to close down the clinic because there was hardly anybody else alive because of the factor VIII concentrate. So you can imagine how happy the hematologists were when suddenly it was synthetic and pure because they've been sequenced. And now 0 transmission of HIV. But the question is still out there, and I've seen it. Which blood product has the highest incidence? Okay, or highest prevalence? Because new cases is incidence. There's no new cases, but prevalence. The highest prevalence of HIV transmission. There you go, right there, factor VIII concentrate. Last one, next one. Albumin, 5% or 25%. First of all, 5% is isotonic. 25% is hypertonic. But who needs albumin? Is a person who's deficient in albumin. All right, Rachel, maybe it's somebody who doesn't eat enough albumin. Who doesn't eat enough protein? You know what disease that's called when you don't eat enough protein? Veganism? Wait. Okay, veganism. Okay. You know what it's called? It's called kwashiorkor. No, marasmus just means you've lost weight, but you're not protein deficient. Kwashiorkor says you're protein deficient, protein malnourished, so I got to give you some. Okay? So maybe you're not making enough protein. Mitchell, what would that be? Yeah, like cirrhosis. So everybody's listening to the physio now. That's how I talk myself into my differentials. I don't try to memorize lists. Try to see how do I come up with this stuff again. Once you see the physiology behind it, you come with the list anytime you want. You're not eating enough, kwashiorkor. You're not making enough, cirrhosis. Number one cause of cirrhosis right now in America, obesity. And then acetaminophen now is on to number 2. You believe that? Alcohol used to be number 1. Alcohol's been bumped down. Over down to number 3 now. All right. So anyway, just be aware of it. Anyway, cirrhosis. Maybe you're peeing it all away. Ida. Nephrotic syndrome. And the most common nephrotic syndrome in children, Ida. Minimal change disease in adults, Gloria. Diabetes can cause it, but they're not gonna say diabetes. All right, Ida, back to you. Focus, remember, FSGN is now number one. That's because hypertension is the number one cause of FSGN, followed by diabetes. So FSGN is the number one cause of nephrotic syndrome in all adults. Remember, this has been brought down to number 2. That's why, I'm giving you a whole lot of updates so that you don't accidentally go pick wrong answers on the exam. A lot of things have changed over the last couple of years. For what? No, for cirrhosis?
Yeah.
Cirrhosis, obesity is number 1. Acetaminophen is now number 2. Alcohol has been bumped down to number 3. Nephrotic syndrome in adults, most common cause is focal segmental glomerulonephritis, FSGN. Remember, this has been bumped down to number 2. And then after nephrotic syndrome, maybe you're allergic to proteins. That's called celiac sprue. You're allergic to proteins. And then a rare disease, maybe you're oozing proteins out of your stomach. That's rare, but it's called Menetrier's disease. Menetrier's disease. So that's how I come up with my differential again. Okay? And that's how I want you to come. Just talk it out. Don't try to memorize lists. Not eating it, not making it, you're peeing it away, you're allergic to it, or you're oozing it out. Hypertrophic gastropathy, correct. Yeah. They got such big rugal folds, mucus along with proteins just being pushed out all day long. Yep. Celiac sprue. What's the screening test for celiac sprue? Anders. Yeah. What'd you say? Oh, you know what I mean? It's called tissue transglutaminase. You said transaminase. That's the liver inflammation. That's the wrong one. That's why I thought give you a chance to correct it. So tissue transglutaminase is a screening test. All right. And the rash that goes with celiac sprue is Ida. There's a rash that goes with it. Real classic and unique. Let's go to Gloria. And the name of this rash is what again? What is it? No, that's one that goes with glucokinoma. Anyway, the rash that goes with this is called dermatitis herpetiformis. It looks like a herpes rash, but it breaks out when you got diarrhea. That's how you know it's got nothing to do with herpes. Okay. Anyway, again, we'll be talking about these. I'm just drilling as we go because they're ahead of you guys. I want to make sure they're getting ready for their exams. All right, so just so nobody feels bad because you don't know, I only expect them to know. All right, so anyway, when do we use albumin? In any one of these instances, 5% albumin is isotonic. It's just a by time. The way they'll say it is temporizing measure. 5% albumin as a temporizing measure, because that'll be helpful for somebody who doesn't have protein. And that's because they're losing all this fluid in the interstitium because they don't have enough oncotic pressure. Well, I can help them out. All right. What about the 25% albumin? It's used when you want to suck fluid back into circulation so they can pee it away. So that, because they got a subdural effusion, fluid effusion, ascites, swollen testicles, legs are swollen everywhere. Well, use 25% albumin, pull that fluid back into circulation and give them a little furosemide and pee right out. Okay, but just so you know, it's for the people who actually need it. Okay, so the number one reason for my having to pull fluid into your circulation is if you got heart failure. So heart failure, you got so much fluid all over the place, but it's not in the blood vessels, it's in the interstitium. So every now and then, we've used 25% albumin to suck fluid back in and furosemide to make it pee it away. All right, renal failure is number 2. And then hypothyroidism. Why hypothyroidism? Because when you're hypothyroid, your heart and your kidney will fail. So it's really saying the same thing. Again. All right. All right. Any questions so far? Yes, sir.
Is there an ejection fraction indication for?
Ejection fraction, no. There's ejection fraction indication for heart failure. And then heart failure is on here.
But like, to the start,
No, you can use any ejection fraction you want. Yeah. Yeah, I've never seen any article say you need a certain ejection fraction. All right, Joshua Bond, you have a question for me?
Yes. So for desmopressin, I heard what you said with using it for people with central diabetes insipidus and VFib, but
Correct?
it says in your little like book thing, it says for mild hemophilia A or von Willebrand's disease. And I'm
Oh,
just
yeah. I'm glad you brought that up. Let me explain that. That's another indication for DDAVP because the V1 receptors on endothelial cells, when you squeeze your endothelial cells, they actually release preform 5, 8, and VWF. And so that's why you can use it for mild bleeding in hemophilia A or in von Willebrand's disease. Thank you very much, sir.
So even though people with hemophilia A like lack factor 8, it still helps release factor 8. Yes.
Yeah, remember endothelial cells make factor 8. So when you squeeze them, they release what they made.
Okay. That's what I was just.
Majority comes from the liver, but and I'm sure that's why you're bringing up the question. Majority of factor 8 comes from the liver, but the blood vessel cells make some as well.
Okay.
That's why it says mild bleeding.
Gotcha.
That's just like your gums are oozing after you brush your teeth or something. Severe bleeding, no, this is not enough. All right, moving on. Who needs albumin? All the stuff we just talked about. Notice I put it in the labs for you. I know you guys writing viciously everything I say, but I told you I put it in your notes for you now. It's just like it's a way of doing things twice, just so it's repetition, so that I can discuss it when I'm on this slide, and then here comes the slide with all the information again, so that we say it all again. That's all. Now, transfusion products, immunoglobulins. When do we give immunoglobulins? Number one, passive immunity. Hey, doc, I'm going to Africa. There's a lot of hepatitis A down there. Okay, here, hepatitis A antibody. Have a good trip. That's the number one reason for immunoglobulins. Passive immunity. You're about to get exposed to something, I can protect you. Okay? Blocking antibodies. Blocking antibodies. Think of like Kawasaki's disease. What's the other one? Blocking. We're using myasthenia gravis. We're using multiple sclerosis. All these blocking antibodies. What are you trying to do? You're trying to block the antibody that's attacking your patient. And that's how they all work. Block the antibody that is attacking your patient. So a lot of autoimmune diseases. So don't try to memorize 1 or 2 or 3. There's a lot of them. Okay? You can always use blocking antibodies if you want.
The anti-inflammatory drug, etanercept, is that the same?
Yeah, etanercept is a decoy receptor so that it binds up your TNF so it never actually gets to the real receptor. Infliximab, those are the antibodies, right? So those are different. They're going to block TNF so that it can't get to the receptor.
Oh, these are blocking, antibodies are blocking.
Yeah, these are blocking antibodies. Yeah, I'm just saying in general. So if I give you a bunch of antibodies, what am I trying to do for you? Block the antibodies that would have attacked you. Okay? All right. Third reason is when you don't have enough antibodies, like Bruton's, common variable, whatever disease you want to talk about. All right. For like A-gamma globulinic, so Bruton's or common variable both occur. Bruton's before age 1, common variable is anytime after age 1. But all these children under age 4, we routinely give them immunoglobulin transfusions every month the first 4 years of life. Why? Because that's when they come in contact with the most diseases. So that's why we just give it to them every month. And then after 4 years of age is only if they're septic and they actually need it. So again, it's got to make sense to you. First 4 years is because we know they're exposed to so many diseases as children. Children are crawling on the floor and mouth, everything, hand to mouth, they got germs everywhere. So that's why we just say transfuse them every month. That's how you protect them. Okay, because that's normal childhood play. But after 4 years of age, we say, okay, only if they're septic. Then they really need the antibodies, otherwise don't do it. All right, so transfusion products. Transfusion-related reactions, let's go through them. All right, Mabel, I think, yeah, that's your mic again open. All right, so transfusion-related reactions. Number one, the worst one is called anaphylaxis. Now, most students can recognize anaphylaxis when it's described in a vignette. That's not the hard part. Okay? The hard part is, they'll ask you, what's the most common cause? All of a sudden they forgot. Selective IgA, A for anaphylaxis. Easy for that's what I've used all these years, it still works for me. Okay? Selective IgA, it means that the person you just transfused into
has no IgA in their blood, in their body, and you just gave them IgA by accident. And that's why they responded against it. Okay, redness, flushing, wheezing, shortness of breath, blood pressure just tanks. So how do you manage that one? Stop the transfusion. I know you're gonna pick epinephrine, don't do that. Epinephrine is always answer A, not the right answer. Stop the transfusion first, otherwise your patient will die. I don't care how much epi you give them, okay? Stop the transfusion first, then epi, okay? And there's usually 2 epi pens that run together, right? That's because we wait about 60 seconds, then I better hit it with the second epi right away, okay? To save their life, because you don't want to close off the airway, because it will close off, all right? All right, that's what you do acutely. And then chronically, there's a filter you must put in the IV line. I'm surprised nobody's ever put their name on it, because I've never seen a name for it. I just look for an answer with a filter in it. That's the answer. There's a filter you put in an IV line, antibodies cannot cross. So you don't have to worry about it anymore. Okay. Another way to avoid it is called washed packed cells, because you're washing away all foreign proteins. Don't worry about the process. That's what you're doing. Okay. They'll just ask you, how can you prevent or decrease the frequency of this reaction? That's how you do it. Either put an IV line, a filter in the IV line, or just transfuse only washed cells now. Okay? All right, that's anaphylaxis. Then there's one called acute febrile reaction. Well, honestly, it describes exactly what you're going to find. The person will get transfused a few hours later. So a few hours later, that's how you know it's not anaphylaxis. They get a fever, but nothing else. That's why it's great. It describes exactly what you see. A fever with no other symptoms. A few hours after transfusion. How do you treat it? Acetaminophen. I'm telling them. So simple to treat. But they'll ask you, which is a little harder, how did it happen? The way it happened is antigens on the surface of white cells. Antigens on the surface of white cells is the cause of it. White cells have a lot of antigens on their surface. So how do you prevent that? It's called leukoreduction. Yeah, you've heard that, right, Madam? Yeah, now you know exactly what it means. Leukoreduction process. You have to write it in your order, so because they have to order it special for you. You know, 2 units of packed cells, leukoreduction. That means you got to run some stuff on it. Yes.
How is leukoreduced cells different from washed?
Oh, wash, you're washing away all any foreign proteins within the plasma that is suspended in. Leukoreduction, you're washing away any white cells and any antigen. So one step further. Yeah. So that's how I remember leuko, white cells. That's what you're interested in that process. But washing can wash the antigens off the white cells, but the white cells are still there. Yeah. So we refer to leukoreduction for this one. ABO compatibility is the most common one that you're going to be tested on. This is the most common one that occurs. How do I know you have ABO compatibility? Because you're going to have massive hemolysis as soon as I give you the blood, because it's the wrong blood. You understand, Melissa? You're type A blood, I gave you B. I'm sorry. You're type A, I gave you B blood. You have antibodies against B already. Okay, so this one will be hours later too. So maybe 2 or 3 hours, and all of a sudden you get a fever and back pain. Why back pain? You just destroyed a whole lot of RBC, a ton of bilirubin just went to the kidney. I mean, that much bilirubin shows up in the kidney within minutes, and it hurts them because it is clogging up the glomerulus. Okay, so fever and back pain is how I know my patient is having AV incompatibility. What do you do for that? Stop the transfusion. Don't forget that now. Stop the transfusion. Give them plenty of fluids to flush this through the nephron. Okay, and then retype and cross. Somebody messed up somewhere. Retype and cross. Any questions so far? So that's the top 3 reactions. I want to make sure everybody can get those. All right, these other ones, the other 3 are rare. Don't happen that much, but they're deadly. TRALI, transfusion-related acute lung injury. Presents just like ARDS, 60% mortality. So it's rare, but when it happens, a lot of people die. It looks just like ARDS,
white out in both lungs on the x-ray. And then like the ARDS patient we saw this morning in question, remember, pulmonary pressure suddenly goes sky high. What is the cause? Cytokines that were released after the transfusion. That's why it took a few hours later before you got it. Cytokines that were released into the patient's blood. And just like ARDS, the blood vessels got leaky and then fluid and protein leaks out. Watch the way you surfactant and the lung collapses. Any questions on Trolley? The only treatment we have, just like ARDS, we put them on steroids and hope that can help heal up the lungs a little quicker. But 60% mortality tells you we really don't know what's going on yet. That's we're not saving the majority of people. All right, that's Trolley. Taco, transfusion-associated circulatory overload is volume overload. Yeah, because we reconstitute packed cells with normal saline. What if you gave too much to the person? Well, you put them in heart failure. So they'll give you all these signs and symptoms. So now you got JVD. They'll give you capillary wedge pressure is low. All right. Peripheral resistance high. I mean, they'll just throw some labs at you that definitely go with you got heart failure all of a sudden. So wedge pressure will be high. Sorry, I think I misspoke on that one. Yeah, so JVD would be high. So CVP is high, wedge pressure is high, cardiac output is low, and resistance is high. Anyway, that's Taco. What do? Just like heart failure, hit them with furosemide, diuresis, and they do just fine. And then the last one, true, transfusion-related urticaria. It looks like anaphylaxis because they'll start out with breaking out in hives, but they'll tell you no breathing problems and no shortness of breath. Like, wait a minute, this is not it looks like anaphylaxis, but it has no other symptoms. It's just a limited release of histamine by mast cells. And all you do is just treat them with a little Benadryl, they do just fine. But they say stop the transfusion, give them Benadryl or steroid, just like anybody with allergies, right? And then wait about an hour later, restart the transfusion, and they do fine. Because it's mast cells, got nothing to do with the blood at all. Blood is fine. Right? It's just that you irritated some mast cells while you were transfusing. Much like vancomycin does. You guys know red band syndrome? Yeah, that's just vancomycin that going through the skin. All of a sudden, stimulates a lot of mast cells. You look flush red. Same thing here, except this one comes out as hives, but with no other symptoms, and then it goes away. That's why they say restart the transfusion, because it's not really an iron overload. It's called hemosiderosis when the bone marrow is overwhelmed by iron. It's called hemochromatosis when iron overload has involved other organs. Skin, we call it bronze pigmentation. Liver, we call it bronze cirrhosis. Pancreas, we say bronze diabetes. In fact, they tell you if ever you see diabetic with arthritis, that's hemochromatosis until otherwise. Because diabetics don't get arthritis. But if you have diabetes and arthritis, there's something being deposited in your joints and in your pancreas. That's how you got it. I've seen that a couple of times now, and in real life, it does work. You see that combination, oh boy, you score points with your attending when you know that. Karina, question? Is that what now?
So, you know, in chronic disease and like how iron will start being held on to.
Yeah.
Is it eventually?
Yes, right.
For any chronic.
Yeah, for any chronic disease, especially if you're giving transfusions. If it's just chronic disease, it's rare to get it.
Okay.
You get hemosiderosis, but hemochromatosis is rare with chronic disease. But if you're giving transfusion, it can transition to hemosiderosis, then hemochromatosis.
So is that, so like,
Yeah, yeah. Any chronic disease can give you hemosiderosis. All right, in the heart, you get what they call restricted cardiomyopathy. The heart will become so metallic, it can hardly beat. And then one day the person dies. So iron overload. Hemochromatosis, focus on that, Josh. Primary is autosomal recessive. This is genetic. The problem, too much iron being absorbed into duodenum. That's your favorite question. Where is the problem actually occurring? So in GI, you'll learn 90% of iron is absorbed in the duodenum. So easy to remember if you know normal physiology. HLA-A3 on chromosome 6 is the marker. All right, markers are big time clues on exams. So you're gonna see me highlight a whole lot of markers because I rack up a ton of points with markers. Okay, secondary hemochromatosis is from too many transfusions, which is how we started this discussion. Most common cause of death in the first 10 years, transfusion-related infections. And then after 10 years, it's heart failure from your heart became metallic. So this is the two types of hemochromatosis, how to separate them. Any questions at all? Prussian blue is a stain for iron. So sometimes they'll hint at it with just Prussian blue without saying what's going on. And bone marrow biopsy stained intensely with Prussian blue. Ooh, iron overload. Or his heart biopsy stained intensely with Prussian, ooh, hemochromatosis. Anyway, I want you guys to know that stain. Yes, sir. Diabetic with arthritis, think hemochromatosis, yes. So if we have a patient who's like 70 years old, no, osteoarthritis would definitely be much more common. This is usually a middle-aged diabetic, yeah, like in the 30s and 40s, where you don't expect osteoarthritis to be so bad. You better think there's disease, because it is bad, and he has diabetes, and diabetics don't usually get osteoarthritis. What if the 70-year-old had recent onset of osteoarthritis? What about it? Should we think about hemochromatosis? If he's a diabetic, you mean? Yeah. No, I mean, after by 70-year-old, it's probably not gonna be it. Yeah, we don't routinely screen for that. But like I said, if it's in the 30s and 40s, then I don't expect severe osteoarthritis in a 30 to 40-year-old diabetic. That's when we look for it. Yeah. And we just check their ferritin is sky high. All right. Deferoxamine is a drug we use to chelate iron. Give me a drug that chelates copper, Bryce.
I'm sorry.
Give me a drug that chelates copper.
Penicillamine.
Okay, good. How about one that chelates arsenic, Hendrik?
EDTA.
Not EDTA. Joshua. How about Mabel? Mabel?
Mabel, Sosima.
Yeah. No, not Suximer, not Suximer.
Okay.
Not Suximer. You were close though. Anna. Yeah, Damercaprol is one of the we use for lead and arsenic poisoning. All right, folks, be on your toes. You never know when I'm going to ask you a question, but it's always on stuff that I've taught you. So I don't ask you strange things I haven't taught you yet. All right, transfusion-related infections. This is just to show you how we as physicians, we transmit so many infections by transfusing people non-discriminately, which is why we've gotten in trouble over the years. Now you have to fill out a form for the blood bank to give you the blood. If you don't have an indication for it, they will not give it to you. We brought that on ourselves, okay? Because they showed where we as physicians were transmitting so much infections to people with all these no big deal transfusions that are not necessary.
Yes, sir, other than Ebola.
What about it? What are you saying?
Examples of hemorrhagic viruses.
Oh, hemorrhagic viruses, Ebola, there's dengue, chikungunya, all of those, yeah. They all cause thrombocytopenia, wiping out your bone marrow. All right, so we've gone through this curve, shifted to the right. Remember, increasing everything except pH. Shift to the left, decreasing everything except pH. We talked about the second wind, when myoglobin gives you a burst of oxygen release, right? And then we talked about what happens if you exert yourself too much. You start to destroy your own myoglobin. Myositis is when one muscle hurts. Polymyositis is when a bunch of muscles hurt. All right, is myositis when CPK is elevated, or rhabdomyolysis when myoglobin is elevated. All right, so a lot of stuff came off of this curve. So make sure, again, review it, talk it out. Just, you should be able to just kind of look, drill with somebody, just talk it out. Explain the whole thing, all right, so that this way you now have it visually in your brain, okay? Collagen, next protein we need to talk about. What is the definition of quaternary structure, by the way, Akshay? No, I said, what is the definition of quaternary structure for a protein? Leslie Gonzalez wants to help you. Leslie.
When more than one protein are together, cooperativity, allosteric cooperativity.
Very good. When anytime you have two or more different proteins interacting, collagen is 3, remember, triple helix. So it qualifies. 2 or more proteins interacting equals quaternary. All right, more than a quaternary structure, it is a triple helix. What do you have in there? There's 4 main types of collagen, but now they describe a 5th. There's a collagen type 5. Okay. Now, type 1, this is a mnemonic a student gave me years ago, and it works over 90% accuracy. I'll take it. The reason why I'm saying that is because if you look in the book, they organize it a little differently. But it doesn't work 90%, so I'm not using it. Just so you know. This has worked over 90% accurate in answering their questions. Okay? So anyway, scab. So type 1, 2, 3, 4. Scab. That's easy to remember. You understand Abby? You understand Andrews? You understand Melissa? All right, Melissa, the question I'd like to ask. What type of collagen would you find in the aqueous humor of your left eye if you close your eye and shake your head 3 times and then wiggle just a little bit and then click your shoes 3 times? What? Why type 2? In the aqueous humor of your left eye. When you close your eye and you shake your head a few times and you wiggle your butt just a little bit and then you click your heels. It's type 2, girl. You got it right. I just want to make sure don't dare change your answer on me. All right. That's why I stalled for a bit. Don't ever change your answer. What did you think first? Folks, go with it. All right. Now, the reason why I asked that question, because that's their favorite question. Not so much aqueous humor, but students forget that all liquids in the body are connected tissue. All liquids in the body are connected tissue. And they know that students forget that. That's why they always pick another liquid. Aqueous humor was one I saw years ago. But synovial fluid, I think, was the last time I saw it. See, they know that students don't remember this stuff. If you take the aqueous humor, it's a clear liquid. That's why you can see light. Light goes right through, right? If you run through your fingers, like water, yeah, it goes right through. But let's say you put it between your 2 fingers, like this, pinch it hard, wait about 30, 60 seconds, and then separate your 2 fingers, you're gonna see fibers. A minute ago, it looks like liquid. It's actually fibers, but the eyes cannot tell. Okay, so all liquids in your body, connective tissue. Your favorite one, Amy, blood. See, students will accidentally pick type 3. Artery is type 3, not the blood inside. The blood inside is 95% water. It's supposed to say type 2. All right, any questions on that? All right, cool. All right, let's see, I need somebody to help me. So Angie, you help me with this, ready? Let's go. In order to synthesize collagen, Angie, you need glycine. Remember, the smallest amino acid, I told you it's gonna be everywhere we go, right? Here it is again, okay? Every 3rd amino acid in collagen is glycine. Then you need lysine. What's unique about him, Angie? What's unique about lysine? Cynthia will help you. What? That's fine. Yeah, you can tell me anything as long as it's true. Yeah, purely ketogenic. Okay, but lysine, remember, basic amino acid. Extra NH3 plus. What's unique about proline, Ashley? Huh? So imino. Yeah, just so you said it right. So imino, remember, twists and bends, twists, turns, kings and bends, proline. And then you need to hydroxylate proline and lysine. What else do I need? Vitamin C. Vitamin C is used in the hydroxylation process of lysine and proline. And that is done in a rough yarn. Please ask you. Then you need copper to hydroxylate lysine. And then there's a chemical called homocysteine. Homocysteine is derived from red meat. This is why they tell you don't eat so much red meat. Homocysteine will block lysine hydroxylase, which means it creates a collagen problem, especially for type 3. Guess what? You now have vasculitis as a young child. Think about homocystinuria. Come to have heart attack at age 3. How about DVTs at age 4? See that? This is that way you see the connection. And then as an adult, they tell you don't eat so much red meat. It's not good for you. It'll definitely stimulate atherosclerosis and everything else. All right, anyway, what else do I need? Protein synthesis for packaging. Let's go back in time. Protein synthesis, what do I need to know? First of all, you need ribosomes. Ribosomes. In order to assemble ribosomes, you need ribosomal RNA. Ribosomal RNA comes only from the nucleolus of your cells. Remember, we already saw a question about that. You gotta know this. All right, because they were studying collagen, but they found out how proteins are made in the body from this research. That's why it's tested so heavily. So ribosomal RNA comes only from the nucleolus of the cell. But you have two types of ribosomes, free and rough ER. Free and rough ER. So here, rough ER makes proteins that have to be packaged to go to another cell organelle or another cell altogether. Rough ER makes proteins that have to be packaged. Whereas free ribosomes make proteins that float free in the cytoplasm. So the word free connects the idea for me. Give you an idea, the last time I saw that question, they say, where would you make hexokinase? See, now the detailed mind will immediately focus on hexokinase and start worrying about glycolysis and all that stuff. But here's how you do it. You say hexokinase is an enzyme is a protein. You're either made from rough ER or free ribosomes. Then you say, well, hexokinase is part of glycolysis, which goes on in the cytoplasm, which means there you have it, is made in the free ribosomes. See? But by asking it that way, it sounds so specific, like you were supposed to read a chapter. They didn't even talk about it in the chapters. Okay, it's just something you're supposed to figure out for yourself. Okay? All right, one more time. Rough ER is used to make proteins that have to be labeled to go someplace else. And free ribosomes make proteins that flow free in the cytoplasm. Everybody clear? All right, the sequence of events. There's 4 labels they want you to know. Yeah, 4 labels. So I'm going off this picture. This is just for you to look at. And then I'm just going through it step by step for you. When you're making a protein, you start out with a pre and a pro sequence. So it'd be like pre-pro insulin, pre-pro PTH. So I'm just saying it generically, pre-pro protein. And then it'll ask you what the sequences are for. Pre-sequence guides a protein into the rough ER. Remember, the protein's made on, you're not inside, you're on it. Okay, on top of it. So pre-sequence guides a protein into the rough ER. Within the rough ER, Josh, collagen is the only protein that's completely modified in that rough ER. They'll just pick any step and ask you where to happen. Hell, just say rough ER. When you're talking about collagen, everything is done in the rough ER. For every other protein is done at the Golgi. See, easy. Two places to know about. So pre-sequence guides a protein into the rough ER. Collagen is the only protein that's completely modified in that rough ER. Everybody else is going to be modified in the Golgi. Pre-sequence is then cleaved and destroyed in the rough ER. We're done. Any questions on pre? Pro-sequence. Pro-sequence will guide a protein to the Golgi apparatus. Pro-sequence will guide a protein to the Golgi apparatus. That's where every other protein except collagen will be modified. But the Golgi apparatus has a chaperone. Chaperone means some protein is floating around and says, hey, I know where you're going to help you. HSP 90.
heat shock proteins. HSP 90 is a chaperone for the Golgi apparatus. He recognizes the pro sequence. Says, hey, I know where you're trying to go. Let me help you get there. Grabs that pro sequence and drags you right to the Golgi apparatus. Any questions on the pro sequence? Done. The pro sequence then gets cleaved and destroyed within the Golgi apparatus. Cleaved and destroyed within the Golgi apparatus. And that's for every protein, Bailey, except for one. That one is called insulin. That pro sequence for insulin is cleaved off, but repackaged with insulin. And then secreted into your bloodstream. And in the bloodstream, we now call it C-peptide. So C-peptide is the pro of proinsulin. It's the only pro sequence our bodies do not destroy. Any questions on that? Very common test question. All right. So the other two labels, mannose-6-phosphate label is added at the Golgi apparatus, added at the Golgi apparatus, but it leads you to the lysosome. Mannose-6-phosphate label is added at the Golgi apparatus, but it leads the protein to the lysosome. If genetically you cannot label protein in the Golgi, that means your lysosome will be empty. That's what they call eye cell disease. All right, all that's again written later on. Okay, I'm just going through it so you get the 4, and then we'll go through them again. All right, so mannose-6-phosphate label. Then short amino terminal sequence is added at the rough ER to get a protein to the mitochondria. Short amino terminal sequence is added at the rough ER to get a protein to the mitochondria. And let's go through it one more time. Pre-sequence, guys, a protein into the rough ER. Only one protein is completely modified in rough ER, Angie. Who is that? Collagen. Everybody else is fully modified where, Melissa? Golgi apparatus. Pro sequence. Guys, a protein to the Golgi apparatus. Chaperone. HSP 90. Every pro sequence is then cleaved and destroyed in the in the Golgi apparatus, except for one protein, Ida. What protein are we talking about? You gotta say insulin. C-peptide is only a piece of insulin. All right, so insulin has the only pro sequence that does not get destroyed. And then on the periphery, we call it C-peptide. So that's why we use C-peptide, therefore, Sabu, as a measurement of endogenous insulin production. Make sense to you? So if I see high insulin, high C-peptide, what does that tell me, Sabu? Yeah, that the patient's body made it. That's how you know they didn't inject themselves with it. They made it. All right. So C-peptide, high C-peptide, high insulin, you made it. In a newborn, we call that nesidioblastosis. This is seen in babies born to a diabetic mom. Their islet cells have been so stimulated, they started replicating, and now they got tons of islet cells everywhere that they don't even need. Oh yeah, infant of diabetic mother. But the clue is their insulin is high and their C-peptide is high. And that's how you know they're making way too much of this stuff. Okay? And after the newborn period, we call it insulinoma. Now it's just one solid mass versus a bunch of islet cells. So the description tells me the difference. Newborn, islet cells everywhere, that's called nesidioblastosis. Outside of newborn, one big mass, okay, insulinoma. But the presentation is the same. They're both hypoglycemic. They're both lower in these states, so you know the rest of the evidence is not going to help me. I just want the labs. There's a lab that tells me the difference. Okay? Insulinoma. And then if they want a drug, it's called sulfonylureas. Sulfonylureas. All right, like glipizide, glyburide. What they do, they block the voltage-sensitive potassium channels. Remember, drug action is the most important thing you got to know about a drug. That's why I always give you that when I start talking.
Okay, so we'll go through that family in a minute. They block the voltage-sensitive potassium channels is their main action. All right, what about low C-peptide and high insulin? Means the person injected themselves. Can't outmaneuver physiology. You bring something in from the outside, you suppress the signal from the inside. So low C-peptide, but high insulin, factitious. All right, question, Karina?
Yeah, just like the insulin, you said it's out of the newborn.
It's usually outside of the newborn period, which means newborns don't have insulinomas. They have islet cells. No, not outside the body. I mean, outside of newborn period. Yeah. All right, so I see peptide. Here comes the sulfonylureas now. Main action, block the voltage-sensitive potassium channels. When you do that, acid, you're blocking potassium inside the cell, and that promotes insulin release. Sulfonylureas, how do they work? They block the voltage-sensitive potassium channels, trapping potassium inside the cell, which then promotes insulin release. There's a mechanism inside the islet cells that requires potassium to push insulin out. That's what you're promoting. Voltage-sensitive potassium channels, what they block. That traps potassium inside the cell, which then promotes insulin release. So high insulin, high C-peptide, and then hypoglycemia. These guys have the highest incidence of hypoglycemia of all the diabetic drugs. Which is why I don't like them. All right, that's just me. I mean, there's people on them, but you got to watch them carefully, folks. Now, I drive from an hour away every morning, but I used to live right here in town. All right, so then I moved out. I remember leaving home, and I was on my way here, and I usually start with McDonald's, just 5 minutes away from my house on the way here, grab a little breakfast. And the doctor said, okay, we went from metformin, which I really like, and he wanted to add one of these. And I said, okay, fine, trying to be a good patient. Took my first pill. McDonald's only 5 minutes away from me. I stopped at McDonald's in the drive-thru, and you know, there's always somebody who's taking too long to order. They've seen that damn menu, what, 10,000 times? But they always stay there. Let me see now. Hey, come on, you don't memorize this whole damn list, and you have to say you get 20 minutes a day to figure out what you want. Anyway, as he starts talking, just like this morning, I can feel my sugar start dropping. I said, oh my God, this guy got to move. He's got to move fast. Come on. You know, I'm trying to, dude, hurry up. And finally he moved on. And I just went to the front and said, man, give me a sandwich. Give me a sandwich. I don't care what sandwich. Just give me a sandwich. And they look at me like I'm crazy. I said, dude, just give me a sandwich. And so give me a sandwich, just give $2. Here you go, man. I just pull off the side real fast. Less than 10 minutes, I'm hypoglycemic. That's when I realized how fast these things work. Why most people complain about hypoglycemia. That's the #1 side effect. But I didn't know it happens in 10 minutes. So I told the doc, no, you keep these pills for yourself. It ain't gonna work for me. Because I'm driving an hour a day. There's no way. What if I start getting hypoglycemic on the way here in the highway, you know, the next exit 10 miles away? So no, I can't take that chance. So anyway, so we went with the incretins, which we'll talk about later. All right, but that's how they work. High instances of hypoglycemia. You're promoting insulin release, right? Insulin, you remember, is a growth factor, so it causes obesity. That's not good, but it's on the market, folks, so you know. Causes obesity. Insulin is a growth factor, promotes atherosclerosis. See that? That's why I don't prescribe them to any of my patients. I just don't like the outcome. Okay, and that's why they haven't really done that well in the market. Doesn't surprise me. Okay, when they first came out, they thought, oh yeah, this is gonna do well. No, they've not done very well. Because people complain when they suddenly start gaining weight. I mean, remember the person's already obese, and now you're gonna give them a drug that makes them gain weight. That's not good. All right, and then because they have sulfur, we'll talk about the sulfur allergic reactions in a few minutes. A lot of reactions. All right. So the first generation, chlorpropamide, topiramide, tolesolide. Chlorpropamide causes SIADH. It also causes disulfiram reaction. So he has 2 good clues. SIADH and disulfiram reaction. The other 2, no big deal. The 3 down at the bottom, second generation sulfonylureas. Their benefit was they enhanced peripheral glucose uptake a little bit. So we thought that was going to make a difference. And it didn't. Which is why, again, they're not very highly used. Too many side effects. And like I said, experiencing myself, I said, oh no, I would never prescribe these. All right, but if you have to, you have to. Sulfur connection, I call them a sulfur connection, but listen carefully. The reason why I call them a sulfur connection is because we're gonna talk about a lot of drugs with sulfur in it. So this is not just about one group of drugs, there's a ton of drugs coming up in this program. You're gonna need to know these side effects. So for this time, I'm gonna go through them with you one by one and show you keywords that tells you that's the reaction the person's having, okay? But you're gonna see, we're gonna go through a lot of drugs where you need to know every one of these. So from the beginning, the worst thing that can happen is called anaphylaxis. Flushing, wheezing, itching, swelling, shortness of breath. I'm dying, doc. Okay, blood pressure just plummets. That's anaphylaxis. Once again, stop the drug, epinephrine. If not better in 60 seconds, hit him again. If not better, intubate. They're about to close up the airway. That's anaphylaxis. The worst thing that can happen. Now, just so you know, I'm not randomly going through these side effects. I've actually got a group into type 1, 2, 3 hypersensitivities. Again, I told you my brain sees patterns. One day I saw patterns. I said, oh my God, this is easier because I can remember them in groups. So this is all type 1 hypersensitivity reactions. Anaphylaxis is the worst. Urticaria, hives. Red raised skin equals hives and a lot of itching. Red raised patches of skin with itching. Next one, erythema multiforme. Flat red areas. Flat red circles that look like targets. Like the Target store, classic, but easy to make the diagnosis. Okay, erythema multiforme. Flat red, target-like lesions with a lot of itching. So notice urticaria is raised, erythema multiforme is not raised. And it looks like a target lesion.
So these are reaction tracks.
These are reactions that come from sulfur? Yes. Every drug that has sulfur, you got to know every one of these side effects because they can do it. And then we'll talk about other drugs that can also do the same profile. All right, that's erythema multiforme. Stevens-Johnson is when erythema multiforme is getting worse. So now you have 2 or more mucosal surfaces that are inflamed along with erythema multiforme. It means it's spreading. So they'll describe the target-like lesions all over the place. And then they'll tell you the eyes are bright red and the lips are bright red, or for a little girl, the vagina is bright red, or the anus is bright red. That's how you know they're going for Stevens-Johnson now. Man. Stevens-Johnson. And then when it gets even worse than that, your skin will start to peel off. That's called toxic epidermal necrolysis. So they will describe what we call positive Nikolsky sign.
This is also type 1.
This is all type 1, so. Which means if I touch your skin, it slides right off. That's a Nikolsky sign. Seen only in TEN, you're talking about drug allergy. Staph scarlet skin syndrome, if it's an infection, right? And pemphigus vulgaris, if they got bullous lesions. So it's easy to separate all 3, folks. But that's the only 3 things with Nikolsky sign. So toxic epidermal necrolysis is equivalent of a 3rd-degree burn, which means you need to do fluid resuscitation. Man, but if I can't remember, how do we do fluid deficit for a burn patient again? Reed? I heard somebody named Dr. Parkland or something, I can't remember. What do you want me to say? I said, how do you calculate the deficit for a burn patient? It's called a Parkland formula. What's the formula? No, you're figuring out maintenance fluid right now. That's not Parkland formula. That's all right, we'll come back. Montessori, what is it? What is it? Parkland formula, deficit for a burn patient. Okay. All right, that's not quite it. All right, Karina? 4 cc's of normal saline. Say normal saline. times your weight in kilograms times percent burned area not to exceed 50%. Okay, that's all right. You just heard it today, so I didn't expect everybody to know it. 4 cc's of normal saline times your weight in kilograms times percent burned area not to exceed 50%. Anna?
Sir, you might have already covered it, but what if burn percentage is greater than?
I showed you, you still only put 50% in there. If you put 60, 70, 80, you put them in a heart failure in just a few hours. That's what we
A
don't.
patient who has greater than 50%.
You still, yeah, somebody who has greater than 50% burn, you still put 50. Yeah, maximum you can put in there is 50, yeah. But they have real poor prognosis when that happens. Because that means almost the entire body's burnt, yeah. So it makes sense. Pablo, you have a question?
Yes, for the people that have more than 50%, do you keep it at 50% so you don't dilute their electrolytes too much?
Yeah, that's what we just said. It doesn't matter if it's 60, 80, 90, you still put 50 in there. Yeah, because otherwise you would give them so much fluid, you'd kill them the same day. That's why they say do not exceed 50% in that parentheses. You understand?
Yes, thank you.
All right, no problem. All right, Eric Bouchard. Or Beauchard.
Hey, Dr. Francis, can you hear me?
Yeah, I can hear you. Go ahead.
I was going back to the sulfur connection. I just wanted to double check, were these reactions independent of the method of delivery of the drug? So like a lot of these were skin related, so they're not topical related.
That's correct. It doesn't matter the route of delivery. The key is if the drug gets absorbed into your system, any of these reactions can occur. Yeah, even topical sulfur drugs can cause any of these. All right, and the last person, let's see, Shri, you have a question?
Yes, so for the Nikolowski sign, can you repeat
Nikolsky sign? Nikolsky sign says you touch the skin and the skin peels right off. It means there's so much inflammation underneath the epidermis that it can't anchor. Remember, like in pemphigus vulgaris, your desmosomes, you cannot anchor to the base membrane anymore. That's why it slide right off. And hemidesmosomes. Was that?
3 examples. You said there were 3 things that have this sign.
Yeah. TEN, pemphigus vulgaris, and staph scarlet skin syndrome.
Thank you.
No problem. All right, so those are all type 1s. Then I move to type 2s, non-specific rash, which means, just some red dots, that's it. Nothing to write home about. Type 2s, methemoglobinemia. It can oxidize the iron at 3+. What's the treatment for it, Steve? Treatment for methemoglobinemia. No cytocobalamin. Close. Angie. Methylene blue. Give him some blue, watch him turn pink. It's a methemoglobinemia. Hemolytic anemia. Because it causes release of free radicals. The free radicals can pierce right through the red blood cell. And now you've lost the RBC. So it can just oxidize the iron at 3+, or it can pierce all the way through. Then you got bigger problem, hemolytic anemia. Disulfur reaction means it blocks, let me see, alcohol dehydrogenase. No, not alcohol, acetaldehyde dehydrogenase, sorry. Second enzyme is blocked for disulfur reaction. And we'll be talking about that later. Acute renal failure. Remember sulfur, acids, water soluble. See all the stuff we've been talking about. Notice a whole lot of renal problems. So acute renal failure, it can cause a severe allergic reaction within the kidney. We call that interstitial nephritis that then leads to renal failure. Or it can lead to acute tubular necrosis. Or it can cause kidney stone. Drug-induced lupus that I showed you earlier. What's the marker for drug-induced lupus, Gustavo? The marker for drug-induced lupus. Antihistamine antibody. The best marker for regular lupus. Chris with a K.
Yes, Dana.
Go ahead, Chris, finish. What's the best marker for regular lupus? Double-stranded DNA. Mabel, you're on mic again. Be careful. All right, so photosensitivity. That means, Mabel, when you go outside, you may want to wear an SPF of what number? Mabel,
Sir?
what SPF do you want to wear when you go outside in the sun?
I can't remember.
Okay, no problem. SPF, Zena, of 30, which blocks what percentage of sun rays? Zena? 97 sounds good. And then you trying to block UVA or UVB, Zena? B for burn, B for bad. That's how to remember that. A is for aging, that's to dehydrate your skin. That's why you wrinkle. All right, so that's photosensitivity. Sulfur is the most protein-bound drug in pharmaceuticals, meaning it can push anybody else off of albumin. This is why we don't give it to pregnant women, because you have no idea what toxicity you're gonna get. So we don't want to take that chance. Sulfur can displace anybody off of albumin. It is the most protein-bound drug that we know in pharmaceuticals. And then leukocytoclastic vasculitis means that's a type 3 reaction. It's immune complex reaction that causes a vasculitis. So notice type 1s, there were type 2 reactions, and now we're going to type 3s. All right, leukocytoclastic means a vasculitis caused by immune complexes. Kernicterus is when fat-soluble bilirubin does harm to your basal ganglia. Kernicterus. All right, mannose-6-phosphate label, guys, a protein for the Golgi apparatus of the lysosomes. Eye cell disease is when you have empty lysosomes, which means the mannose-6-phosphate label does not work. It's genetic. So by genetics, the person doesn't have the capability to do it, so your lysosome is empty. The group of enzymes that enter the lysosome, collectively we call them acid hydrolases. Why? Because it's very acidic within the lysosome. That's all that means. How do you know someone has eye cell disease? Because the acid hydrolases are now in the plasma. What are they doing in the plasma? They shouldn't have been in the lysosome. It means they never got labeled. Yes, sir.
You're mentioning antibody markers for lupus.
Antibody markers for lupus, yes.
Where does anti-Smith?
No, Smith and cardiolipin are also for regular lupus, but they're not as specific as double-stranded DNA. Yeah, double-stranded DNA is the first one we always get. Yeah. All right. Short amino terminal sequence. I said, guys, a protein from the rough yards to the mitochondria. Your mitochondria is unique in that its DNA, if you remember, is circular. It's the only circular DNA anywhere in your body. And we had that one question where once they mentioned it, I said, stop reading, put your answer, get out. Because you're not going to find circular DNA anywhere else. That's a freebie point. Okay? If they ever mention it, freebie. HSP, so chaperone for mitochondria, HSP 70. Don't get 90 and 70 mixed up now. 90 is for the Golgi. This is 70 for the mitochondria. Mitochondrial genetics is unique. Who can transmit mitochondrial genes? Only your mama. Only your mama. Sweet mama. All right, so transmitted only through the mother. So that means mom has it, all her children got it. And you don't need to even look at the rest of the pedigree. No, nothing else can do that except mitochondria. A muscle biopsy, though, is that the way they like to hint at it. Ragged or wavy red fibers. Better be clicking and moving, folks. Clicking and moving. Of course, they like to ask variable expression. Now, variable expression is a term I taught you only for autosomal dominant diseases. But when you see the same thing within mitochondrial diseases, we call that heteroplasmy. Hetero meaning different. It means it looks different in a different set of genes. Okay? So heteroplasmy, they love to ask what that means. And Shri, you have a question for me?
Oh, I think I had my hand raised from before. I'm sorry.
Oh, okay, no problem. Abdullah.
Yeah, what was the thing that blocked in the sulfur connection? What was the thing?
That blocks what?
In the sulfur connection, you said something is blocked. I forgot what it was.
I'm not sure what you're talking about. Was something blocked? Anybody know what he's talking about? Are you talking about the actions of the drugs?
Yeah.
Oh, we said it blocks voltage sensitive potassium channels.
Okay.
That's the main action. All this stuff was just side effects. All right, so that's should have been determined sequence of mitochondrial diseases. And there's the whole sequence of things occurring again. All right, so now let me go through collagen itself. Yes, Zena. So, yeah, that's exactly what it means. So mitochondrial disease, heteroplasma means you got 3 family members who have the same gene, they should have the same disease. But instead, all 3 have 3 different types of the same disease. That's the same thing as verbal expression and autosomal dominant. Yeah, that's all it means. All right, so now let's go through collagen. So, Raimondo, you follow me on this one. You have pre-pro collagen at the rough yarn. The pre-sequence were guided where? Into what? Yeah, very good. Into the rough yarn. All right, then the pre-sequence is cleaved and destroyed. We're done. Then I now have pro-collagen. Pro-collagen, the pro-sequence got the collagen where? Golgi apparatus, who's the chaperone? Hey, Miguel? All right, Cesar. The chaperone for the Golgi apparatus? It just be 90. It just be 90, recognize the pro sequence and takes them all the way to the rough yarn. Sorry, to the Golgi apparatus. Every pro sequence, so in this one, this pro sequence will be cleaved off, destroyed in the Golgi apparatus. Now you have what we call tropocollagen. Okay, tropocollagen, no modification was done. All right, just cleaned up the pro. And then you secrete tropocollagen out of the cell, which means collagen is not even done yet. Collagen is the only protein that's secreted out of a cell, still in the incomplete form. Like when you're making insulin, let's say, when pro-insulin, you gotta wait till insulin is completely processed, then it gets secreted. Collagen is the only one who's not completed when it gets secreted. Now, you gotta say, well, why is that? Think about this. I wanna form a scar. Do I wanna form a scar within the fiberglass who's making this stuff? No, I wanna form a scar out here in your skin or your muscle or your bone. So it makes sense not to complete collagen until it comes out of that cell, okay? But just so you know why they would ask that on the test. Okay, it's the only one where that happens. All right, then while it's out here in the plasma, so extracellular, then we have what they call a bunch of peptidases. That means enzymes who recognize these ends and cut them off, which means the triple helix comes together as a tight cable. And then you lay it down on that scar. And that's how you form a scar. Any questions on that? Again, it's just a matter of going through the sequence, just the way we just talked it through twice. Okay? All modifications of collagen done in rough yarn. Everybody clear about that? Because that's one of your favorite questions. Who makes the collagen? Fibroblast. If you want a simple scar, fibroblast. But if you want wound contraction, myo. Notice muscle. Myofibroblast. You understand that, Mabel? Mabel.
Yes, sir.
Yeah, do you understand that so far?
You said that fibroblast make collagen, right?
That's correct. Now, answer this for me. When does a fibroblast show up to an inflammatory response?
When does what?
When does fibroblast show up to an inflammatory response?
You show up from 3 days?
No, not 3 days. Let's teach us some macrophages. Rachel. Fibroblast show up.
7 days, sir. 7 days.
I told you, it always shows up when you're not the one on the spot. And I answer first. Oh, wrong answer. Since I said Rachel, oh, 7 days. 7 days. So I know she's nervous. That's normal. I expect it though. So folks, that doesn't bother me. Okay, but just so you know the physiology behind it. If you stay nervous, you're not going to know the answer when I ask you. And so you think you don't know. No, you do know. But you don't know why you're nervous. That curtain goes up like this. And the answer over there, but you can't see right now. The minute I call somebody else's name, the curtain goes right like that. All of a sudden you can see the answer clear as day. Okay, so that's why I want everybody to learn to be calm, to fight that cortisol battle. Anyway, that's collagen made by fibroblasts. Fibroblasts show up at day 7, peak in 1 month, and take 6 months to finish scarring. We're gonna rehearse that 1,000,000 times, because I don't want to get to staph aureus, and you're trying to tell me some new thing you read about. And we get the E. coli, you want to tell me something new. There it is, inflammation to everything. All right, that means over 90% accurate. I'll take it. Rather than I gotta learn the information for every bug in the book. You don't want to do that. Okay, you know, you're not gonna remember it. That's the problem. All right, Victoria, question.
This is a silly question, but myofibroblasts would also show up at 7 days, right?
That's correct.
Okay.
That is correct, Victoria. All right, fibroblasts. See again, I told you we do something, then we go through the notes. It's all the notes, folks. So I don't want you to have to write down everything I say. All right, so fibroblasts show up at day 7, peak in a month, finish 6 months. And when does collagen synthesis go wrong? Desmoplasia is when collagen is wrapped around a tumor. So at least now you know what a desmoid tumor is. It's benign, but they may ask you to describe what's going on. It's just collagen wrapped around the tumor. That's it. We don't do anything to it. Leave it alone. What about a keloid? Real common in pigmented people. As Blacks, Hispanics, and Asians. We get keloids a lot. And the most common keloid is right here in the earlobe from ear piercing. All right. Now, keloid is too much collagen deposition. Whenever you have too much of a normal thing, we have a term for that called hamartoma. So a keloid is a form of a hamartoma, abnormal growth of normal tissue. So you know, flash you what it is. Abnormal growth of normal tissue. All right, how do you manage it? First step, do nothing. Why? If you remove it, it's coming back bigger than it was. So you're gonna start a vicious cycle. So let's say, do nothing. That's the first answer. But then the next one says, the patient insists that you do something about it. Well, fine, cosmetic surgery, you gotta pay for it, because the insurance is not gonna cover it. But if they wanna do it, fine. What do? Inject it with steroids. If you remember, steroids break down proteins. This is a protein. It may take like 8-10 injections, but they're happy because it shrinks down. It never completely goes away. So you gotta make sure you tell them that. I cannot make it totally go away, but I can shrink it down for you. And let's see, when it's usually a female. Men don't care. Man get jealous. Women, oh no, I don't want that blemish on my ear. Okay, no problem. They say never cut it off. Now, this is real common. My mother's got one in her right ear. Now she's almost 96 years old. So when she came to me with that, I said, oh no, Ma, leave it alone. I said, don't bother her. Because I don't want to insert my 96-year-old mom. I want to enjoy her while she's still alive. You start messing with that before you know it, and then she dies during surgery. Now I've lost my mind. I said, no, let's leave it there. Yes.
I had wrist surgery.
You had wrist surgery for keloid?
Yeah, and I know,
Oh.
like I had tried to develop.
You developed the keloid in one of the surgeries?
And then they removed it and never.
They removed the second one? Yeah, it's rare, but yeah. There are sometimes where it doesn't come back. The only time I ever had one taken off was a little young girl, a real pretty girl, but she had one on her ear as big as I would say like a baseball. I said, now she was almost to the age where she's real conscious about her body. I said, Mom, let's go ahead and take this one off. Okay. Now, if it would have been a son, Mom would give it that. Let it stay there. Put a starter cap over it. Nobody will know. I said, Mom, it's as big as a baseball. And he said, boy, he'd be all right. But the little girl, pretty little girl, no. Who do we go to? Who do you go to? Mom was ready to pay whatever it has to be paid. So anyway, I sent it to one of the best cosmetic surgeons I've ever seen. Luckily, he was in our town. You know where they use the sutures, but you can't see it? I mean, the suture is that fine. You see his finger doing it, but I can't see the suture. He took it off, sutured it up, and never came back. I mean, it was the best surgery I've ever seen. You know, of course, very expensive, but Mom was willing to pay for it, so it was up to her. But anyway, again, for most people, always say, no, it's best to leave it there. And that's what I tell almost every patient. All right, but if a young woman wants to take it off, it's okay, fine. We'll inject it with some steroids. But I'm not gonna cut it, because if you cut, here comes a bigger one. And now she's really dissatisfied. Now, the worst one I've ever seen, watch my hands. I saw a young man when I was at church, and he had a big keloid that went behind his ear like this, under his neck, and came up behind the other ear like that. Anybody know how he got it, Gustavo? What did he do? Yeah, he tried to hang himself. And now he has a permanent memory of that suicide. Yeah. Luckily, he lived. I mean, this was in church, so I could tell somebody must have rescued him and talked to him, and now he's in the church, he was in the choir. And he had a big one, but you can see this man was just so happy to be alive, praising God. Man, I just prayed for him. I said, man, this is nice. God brought you back for a reason. You know, now he's in church praising God, and even though he's got a big keloid wrapped around his neck, he can care less who sees it. But when I saw it, I said, oh man, that guy tried to hang himself. You know, but he was a very happy man at the point in time when I saw him. All right, when college assist goes wrong, college profile. Let's see how we do this. I need somebody to help me here. Let's go over to Sandra. You gonna help her? Yeah. You ready? All right, Sandra. Now everybody listen, don't try to write. This is another exercise. How to create an entire syndrome without reading a book. Okay, just listen. All right, Sandra, I heard there's 4 types of collagen. Is that true? I heard there are 4 types of collagen. Is this true? All right, where do I find type 1? Skin. So what do? I go to skin and mess it up. That means easy bruising. Everybody with me? Easy bleeding into the skin. Dot hemorrhage, petechia. Couple hemorrhage, purpura. Bruise, ecchymosis. When it follows the skin lines along your back, striae. That means I can tell you they all have it, but I don't have to go look it up. Everybody follow me? Where do I find type 2? Connective tissue. So now I'm going to go throughout his entire body and mess up all this connective tissue. Everybody understand what I'm doing, right? So connective tissue, I go to fascia and explain to you why they get fasciitis. Fasciitis then leads to compartment syndrome. See? I go to cartilage and explain to you why they get arthritis all the time and deformed bones, bowed legs. Even though they don't have vitamin D deficiency, they get bowed legs all the time. All right? Osteomyelitis, septic arthritis, real common. See? Connective tissue. I can tell you why they get tendonitis and tendon ruptures all the time. I can tell you why they get tracheitis and tracheomalacia in the newborns. See that? Everybody understand what I'm doing? I'm just going throughout the body, connective tissue, messing it up, and putting a name on it. And therefore, you see exactly how they wrote the book. Okay? Now, where do I find type 3? Arteries. So now I'm going to go throughout your body and mess up your arteries. If I mess up your arteries become inflamed, Sandra. What disease process they're called when your arteries are inflamed? Vasculitis. If you got a vasculitis, Sandra, what funny looking red cells and platelets you see the peripheral smear? I just realized I'm not sure I said it. Well, I think I said this one. Anyway, it's called schistocytes. I did say it on day 1. Schistocytes are going to be everywhere. That means if you have a vasculitis, your blood vessels are inflamed. Isn't that true? And when you have a vasculitis, you're not predisposed to clots. Everybody understand? That means I can tell you why they have strokes, MIs, DVTs, PEs, priapism. I mean, any clotting disease you want to hear, I just put a word on it. They have all of them, okay? But they also can bleed. That's why they can bleed in their head, intracerebral hemorrhage, pulmonary hemorrhage, bleeding into the kidney and everything. Now, let's say if I were to ask you what organ you're worried about when you have a collagen disease. Sandra, hit me. What organ you worried about? Thank you. Nothing has changed. Brain, heart, kidney. What organ do we sacrifice first? Huh? Kidney. So let's say we go to kidney, since it's going to be taken out first. Watch my hands. And let's say you ask me, well, what do you expect to see in the kidney, Dr. Francis? All right, here's what I'm going to see. I'm going to put a partial clot in there and call it renal artery stenosis. I'm going to put a full clot in there and call it renal failure. I'm going to take the clot, put it over the glomerulus, and call it glomerulonephritis. I'm going to take it and put it over the papilla and call it papillary necrosis. I'm going to take the same clot, put it different places in the nephron, and now call it focal segmental glomerulonephritis. And I'm going to clot off all your glomeruli, and you now have crescents all over the place, and then we call it rapidly progressive glomerulonephritis. Look in the books if I make something up. Folks, in the old days, they thought those were 7 different diseases. They're not. They're the same disease moving through the patient's kidney, but they didn't know that back then. So that's why it was a different chapter for every disease, because I thought it was a different disease. It's one disease moving its way through the kidney. That's it. See? All of a sudden, now it's so much easier. And that means if I ask what's the most common cause of death, Sandra, what's the most common cause of death for all the collagen diseases? I can hear you. Right there. Here it is, folks. Every collagen disease covered. Didn't have to open up a page. Didn't have to read anything. I haven't read that chapter in many years either. For what? I already know the whole profile. Okay? So that means in order to know what disease they're talking about, because you got the same signs, symptoms, infections, complications, causes that, all of them the same. Okay? What if I ask you what cancer can they develop as part of their disease, Sandra? Skin followed by? GI followed by? Bone marrow. What part of the lymph will shut down first, Sandra? What part of the lymph will shut down first? Why are you whispering, girl? Of course it's PCT. See now, the E of little faith. Now you all of a sudden, she doesn't believe that she's remembering the information. It's the same information. As I'm trying to show you. It's the same information. Before today, you didn't even know every collagen disease was just another lineage state. It saves you a ton of reading once you start to see these connections. You have to look them up anymore. That's why all I gotta do is explain to you the glues. That's it. But if they ask you anything else, come on. You can figure it out on your own. All right, let's do it. So we can get these done before the end of the day. So collagen, skin, scab. That's your form. Anytime you connect to the lower knee state, remember, use the same profile. I didn't change anything. All I did was but in arteries, messed up my blood vessels, that's blood flow, that's oxygen, that's energy. Boom, there it is. They're all lower knee states now. Okay? That means I can fill in chapters of information if I want. Hello? Is this? Oh, I thought it went out. All right, so stop the guessing. So here's the collagen diseases and the clues you need to know. Ehlers-Danlos. What do you need to know about this one? Stretchy skin. As is hallmark, stretchy skin. No other disease has skin as stretchy as it. Oh man, anybody hear about the one person who's trying to get across TSA by packing himself in a suitcase? This was on the news recently. I said, oh my God, it's gotta be some Ehlers-Danlos. Only Ehlers-Danlos can ramp himself up and bring his legs up here by his ears. He fit right into a suitcase. But he forgot once they put you through the damn x-ray, your bones show up. I mean, he totally forgot. I would imagine somebody put him on the thing and then too late. X-ray, there you are. There's some guy in your suitcase. How do you lie about that? Oh, I don't know how he got in there. I don't know, you know how strangers get in your suitcase when you're not looking. Oh my God, they got busted. But anyway, Ehlers-Danlos, classic. All right, so stretchy skin is the best clue. Or they'll say velvety skin. That's how many layers. So when you let them go, layers down like velvet. But it's really stretchy skin way out here. All right. There used to be contortionists in what are they, circuses. Yeah. All right, that's Ehlers-Danlos. Marfan's is the most common collagen disease. Marfan's is the most common. This thing is so common. I can spot it in the mall when I'm walking around. All I gotta do is watch a basketball NCAA. Basketball teams, they all got at least one guy who's got Marfan. That's usually their center. Just look real hard, you see it. You make like Michael Phelps, a swimmer. Marfan's. There's a lot of them. It's that common. So Marfan's, what do I need to know? Fibrillin is the protein that's defective. So it's part of collagen. Fibrillin is a protein that's defective. Marfan's, long wingspan. Wingspan is longer than their height even. Long wingspan, longer than their height. Next, spider-like fingers, arachnodactyly. Spider-like fingers, say four. You ever see spider-like fingers before? Oh man, it's a weird dude. You know why? You don't want to see him picking his nose. That ain't a pretty sight. It ain't a pretty sight, man. This is the only guy that can pick his nose and a finger come out of the ear. You're like, hey, how'd you do that? I got skills, man. I got skills. Certainly you do. You know, some ET phone home. Man, some of the longest fingers I've ever seen. And don't let your doctor be a Marfan's and it's time for a rectal exam. He's gonna feel like colonoscopy. Hey, doc, I thought this was just a rectal exam today. Oh my goodness. And it's Marfan's. Other problems. Pectus excavatum, their chest will be caved in or popped out. Pectus carinatum. So pectus excavatum or carinatum, either one equals Marfan's. So that's why it can affect their lung function and their cardiac function. All right. Lens and retinal detachment happen all the time. Now this one's unique. When their retina detaches, they come in and watch my hand. If this is their, let me make sure we know. If this is their retina, the bottom tends to tear first. So in ophthalmology, listen to the language, you say upward detachment of the retina. So ophthalmology, they name it based on which direction it's going. Upward detachment, okay? But it means the bottom of your retina has torn. So on a test, it'll ask you what part of the retina is torn. Even though it's described as upward detachment, it's the bottom that's gone. So that means the person can only see through the top of his retina. So they walk into your office and they're staring at your ceiling. That's because they can't look down. That part of the retina is ripped. All right, big clue. Another clue, they have trouble when they're walking downstairs. They fall a lot. Why? Because you never look down when you put your foot on the next step. They can't look down. And so fall down the stairs all the time. Okay? All right, but that is an ophthalmological emergency. You got an ophthalmologist right away. Because laser surgery can push that back down and preserve it for a little longer. All right, so that's why you want to recognize it. All right, so retinal detachment and lens detachment. All right, they have high incidence, a bunch about prolapse and aortic recurrence. All of them do, but because he's the most common, I know that's the one they're going to ask you about is there. Marfan's. All right, homocystinuria is a Marfanoid child. Usually 5 to 10 years of age. So they'll describe the Marfanoid features. That age is what gets my attention. Most Marfanoid children, true Marfans, you start to see the Marfanoid features around adolescence. Now some will be earlier, but majority around adolescence. So once they tell me he's got the long wingspan and all this other stuff, but he's only 4 years old, I said, no, that's gotta be homocystinuria then. Okay, again, play the odds. Over 95% accurate for that one. So homocystinuria, Marfanoid child. Second way to separate it from Marfans, when his retina or lens detaches, it goes from the top and rolls downward. So they'll describe it as downward detachment of the retina, but it's the top that's gone. So now they come into your office looking down at the ground. So I always think looking down at the child. Okay, so the 3 different ways to separate homocystinuria from Marfan. Because otherwise, a lot of the features are the same. So if you get locked in on that, you're going to miss the question. Okay? The third way to separate it, homocysteine. Homocysteine methyltransferase is an enzyme that uses what vitamin as a cofactor? Arginine. Homocysteine methyltransferase uses what vitamin as a cofactor? B12. And so you'll turn homocysteine into methionine. So you can actually measure high methionine in the urine. Excuse me?
And folate.
And was it?
And folate, right?
And folate, no, folate can help you. Yeah, are you saying folate would be increased?
Oh, I meant, enzyme.
Oh, you mean that, yes, folate can connect right into the same reaction, which is why you can cover up the anemia of B12 with folate. That's how they connect. All right, so homocystinuria, the fourth way to separate it from Marfan's is that it'll be a child with multiple clots. Like I said, it'll be a 4-year-old and he's had 2 DVTs already. Or a 3-year-old with an MI. That's just unusual to ever get it outside of homocystinuria. So those are the 4 clues I use to separate homocystinuria from Marfan's. Laurent. Is because, so he's saying in terms of pathogenesis, is because homocysteine damages lysine hydroxylation, which then messes up type 3 collagen. That means you got vasculitis at an early age. Yeah. Next one, scurvy. Oh, wait a minute. Does anybody know who the third Marfanoid patient is in medicine? There's 2 Marfanoid patients. Anybody know who else is Marfanoid? Gloria, you know this one? Oh. Wait a minute. All right, Anna?
Abraham Lincoln, right?
Yeah, but what disease? What disease? Abraham Lincoln has Marfanoid, but that's not what I'm asking. There's another disease that has Marfanoid features. All right, Michael.
I think one of the genetic disorders.
Which ones?
Turner, maybe?
Not Turner's. All right, go ahead and tell them, Ida. Yes, MEN3 or MEN2B. Everyone's saying. All right. Yeah, I told you, trust what you think, girl. All right, Pablo, you have a question?
No, I was trying to answer.
Okay. Oh, good, my man. Excellent. Okay, I'll give you a point just for that. All right. So scurvy. Remember the clue? What was the clue for that one, Melissa? Scurvy. Yeah, remember bleeding from hair follicles and gums. We already did that one. Osteogenesis perfecta has to do with type 1 collagen, primarily, and occasionally type 3. All right. This is the first time they ever coined this term, pleiotropy. Now they use it for a lot of different reasons. But what does it mean? Pleiotropy means a minor mutation, but with devastating consequences. With OI, let's say before they found out it was just primarily type 1 and type 3. So that means skin and blood vessels. But OI affects almost every organ in the body, which didn't make any sense. So that's why they coined this term. Simple mutation, but with devastating consequences. What do you see in OI? Remember, blue sclera. What you're really looking at is the venous plexus in the back of your retina because your cornea is so thin. Okay? Blue sclera. Multiple fractures at birth. Now, because we don't know what the baby has until all of a sudden he's coming through the vaginal canal and all you're hearing bones cracking. That's why they call it brittle bone disease. The kid has got like 17 fractures when he comes through. Okay. Now, the most complete case I've seen one, because I had one when I was in NICU, and this kid had so many fractures we couldn't even count them. I remember going into the room where we put him, and the nurse was hovering over his belly, umbilical vein and artery, and injecting a little morphine. I said, what do we do with this kid? And she said, oh, we're just waiting for the mom to come in and say goodbye so we can let him die. And I said, wow, that's severe, huh? It was that severe, folks. This kid, you can't feed him. As soon as you put a bottle up his mouth, you crack his jaw. How do you start an IV? He can't hold his hand still. Okay, so I want to see how fragile he was. So I remember I put I think it was either this finger or my thumb. I just put it under his wrist like this, and I lifted up, and all I heard, holy cow, just by lifting up with one finger, crack some more bones. I said, okay, now I understand why we're letting mom say goodbye. Because how does mom hold the kid? How does mom feed the kid? How do we start an IV to feed the kid and keep him alive? We can't. Nothing you can do. We just have to let the kid expire. Yeah? It was a sad case, obviously, but mom had to accept her baby is not going to live. All right. So that's what OI is all about. That's the worst case scenario. However, the milder forms are the ones we're worried about. Why? Because they go unrecognized. Children run around the house all the time and they run into furniture bump, run into furniture bump, run into furniture bump, run into furniture bump. They've been cracking their bones all day long and all week long. And then one day they get an earring and mom takes the emergency room to be seen. And they see like 6 fractures in this kid. They say, Mom, what's going on with these fractures? What fractures? I don't know. And that's exactly how an abuser sounds. They always say, I don't know. And moms and dads got put in jail for it. Seriously, a lot of parents got jailed because we thought they had abused the child. Because remember, fractures at different stages of healing? Because yeah, he cracked his wrist a month ago, broke another one, 2 weeks ago. The parents didn't even know, and we didn't know. But the kid shows up with, multiple fractures at different stages of healing. That's child abuse. And these parents end up in jail. Till geneticists wrote a book. They got them all out of jail. Hopefully, all, I don't know, if anybody got stuck, but a lot of them got out of jail. But he showed you can clearly differentiate OI fractures from regular fractures. He said, number one, if you got regular bones, if I crack your bone, I should see both ends like this. A normal bone cracks so I can see both ends with no problem. If you got OI, when you crack their bone, you see like 3, 4 little pieces that broke off like that. It shatters. Normal bone does not shatter. And then when they went back and looked at all the old x-rays, you can see the little cracks of bones all around. It's, oh my God, these parents are in jail for nothing. You can imagine, it ruined their life, but sad, because everybody thought they were a child abuser. Think about it, the neighbors thought you killed your child and broke his bone 3 times. And you know, everything gets around the neighborhood, they think you're some child abuser. You know, and instead, no, it was just osteogenesis imperfecta. So that's why they want you to be able to understand it, folks. Another one, besides little pieces of bone around the shatter site, you see a line cracking in the bone all the way down the long, you know, diaphysis, long part of the bone. Normal bone doesn't shatter like that. Okay, but you'll see that in OI. Any questions on that? All right, next one. Mickey's kinky hair syndrome. What was the clue for that, Amy?
I have questions, sir.
Oh, yes, Mabel, go ahead.
So please, I'm so sorry to draw you back. I'm having difficulty in the difference between the Marfian and the homocysteine urea, please. The 4 differences.
I'll give you one difference.
Okay, there is high methionine in homocysteine urea, and there's also there is high methionine in homocysteine urea.
So high methionine in the urine is one way to differentiate it. Another one.
And there is downward detachment of retina.
Downward detachment of retina, so they're coming looking down at the floor. Okay. Number 3 was multiple clots in a child. DVT, strokes, MIs, whatever they want to call it. In a small child, always think homocystinuria. You understand?
Yes, sir.
Yeah. And then Marfanoid features between the age of 5 and 10. That's the 4 ways I separated. Okay. All right, Mickey's kinky hair syndrome, if you remember, she has orange colored hair, which is copper deficient. She has copper-like hair, it cuts like copper, which is copper deficient. In actuality, her hair is pulling copper out of her body. Weird disease. Her hair is full of copper like you would believe. It looks just like copper wire when they're building a house or something, but she's copper deficient. Pleiotropy, a minor mutation with devastating consequences, OI and homocystinuria. They use that term now. And then I got a group here of secondary collagen diseases. So first one I'm going to talk about ankylosing spondylitis, but to be complete, I'm going to talk about all 3 HLA-B27 diseases. First of all, what do they have in common? They attack the sacroiliac joints. All 3 of them have that in common. They attack the sacroiliac joint. And they actually put bone into the joint. That's why the joint is obliterated. They actually deposit bone in the joint. And so that way you lose all flexibility of your lumbar area. Now, this is what they all have in common. So I'm going to go through all 3. That's why they get stiffness. Yeah, everybody moves behind is because you got so much bone in every joint there, they can't even move. Okay. All right, first one, ankylosing spondylitis. Is chronic back pain in the middle-aged male. Number 1. This is when they say I've had this pain for about 2 years. Not 2 days or 3 days. It's got months and months. Always think AS. It starts in the sacroiliac joints, which is why we do back x-rays. And you can see new bone formation in those tiny joints. So it's easy diagnosis to make. From there, it goes from sacroiliac joints to lumbar joints. So you see white bones here and a white bone all along here. Lumbosacral joints, all obliterated. If you ask them to bend over, they can barely do it. It's called a Pazis-Schoper test. The normal person, you should feel the vertebrae separate by at least 1 inch when you're bending over. That's easy for anybody. But when you got AS, you say bend over. You can see it. They can barely do it. That's a Pazis-Schoper test. From there, you get bamboo spine. The whole lomosacral area fuses together as one big bone. Now they have zero flexibility. Okay? And then from there, the information jumps into the aorta and it can die of dissection. Now, what the lumbar spine and the aorta have in common, nobody knows. Because why does it jump only to the aortic arch? Why not any other vessel? That means there's something up there that, that they have in common, but we don't know what it is. So HLA-B27 diseases, AS, any questions on that? Finally, treatment. When they have just bony aches, oh, my back hurts, NSAIDs. Once you see joint obliteration, that means you see the whites. That means the bone is being deposited. You do TNF drugs. And we'll talk about those later. From what I read, the TNF drugs are very successful. I was like, wow, I was surprised, but it seems to be working. And I saw a question on it on UWorld, I think last year. So, oh, good. That means it's caught up on the board now. All right, that's next one. Psoriasis. The second HLA-B27 disease, psoriasis. Psoriasis, by definition, Lillian, is autoimmune attack against skin cells. Autoimmune attack against skin cells, Justin. But what's different is the skin cells die and form a plaque rather than just falling off. Like normal skin, when it dies, it sloughs off. These skin cells don't slough off. They stay there and pound on top of each other, now you got a thick plaque. So big clues, silver oval plaques on extensor skin. Again, why just extensor skin? Nobody knows yet. Silver oval plaques on extensor skin. You can see lakes of blood in the middle of those plaques, which is why we say, please don't peel them off. They'll bleed everywhere. That's called Auschwitz sign. There's little capillaries right underneath. If you peel that plaque, it's gonna bleed like crazy. Auschwitz sign. Every time they hit their skin up against something, you and I may kill 2 or 3 cells, they'll kill thousands. They form a plaque every time they hit the skin up against something. Again, highlighting that these cells die so fast and they form plaques in the death process rather than sloughing off like normal skin does. All right, so plaque formation, that's called Kepner phenomena. Easy plaque formation from simple trauma, Kepner phenomena. What else do we see? Pitting of the nails. You can actually see little holes in the nail bed. No, the swan stuff is rheumatoid. This is just little holes in the nail bed, pits. All right. Sausage digits from bony erosions. Question, sir. You mean, are they at a low energy? Oh, heck yeah. And he wasn't talking to me. I don't sound like he was talking about me. No, the person with psoriasis is always a low energy because they're losing a lot of cells every day. That's correct. And what vitamin do you need to put them on? Since cells have to replicate to replace the old ones. Huh? Now vitamin C. Gloria, help them out. Holy. Yeah. See, you're doing good. At least you're stretching outside the boundaries. I like that. See, now I'm going to push you to connect. Ooh, so what vitamin do we put them on? See, because you should already know the connection. Anytime you're around the cells, you need folate. So all of them are folate. Okay? All right, but anyway. Sausage digits was the last clue I gave you. High incidence of gout and uric acid kidney stones. Cellular turnover, right? Purines. DIP involvement, remember, psoriasis and osteoarthritis, the only 2 attack your DIPs. Very strong clue. Psoriasis and osteoarthritis, the only 2 attack your DIP joints. Now, if you have all the skin problems, but no arthritis, that means you only have half the disease. So half of 27 is 13. That's called the HLA-B13 form. That just means early form. And then once you get the arthritis, now you have the 27 form. Just a good way to remember that. If somebody suddenly breaks out with bad psoriasis, and yet they don't have a history of psoriasis, without HIV. There's been a bunch of cases that showed up in the literature And sure enough, I'm starting to see it on all the question banks now. They want you to know that. Anybody, remember, the key is somebody has an outbreak of psoriasis, but has no history of psoriasis. If they have a history, okay, fine, they have an outbreak. But this is somebody who just suddenly has an outbreak of psoriasis, but they've never had a history, you must rule out HIV. Okay. Last thing, avoid beta blockers when you're treating hypertension. Remember, it's a vasculitis, so they're going to get hypertension eventually. But they say do not use beta blockers. Now, how do I make sense of it so I remember it? Beta blockers will decrease cardiac output to your skin, which means you're going to form a lot of plaques. Yeah, so beta blockers exacerbate their disease. Okay. All right, that's psoriasis. Last one, writers. Now they want to call it reactive arthritis. They're getting rid of that name, writers. So reactive arthritis. Was first seen with STIs, chlamydia. You guys remember, can't be, can't see, can't climb a tree, right? Arthritis, urethritis, conjunctivitis. So they thought it was an STI problem. First described with chlamydia. And then later on, they saw we got rid of it. They say, yep, sure enough, STI problem. But then before you know it, Shigella showed up with it. They said, okay, wait a minute. Yes, Shigella doesn't cause STIs. So after Shigella, Yersinia intercolitica did it. Salmonella did it. Campylobacter did it. Inflammatory bowel disease did it. Celiac, flu, Whipple's, all of them do it. So that's when they realized why they want to just call it reactive, because you're reacting to an infection. That's all it is. It's immune complex deposition within the joints. There's no actual joint destruction at all. So how do you manage this one? Treat the STIs that can be treated. And that's only chlamydia and gonorrhea. The other ones we don't treat. Okay. But then, let me see. Yeah. And then NSAIDs for their arthritis. Because it'll go away. Remember, it's just a reaction. So reactive arthritis, and then it goes away. Next one. Fragile X, we talked about. Remember, pill-shaped head with large ears before puberty, and then he gets large testicles after puberty. The most common cause of chromosomal induced intellectual deficiency, Fragile X syndrome. Also has trinucleotide repeats. Next one, syphilis. Syphilis. First of all, you get the college of disease only when it's tertiary syphilis. So syphilis, college of disease, occurs only in tertiary syphilis. You only get aortitis. So again, there's something unique in that aortic arch that gets attacked, and we don't know what it is yet. Because you don't get any other vasculitis with syphilis. It doesn't attack any other vessels anywhere in your body. Aortic arch only. Okay? And then the aortic arch is described as a tree bark appearance. Tree bark appearance, they'll describe it. Wrinkled intima, wrinkling of the skin, or the medical term, obliterative arteritis. Obliterative and arteritis. So anytime you see any one of those three terms, tree bark appearance, wrinkled intima, obliterative and arteritis in the aortic arch, that is syphilis.
Endarteritis obliterans.
Endarteritis obliterans, exactly the same thing. That's correct.
I also had another question. So HLA-B27, can any of those diseases have uveitis?
Yes, all of them can. Yes. Question is whether all the HLA-B27 diseases can have uveitis. All of them can. Again, I want to make sure everybody's understanding. I'm only giving you what's unique for each one because that's what makes a diagnosis. But if you want to ask me about something else, I'll tell you, yeah, all of them have it or don't have it. Yeah, that's why I don't talk about it because it's not going to tell you which disease they have. All right, Lauren? Yeah. It is a collagen manifestation. He's talking about neonatal syphilis. Yeah, it is collagen, but that we'll talk about that when we do torch infections and all that. Yeah. All right, so syphilis. And last one on this list, that's probably enough for today. Takayasu's disease. Takayasu's. First clue, Asian female. Now, what Asian females do to get this, nobody's figured it out yet, because only Asian females get it. So there's something cultural that they're doing to get this. Asian female with a weak pulse. You know, the book calls it pulseless aortitis. Well, I always figured she can't be in my office talking to me and she's pulseless. No, she has a pulse, but it's just so weak. Okay? Why? Second clue. She has a granuloma developing in her aorta. Granulomatous aortitis is what you're going to see because they ask you the pathophysiology. But then it starts with aortic arch and actually spreads to all the peripheral arteries. Notice that's different from syphilis. Syphilis only stays in the aortic arch, never moves. So Takayasu's does move. Okay. Now, when you have a granuloma in your aorta, then the pressure will have a hard time getting past it. Everybody follow? So now it looks like coarctation. You'll have decreased pulse in the lower extremities and Takayasu's eventually. Okay. And then when they have that, that means there's higher pressure up here. Well, that pressure's got to release somewhere. It goes up to their brain. So a high incidence of intracerebral hemorrhage and aneurysms. So Takayasu's, over time, you start to see those complications. All right. So again, remember I told you anything I talk about is in the notes already for you. So this is HIV 27 diseases, everything I've said about them. And then this is where we'll finish up tomorrow morning. Cardiovascular diseases, then we go into enzymes to finish up biochemistry, and then I'll do immunology in the afternoon. Okay? All right. See you guys tomorrow. You've been empowered yet again. Yeah, I got some hands here. Hang on. Eric. Oh, Shark, you have a question?
Yeah, it was just more for my curiosity. I just appreciated the osteogenesis imperfecta story. What's the cause of death in the patient that survives birth at that point? Is it just malnutrition?
Yeah, exactly. Malnutrition, because you can't even feed them. But they end up, since we hold everything, they end up dying of heart failure. So on the 10th, they ask you, what are going to die from, say, heart failure? Because even malnutrition will lead to heart failure too. Yes. If you got a granuloma, the question is about this granuloma that you see at Takayasu's. The pressure is going to have a hard time getting distal. So pressure in lower extremities will be less than the ones upper, just like coarctation. But that's why they also have a high incidence of intracerebral hemorrhage, because that pressure's got to go somewhere. It goes right up to their brain. Intracerebral hemorrhage and aneurysms, very high. Just like in coarctation, they have a high incidence, same thing. All right, next person, John Cisco, you have a question?
Yes, I was wanting to just kind of provide some information from the Advanced Trauma Life Support and American Burn Association. So I've seen it show up on my surgery coma. That's kind of why I wanted to say something. They've recommended, I guess, due to complications from over resuscitation, moving it down to 2 cc's instead of 4.
Oh, you mean the Parkland formula?
Yes, the Parkland formula.
Oh, okay. So they're contemplating decreasing Parkland formula to 2 cc's. I haven't seen it yet on test questions, but that's good information. So that's probably new. So it may start showing up by the end of this year. So that's good information. Very good. And yeah, so over resuscitation, if we give too much fluid, you kill them with heart failure. All right, Mabel, you have a question?
So you said in psoriasis that psoriasis and one other disease like that affect the joints.
The DIPs, distal interphalangeal joints, psoriasis and osteoarthritis are the only 2.
Okay.
Yep. All right, folks, enjoy your evening. Keep on learning. That's the key. Keep on learning. See you in the morning. Question, Adam?